It's not coming. किसके screen? Good morning. Good morning, respected faculty members, dear PG students, and my friends. I welcome you all to this occasion of MP ENT Con 2022. Now, today, Abhi, we are going to start with the PG paper presentation. So, I would like all the candidates who are about to present to be ready, and I will be projecting the slides shortly. I would like to welcome respective chairpersons who are going to chair the sessions of the PG paper presentation. The first session would be Dr. Mahadevaya session. It will be joined by our respected chairpersons, Dr. Yamini Gupta ma'am. She's the HOD of MGM Indore, and Dr. Shalini Jadia ma'am, who is the HOD of People's Medical College, Bhopal.
सदा सर का भी फोन आया था कि तुम मेरा फर्स्ट था
Diksha, you're muted. Can you unmute and speak?
Good morning to one and all. I would like to announce that we are about to start the PG paper presentation session. This session would be headed by the chairpersons, Dr. Yamini Gupta ma'am, who is the HOD of MGM Indore, and Dr. Shalini Jadia ma'am, who is the HOD of People's Medical College, Bhopal. Dr. Shalini Jadia ma'am has an experience in teaching of 16 years, and her field of interest is otology. I welcome both of the chairpersons. Good morning, ma'am. Now I would like to,
Good morning.
I would request the candidates to be ready. Respected chairperson, I would please request you to read the CVs of each other. I would request Dr. Shalini Jadia ma'am. I would like to request Dr. Yamini to read the CV of Dr. Shalini Jadia ma'am.
Yeah, Dr. Shalini is professor and HOD of People's Medical College, and she has special interest in otology, and she has a teaching experience of around 16 years.
Ma'am, you are not audible.
Raise the voice or be near to the mic.
Ma'am, kindly be near to the mic.
Okay, am I audible now?
Ma'am, your voice is audible, but it is very slow.
Is it okay?
No, ma'am. Okay, ma'am, your voice is not audible. Dr. Shalini Jadia, ma'am, she is the HOD of People's Medical College, Bhopal. She has a teaching experience of 16 years and her field of interest is otology. I welcome both the chairpersons. Now we are about to start the session. Dr. Ayushi Gupta.
जी मैम गुड मॉर्निंग मैम am I audible मैम
Yes, you are audible. Dr. Ayushi Gupta.
जी मैम
Yes, okay.
यामिनी का प्रोजेक्ट हुआ
Ma'am, PG पे गए.
यामिनी का प्रोजेक्ट किया कि नहीं सीवी
यामिनी मैम पे गए.
सीवी प्रोजेक्ट करा कि नहीं इस पेपर के बाद वो बच्चे लॉगिन हो गए
Yes, ma'am.
हाँ तो पहले पेपर करा लो फिर सेकंड सीवी
Dr. Ayushi. Okay, Dr. Rushil. Have you logged in, Dr. Rushil?
Yes, ma'am.
Okay, am I audible to you?
Yes.
Okay, I'm displaying your PPT. Kindly be ready to present
and speak loud
and speak loudly, please.
Okay.
Dr. Rushil, your PPT has been displayed. Kindly read.
I cannot see anything in.
Dr. Rushil, please start your presentation.
Ma'am, nothing is visible on the screen.
Even I cannot see anything on the screen.
Hello.
You can put it on show mode.
बात करो श्रीहर्षा से हाँ तुमने लैपटॉप अपना लगा बैठो डेटा है कि नहीं सब नहीं तो यामिनी का को ये
Now it is visible. Ma'am, now it is visible.
Slideshow करूं? नहीं अभी भी क्लियर कहाँ है अब आया ना उनके कलर्स खराब हो रहे हैं हाँ कल तो फिर भी दिख रहा था आपको क्लियर ही है
हाँ आ रही है ठीक आ रही है ये तुमने बना के दी बेटा तुमने बच्चे से इसको दिए कि नहीं समझा इतनी फॉर्मेट में दिया देखो फॉर्मेट है पीपीटी फॉर्मेट में लिखना है क्यों नहीं जो पति मैंने क्यों दिए थे पुराने हैं नहीं आपने के हमारे पास है नहीं ना वीडियो करो पर टाइम लैग नहीं होना चाहिए वॉल्यूम बढ़ाओ
Ma'am, can I start?
Hello.
Can I start?
You can start.
मेरा तो ठीक है हाँ, वो बोला ही नहीं ना कुछ
Ma'am, can I start?
Yes, you can start.
Okay. Good morning, respected faculty and my dear colleagues. Today I'm going to present a paper on incidence of sensory neural hearing loss in patients with chronic separative otitis media. Next slide. Next slide, please.
What is the glitch? Somebody has muted me and wanted कि जो प्रेजेंट है वही अपनी स्लाइड प्रेजेंट करे समझ के वो कल से यही समझा रहे थे तुम लोग को
Well, coming to the introduction, CSM is defined as chronic inflammation of the middle ear and the mastoid mucosa with recurrent discharge through a persistent perforation in the tympanic membrane. Hearing loss is one of the common feature of CSOM and it is the most often the presenting feature in our patients. Next slide, please.
ये काम पे ये कर
Well, we know that hearing is one of the vital sensations to the human body and deafness disrupts the tranquility of life. CSOM usually begins in childhood as a tympanic membrane perforation, generally as an acute separative otitis media or as a otitis media with effusion. Hearing loss in CSOM is usually conductive due to tympanic membrane perforation or ossicular disruption. While sensory neural hearing loss is also reported in patients suffering from CSM. Well, this study has been undertaken to find out the incidence of SNHL in patients of CSOM in population of Ujjain and the surrounding area, so that the patient can be counseled for their further outcome. Next slide. Well, as you can see, this is a flow chart describing type of hearing loss. Hearing loss can be defined into organic and non-organic causes. Organic causes are basically conductive and sensory neural, and sensory neural can further be divided into lesions of the cochlea or in the lesions of the eighth nerve. Next slide. Well, aims were to evaluate the correlation between CSOM and SNHL, and my objectives were to examine the patients of CSOM and to study the relation of CSOM and sensory neural hearing loss. Next slide. Well, it was an observational study and it was done in the Department of Otorhinolaryngology of C.R. Gadi Hospital, Ujjain, which is associated to R.D. Gadi Medical College and is a tertiary care center in central India. My study period was from September 2019 to September 2021. Okay, next slide. The inclusion criteria were all patients of CSM coming to our OPD between the duration September 2019 to September 2021 between the age group of 12 to 50 years, and both males and females were considered in my study. Next slide. Well, the exclusion criteria consist of patients younger than the age of 12 and above 50 years to exclude the possibility of inaccuracies of audiological testing, and also the patient who did not wish to give consent for the study. Next slide. Well, it was a detailed history and clinical examination along with pure tone audiometry and radiological imaging was done. That is X-ray bilateral mastoid Schuller's view. Next slide. Well, coming to the result, out of 200 cases, 160, that's 80%, suffered from conductive hearing loss, while of 20%, that's 40 patients, suffered from mixed type of hearing loss. Next slide. And out of those 40 cases, it was seen the patients were in the majority patients were in the age group of 41 to 50 years. Next slide. Well, in my study, it was seen that out of the 40 cases who suffered from mixed type of hearing loss, the main complaints were otorrhea, which was followed by deafness. And further, it was followed by symptoms like pain in 13 cases, tinnitus in 15 cases, and vertigo in 8 cases. Next slide. Well, out of the 200 patients, examination under microscope revealed that majority, like 117 cases had an MCP, while 74 cases had an LCP. And 6 cases showed aortic perforation, and cholesteatoma was seen in approx 24 cases. While granulations were seen in 3 cases, and retraction pocket and adhesive tympanic membrane was seen in 6 and 1 cases respectively. Next slide. Well, here are some clinical photographs which I took during my study period. You can move to the next slide. Well, now coming to the discussion. We all know that it is a CSOM is a chronic inflammation of the mucoperiosteal lining of the middle ear cleft, characterized by ear discharge through a permanent perforation in the tympanic membrane, and which leads to impairment of hearing. The conductive hearing impairment generally results and is well acknowledged, while the sensory neural hearing loss, there is a again I study this study was undertaken to find out the incidence and correlation between CSOM and sensory neural hearing loss. Next slide. Well, in my study, it was seen out of the 200 cases, 40 cases, that's 20%, suffered from sensory neural hearing loss. While in the other study, it was seen where the number of patients was 115, it could not, there were around 15 cases. And also in my study, it seemed that the patients had the complaints of otorrhea. Further moving, in my study, we saw this, it is not that much clear. Out of the 200.
Dr. Rushil, your time is up.
Okay, thank you. But there was many glitches in my slide. So my
Thank you so much, Dr. Rushil. It was a very wonderful performance. Now I would like to request Dr. Shalini Jadia ma'am to kindly read the CV of Dr. Yamini Gupta ma'am. Dr. Yamini Gupta ma'am is the HOD of MGM Indore.
Please share the slide.
Now, I would like to request Dr. Ria Jain from RD Gardi Medical College to be the next participant. Dr. Ria, your present. I am about to display your present shortly.
Diksha, you are unmuted.
Dr. Ayushi, am I audible?
Please switch on your voice.
Yes, ma'am.
Dr. Ayushi, please unmute yourself.
Yes, ma'am.
Your presentation has been displayed. Dr. Ayushi.
Yes, ma'am.
सीवी किसके पास है ये बताओ।
Ma'am, am I audible?
Dr. Ria, am I audible?
Yes, ma'am, you're audible.
Hello, Dr. Ria.
Yes, ma'am.
Dr. Ria.
Yes, ma'am. Hello. Hello. Yes,
Dr.
ma'am.
Ria, I'm
Hello.
displaying your.
Yes, ma'am.
Okay. Dr. Ria, I have displayed your presentation. You can start.
Ma'am, my presentation is not visible.
नेक्स्ट कैंडिडेट का नाम अभी से बोल दो।
Next candidate is Dr. Dhawal Bhujani from RD Gardi Medical College. Please be ready. Dr.
Ma'am.
Ria, your presentation has been displayed. Kindly start.
Yes, ma'am. Good morning, everyone. Today I'm going to speak on an observational study, which is to assess the outcomes of atticotomy and attic reconstruction by conchal cartilage in chronic suppurative otitis media. Next slide. Next slide, please. Next slide, please. Chronic suppurative otitis media is a sequelae of unresolved acute otitis media and is defined as chronic infection and inflammation of the mucosa of the middle ear cleft and is characterized by persistent ear discharge and perforated eardrum. Can be of two types, either mucosal disease or squamosal disease, or can present as cholesteatoma, which is skin lining skin, which is skin at the middle ear cleft. Next slide, please. Management of chronic otitis media generally requires surgical intervention. The two main approaches for this can be canal wall up or canal wall down mastoidectomy. In canal wall up, we have another approach known as atticotomy, along with the cartilage reconstruction used by many surgeons in the treatment of lymphatic attic disease. The goal of my study is to do the atticotomy and then reconstruct the lateral attic wall after the complete removal of lymphatic attic disease with prevention of residual and recurrent disease followed by restoration of hearing and thereby producing a safe dry ear. Next slide, please. So my objectives are to assess the advantages of attic closure after the atticotomy by simple conchal cartilage in the lymphatic attic disease. The second is to assess the post-operative hearing improvement in such patients. And third is to assess the post-operative complications. Next slide, please. My inclusion, I have included patients with chronic suppurative otitis media with small, medium, large, subtotal, total, and attic perforation. Patients of pure conductive and mixed type of hearing loss and between the age group of 10 to 60 years of both genders. Exclusion criteria, cases who were operated by a canal wall down approach, less than 10-year-old and more than 60-year-old patient, and all acute suppurative otitis media and chronic suppurative otitis media with sensory hearing loss and with complications. Also, cases in immunocompromised states were excluded. Next slide, please. So I have taken 50 patients in this study. The post-auricular approach was used for all patients under general or either local anesthesia. Meatotomy was performed and tame flap was elevated and the meatotomy panel was exposed. Next slide, please. Next, please. Next slide, please. The outer attic wall was drilled to visualize the epitympanum. The limitic attic disease was dissected and removed in toto. Next step is to reconstruct the attic wall to prevent further retraction pockets. The conchal cartilage was harvested and designed according to the size needed and was placed there. The pre and post-operative hearing results were recorded and compared at third month. Next slide, please. So my result was most of the patients were in the age group of 25 to 40 years of age. There was female predominance seen, and incus was the most commonly eroded ossicle, which was seen in the 88% of the cases. In the table given below, both malleus and incus was eroded in the 40% of the case in the 40 patients, and the type 3 tympanoplasty was the most commonly done with atticotomy and with attic reconstruction. Next slide, please. So in my intraoperative findings were there was maximum 80% in 80% of the patient, the cholesteatoma was seen in the attic region for which the atticotomy was done. Other findings were the granulations, tympanosclerosis, ossicular fixation. Next slide, please. So none of the patient, two of the patients had post-op ear discharge in the first month, which got dry eventually. None of the patient had any complications like granulation, surgical site infection, facial paralysis in the post-op period. None of the patient had any residual graft defect in the first and the third post-op month surgery. None of the patient developed recurrence of cholesteatoma. Only one of the patient developed recurrent retraction pocket by the third month. Next slide, please. Next slide, please. There was a significant improvement in hearing by the third post-operative month. In type 1 tympanoplasty with atticotomy and reconstruction, there was a hearing improvement up to 15 to 20 decibels. In type 2, 20 to 30 decibels. In type 3, by 25 to 35 decibels. Next slide, please. So my discussion is the purpose of my study was to assess the anatomical and audiological outcome of atticotomy and attic reconstruction in limitic attic disease. The 50 cases were operated, and the clinical outcomes like tinnitus, otorrhea, attic cholesteatoma, and retraction pockets were significantly reduced, and 92% patients had improvement in hearing, and there was no problem of recurrence of otorrhea. Next slide, please. Many studies also by Vaidya S. et al., UR et al., Deval, Mani, and Sudhagar et al. Also suggested the attic reconstruction with cartilage prevents future retraction and recurrence of cholesteatoma and could also improve the hearing post-operatively. But it depends mainly on the ossicular status. Next slide, please. So my conclusion is atticotomy is a very good procedure for the limitic attic disease. Attic reconstruction is important to prevent recurrence of the disease. To employ atticotomy, decision is to be taken on the operating table after thorough microscopic examination of the extent of the disease. Next slide, please. Ma'am, your voice is not audible.
Dr. Ria, your time.
Okay, thank you, ma'am.
Kindly excuse me for a second. I'm changing the IT system for just 2 minutes.
Can we start?
Welcome again. Sorry for the glitch. The next presentation is from Dr. Dhaval. Dr. Dhaval, your presentation has been displayed. Kindly start presenting.
Thank you, ma'am. Good morning, respected faculty members and my colleagues. Today I present a study of...
Dr. Dhaval, am I audible?
Yes, ma'am.
हो रहा है तेरा हो रहा है मेरे पास इंटरनेट भी नहीं है मैं लेन से कनेक्ट नहीं करूँ
Okay. So today I present a study of anatomical result and hearing improvement in various type of tympanoplasty using conchal cartilage. Next slide. So tympanoplasty is a repairment of the tympanic membrane perforation with the improvement of hearing loss. The purpose of surgical technique means tympanoplasty is a complete eradication of the disease with the restoration of the hearing. Next, please. Various autologous graft materials can be used in tympanoplasty for repairment of the tympanic membrane perforation, such as the temporalis fascia, fascia lata, conchal cartilage graft, perichondrium, cortical bone, vein graft, and fat. These graft materials have stood the test of time in repairing tympanic membrane perforation. Next. Severe conchal cartilage graft have proved to promising in closing the tympanic membrane perforation. A different type of cartilage has been used, like pterygal, conchal, and costal cartilage. A cartilage graft is indeed an effective method for improvement of hearing in CSM patient. The advantage of this method is that the cartilage being autograft, easily available, safe, inexpensive material for the reconstruction of vesicles. Next. A several technique for cartilage tympanoplasty has been used, such as a shield technique, palisade tympanoplasty technique, island flap technique, butterfly inlay graft technique, crown crook technique, and cartilage mosaic tympanoplasty. Next. So aim is to study the anatomical results and a functional improvement in various type of the conchal cartilage tympanoplasty. Objective is to study the clinical profile of the conchal cartilage tympanoplasty to assess the post-operative hearing improvement by audiometry after the 3 months of the conchal cartilage tympanoplasty. Next. So material and method. I do a observational study was carried out on total 98 patients with the CSOM with central marginal subtotal or atic perforation and retraction pocket. All patients underwent the cartilage tympanoplasty by various techniques with or without mastoidectomy. Post-operatively, all patients were evaluated for the graph uptake after 3 months and hearing assessment by audiometry, pre-operatively and post-operatively. Next. So inclusion criteria, chronic suppurative otitis media with all type of perforations, means safe and unsafe type of disease, tympanosclerotic pace, pure conductive and mixed type of hearing loss between the age group of 15 to 60 years, and including both sex, both male and female. Next. Exclusion criteria: patient not included in the above age group, all type of all ASOM, CSM with the sensory neural hearing loss, CSM with the complications, immunocompromised patients, and patients with the patient will having comorbidities and loss of follow-up and incomplete records. Next. So procedure: graft material used was the conchal cartilage, and the type of surgery was decided intraoperatively, depending upon the extent of the disease. The first 2% xylocaine with the 1:2 lakh adrenaline was infiltrated in the subperichondrial plane above the conchal cartilage. Incision was made on the posterior surface of the Simba concha and K1 concha with the length of approximately 1.5 centimeter. Further dissection was performed with the dissecting scissor to expose the perichondrium and the subperichondrial plane. Once the conchal cartilage was exposed, blunt dissection with the ball type elevator. The cartilage was harvested using the tissue forceps and dissecting scissor. Electric cautery was used for hemostasis. Next. So in first picture, you see the temporal fascia graft and conchal cartilage graft. In second picture, positioning of the cartilage graft in place, and in third picture, you see the graft in C2. Next. So come to the results. I did a study on 98 patients in which safe type of disease patient is 75, in which temporal fascia graft tympanoplasty done in 39 patients and conchal cartilage graft tympanoplasty done in 36 patients. And out of 98 patients, there is a 28 patients who is unsafe type of disease, in which temporal fascia graft tympanoplasty done in 11 patients and conchal cartilage tympanoplasty done in 14 patients. Next. Out of the coming to results in conchal cartilage graft, tympanic membrane closure is achieving 100% and hearing improvement in 80%, while using a temporal fascia graft, tympanic membrane closure is achieved in 84% of patients and hearing improvement in only 78% patient. Next. A conclusion, our data indicates the cartilage graft with thickness of 0.5 mm achieved a tympanic membrane closure in 100% of patients and provide a satisfying hearing improvement in 80% of patients. But in temporal fascia graft group, we achieved a tympanic membrane closure in 84% of patients and the hearing improvement in 78% of patients. Next.
Dr. Dhawan, your time is up.
Okay, thank you.
It was a good presentation. Thank you so much. I would like to request the next candidate, Dr. Samiksha Mishra from R.D. Gardi Medical College, to be ready. I'm about to display your presentation.
Yes, ma'am.
Dr. Samiksha, your presentation has been displayed. Kindly present the paper.
Yes, ma'am. I'm waiting for the presentation.
Yes, yes. Wait 1 minute, please.
A very good morning to all the respected faculty members, seniors, and my dear colleagues. The topic of my presentation is outcome of canal wall window tympanomastoidectomy in chronic suppurative otitis media. Next, please. So the canal wall window tympanomastoidectomy is a modified form of aticoenterostomy, which can be substituted for canal wall down procedure. The surgeon dealing with the chronic ear disease has to make a lot of intraoperative decisions. And the most important is whether to sculpt the canal wall intact or whether to drill it away. And the both techniques present advantages and disadvantages, that is canal wall down and canal wall up procedures. Next, please. So this third option, that is canal wall window technique, allows the surgeon to capitalize on the structural integrity of intact canal wall and facilitates disease removal beyond the blind medial end of the canal. And it combines advantages of both our conventional techniques. Next. Next, please. The hearing results are better than expected because most patients have experienced a hearing gain, often to the normal range, after this type of cholestoma surgery, which is performed before considering the canal wall down technique. Next, please. Next. The goal of this technique is to remove the underlying disease, restore hearing, and produce a safe and dry ear.
This study attempts at evaluating the hearing benefits and dry ear achieved by the patients who underwent this window technique based on their disease status. So in our study, we have observed the outcome of canal wall window tympanomastoidectomy in cases of chronic suppurative otitis media. Next. The aim of this study is to assess the outcome of canal wall window tympanomastoidectomy in chronic suppurative otitis media. And the objectives are to study the clinical profile of the cases, to study the hearing outcome after 3 months of canal wall window technique, to study the post-operative condition of ear after 3 months, that is whether dry or wet, and to study the post-operative follow-up of cases to assess the graft uptake rate. Next. In our study, which was an observational study, and it was carried out on 100 patients. We selected them on simple random basis, which were then subjected to clinical, audiological, radiological, and laboratory investigations prior to surgery. The patients were admitted to hospital and written informed consent was taken from them for participation in the study as well as for undergoing surgery. Next, please. The cases included were all the cases of chronic suppurative otitis media with small, medium, large, subtotal, total, and atic perforations, pure conductive and mixed type of hearing loss, age group between 15 to 60 years, and both male and female sexes. Next. Excluded were from this study were those patients below the age of 15 years and above 60 years, all ASOM patients, CSOM patients with sensory neural hearing loss with complications, immunocompromised patients, and patients having systemic illness like diabetes mellitus, hypertension, tuberculosis, and hepatitis. Next, please. Now coming to procedure. All my patients underwent canal wall window tympanomastoidectomy, and post-operatively, all patients were evaluated for hearing gain by comparing post-operative pure tone audiometry to pre-operative pure tone audiometry at 3 months, dry and wet ear, and intactness of the graft. So what we did, the bony canal was widened by cutting bud up to the outer atic wall, that is scutum, and the small hole was made in the scutum near atic, and the medial bony annulus, that is the facial bridge, was preserved. The window was extended in accordance to the disease extent, that is posteriorly. The window at the end was closed using a cartilage which snugly fits in the window. Next slide, please. Here you can see several pictures showing canal wall window tympanomastoidectomy. In first picture, you can see a canal wall has been made. That small hole which you can see is the canal wall window that we have made. In the second picture, you can see that the cartilage is being fit into the window, that small window that we have made. And in the final picture, you can see the cartilage is being snugly fit in the window. Next slide, please. So now coming to the results. Now you can see that 20 decibel of hearing gain was seen in around 29% of our cases, and 16 decibel hearing gain was seen in 40%, while only 10 decibel hearing improvement was seen in 31% of our cases. Next slide. A remarkable dry ear was achieved in 96% of our cases, and only 4% patients came with wet ear, which was managed accordingly. And intactness of graft was seen in almost all of our patients, that is 99%. Next, please. As we have already discussed in the later slides. Next. So coming to the conclusion. So as we have already talked that this technique is not replacing any other conventional technique. We are just complementing the current techniques with this technique. And it is also a novel technique in mastoid surgery. The surgeon can take advantage of an enhanced view, but still maintain structural integrity. That is, we can say that this technique is less destructive. The window slit can be used in
Dr. Samiksha, your time is up. You can conclude now.
Okay, ma'am. Just one more slide is there, if you can allow me.
Okay.
Okay, so another most important point in this surgery is we can avoid the dreadful CSF leak because the low-lying dura can be identified well in advance. It is a quick surgery, and at any point of time, this surgery can be converted into canal wall down procedure as in accordance to the disease intraoperatively. Thank you so much.
Thank you so much. It was a beautiful presentation. Now I would like to request the next candidate, Dr. Ayushi Gupta from People's Medical College, Bhopal, to please be ready. Your presentation will be displayed shortly. Dr. Ayushi, your presentation has been displayed. You can start.
And its association with liposylated hemoglobin. I have done my study under the guidance of Dr. Shani Jadli, Madam, Professor and Head of Department. Next, please. Next, please. Diabetes is a metabolic disorder of impaired carbohydrate, fat, protein metabolism caused either by lack of
Dr. Ayushi, sorry to interrupt, but your voice is not clear. It is breaking and there is a lot of echo. Okay, you can continue. Okay, you can continue.
Loss of diabetes and good control may prevent complications of sensory hearing loss. Next, please. Next slide, please. Aim of my study is to find out prevalence of sensory hearing loss in diabetes mellitus patients and its association with liposylated hemoglobin. Next slide, please. Objectives of my study is to study the prevalence of sensory hearing loss in diabetes mellitus patients and to study the association between liposylated hemoglobin and sensory diabetes. I have taken 60 patients of hepatitis. Am I audible?
Dr. Ayushi, your voice is breaking so much, you are not audible.
There must be network issue, Dr. Ayushi. Please check your network fast.
Yes. Am I audible now?
Yes. You are audible now. Continue, please.
Okay. Next slide, please. I have taken detailed history of each patient and have done thorough examination of ear using otoscope. Next slide, please. I have included all patients who came with the OPD diabetes mellitus in all age group and both genders. I excluded patients presenting with history of any ear disease, ear surgery, head and ear trauma, patients with family history of any deafness, history suggestive of noise-induced hearing loss, any genetic disorder, and severe ill patients. Next slide, please. Character of Tympanum was observed in detail, and pure audiometry was done and observed for type and degree of hearing loss. Next slide. Patients who have diabetes mellitus included all total 60 patients, in which 33 were female and 27 were males. Next slide. Table 1 showing the results of my paper, in which total 13 patients who came with the complaint of diabetes mellitus and with sensory hearing loss, in which 5 patients were male and 8 patients were female. And in all 10 patients who presented with diabetes mellitus with mixed hearing loss, in which 5 patients were male and 5 patients were female. Table 2 showed the association distribution of age, in which one patient with sensorineural hearing loss and mixed hearing loss came under the category of 31 to 40 years. 2 patients with sensorineural hearing loss and 3 patients with mixed hearing loss came under the category of 41 to 50 years. 4 patients with sensorineural hearing loss and 4 patients with mixed hearing loss came under the category of 51 to 60 years, and 6 patients with sensorineural hearing loss and 2 mixed hearing loss came under the category of 61 to 70 years. Next slide, please. Table 3 showed the total 60 diabetic patients, 13 presented with sensorineural hearing loss, and 37 patients had normal hearing. Table 4 showed the degree of hearing loss in diabetes mellitus patients, in which 4 patients had mild sensorineural hearing loss, 6 patients had moderate sensorineural hearing loss, 2 patients had moderately severe sensorineural hearing loss, 1 patient had severe hearing loss, and none of the patients had found profound hearing loss. Next slide, please. This table showing the association between glycosylated hemoglobin and sensorineural hearing loss. So, in 28 diabetic patients who came under the category of HbA1c below 7, represented 3 sensorineural hearing loss patients, and 18 patients who came under the category of 7 to 8 glycosylated hemoglobin, in which 4 patients had sensorineural hearing loss, and 40 patients who came under the category of HbA1c more than 8, in which 6 patients had sensorineural hearing loss. Next slide, please. This table showing the hearing status in each category, in which in all 28 patients, one had moderate severe sensorineural hearing loss, and all 27 patients were found normal hearing. And in all 18 patients, 2 had mild sensorineural hearing loss, 2 had moderate sensorineural hearing loss, and one had moderate severe and one had severe sensorineural hearing loss. And the 12 patients were found normal hearing. And in category more than 8, in 40 patients, 2 had mild sensorineural hearing loss, 3 had moderate sensorineural hearing loss, 1 had moderate severe, and 1 had severe sensorineural hearing loss, and 7 patients were found normal. Next slide, please. This pie chart showing in all 60 diabetic patients, 13 had severe sensorineural hearing loss, 13 had mixed hearing loss, and 37 patients who came with the complaint of diabetes had normal hearing. Next slide. So my study's conclusion is that patients with diabetes mellitus have chances to develop sensorineural hearing loss, and my study showed significant association between diabetes mellitus and sensorineural hearing loss. Next slide. These are my differences. Thank you.
Thank you so much, Dr. Ayushi. Your time is up and it was a very good presentation. Thank you so much. And with this presentation, we are concluding with the first Mahadevaya session. Now, we are judges, I kindly request you to mark these candidates out of 10 and kindly send the marks to Dr. Kavita Sachdeva ma'am. Thank you so much to chairpersons and all the candidates for this session. Now, I would like to request the candidates of the next session to please be ready. Your presentations will be displayed shortly. Before that, I would like to request the chairpersons of this session to please come and grace this session. I would like to welcome Dr. S.K. Pippal, sir. Dr. S.K. Pippal, sir, is Professor and HOD, BMC and Hospital Sagar. He has 28 years of experience in teaching, and his field of interest are microsurgery and ear surgery. We welcome you, sir. And the next chairperson is Dr. Shiv Kumar Raghuvanshi. He is the HOD of Atal College Bihari Vajpayee Medical College, Vidisha. Thank you so much, sir, for being the chairpersons for this session. Now, I would like to request the next candidate, who is Dr. Sweetie Sen. Dr. Sweetie Sen, we are about to display your presentation. Kindly be ready.
Hello.
Hello.
Am I audible?
Yes, yes, you are audible. Just a second. We are about to display. Dr. Sweetie?
Yes.
Okay, your presentation has been displayed. You can start.
Good morning, everyone. I, Dr. Sweetie Sen, under the guidance of Dr. Nitish Besakia, sir, that is Professor and Head of Department, LN Medical College, JK Hospital. Today, I am going to present a paper on the topic Assessment of Hearing Status in Neonates. As we know that hearing is one of our most important senses. It helps us to communicate to the rest of the world. Congenital hearing impairment, it has been associated with lifelong disability in speech and language learning. Hearing is important for communication and social interaction. It allows a child to develop the verbal communication skill. Hence, it is essential to perform screening at birth. Next slide. Previous slide. Congenital hearing loss, it has been recognized as one of the most common birth defect which is present in newborns, and the prevalence of permanent hearing loss that ranges from 3 to 4 per 1,000 live births. The incidence is relatively higher in the high-risk babies, that is 1 to 2 cases per 200. Hearing loss initial signs are very subtle. It cannot be easily recognized by the parents. So the early diagnosis and immediate intervention, it play a crucial role in the development and prognosis of children with hearing disabilities. Next slide. High-risk newborn that must be screened, that is the family history of childhood sensorineural hearing loss, prenatal infection like torch, and ICU admission more than 48 hours, neonatal asphyxia, low birth weight, hyperbilirubinemia, bacterial meningitis, ototoxic drugs, craniofacial deformity. Next slide. The Universal Newborn Hearing Screening Program. I cannot.
Sorry, just a second.
Previous slide, please. Universal Newborn Hearing Screening Program. It began in January 1, 2003. There is two-stage screening. The first stage, all newborns are screened with OE. The second stage, the refer infants of first stage, they are again screened with OE. And the refer infants of second stage need audiological assessment like BERA. Next slide, please. 136 plan. That is all infants that has to be screened before 1 month of age. The complete hearing evaluation should be done before 3 months of age, and the early intervention, the appropriate intervention should be done before 6 months of age. Next slide, please. Prior to the Universal Newborn Hearing Screening implementation, the average age of identification of hearing loss was 20.2 months. But after this, the average age of diagnosis has greatly improved to 3.8 months of age. Next slide. Screening methods. Two primary methods are used for newborn hearing screening, that is otoacoustic emission and the auditory brainstem response. These both tests are objective, safe, non-invasive, and the only complication associated with ABR is skin abrasion and no complications reported from OA. Next slide. Aim and objectives. The aim is to study the role of otoacoustic emission as screening test and ABR as diagnostic test among all newborns. Objective is to screen all the newborns for hearing, to detect the incidence of hearing loss in newborn, to know the prevalence of hearing impairment in high-risk babies. Next slide. Materials and methodology. All newborns born in JK Hospital from January 2021 to January 2022 included in my study. Next slide. This is the methodology depicted in the diagram, that how first all babies are screened within 72 hours of birth, first OE done. Then if it comes refer, then repeat second OE within 5 to 7 days. If again refer come, then proceed for a BERA, and if BERA is abnormal, then rehabilitation should be done. Next slide. Inclusion criteria. All babies delivered in JK Hospital and whose parents gave consent for the study. Exclusion criteria. Babies lost to follow-up and unstable newborns needing urgent referral that were excluded. Next slide. Results and observations to gender distribution. Total in this study, 200 newborns were assessed, 106 boys and 94 girls. So the ratio was 1.13. Risk factors, 60 were having no risk factors and 140 were having high risk factors. Next slide. Risk factor in our study, the most common risk factor was the low birth weight, which is followed by low birth weight along with preterm delivery, and there are some other risk factors also. Next slide. Okay, come to the result. Coming to the result, among two newborns who failed the second OE test, the one neonate full-term baby delivered through LSCS, mother had oligohydramnios, newborn had hyperbilirubinemia. It has been found to suffer from bilateral moderate sensory neural hearing loss. The one other neonate that lost to follow-up. Next slide. Discussion. The incidence of hearing loss is different in various studies. In our study, 200 newborns were screened and one unit that has been found to suffer from bilateral moderate sensory neural hearing loss. According to Wright, the incidence of hearing loss was 2 to 3 in every 1,000 newborns. Next slide. It is concluded that OA is economical, safe, non-invasive, reliable, portable method of screening, which can be beneficial in the early detection and identification. Next slide. Conclusion. Every individual has the right.
Dr. Sweetie, your time is up. Kindly conclude.
Okay. Only through this systematic detection programs, infant with hearing loss can be assured of a chance to develop their full potential. Regardless of the age of onset, all children screening should be done. Thank you. Thank you so much.
Thank you so much, Dr. Sweetie. It was a beautiful presentation. Now, I would like to request Dr. Anmol Patel to kindly be ready with your presentation. We are about to display your presentation shortly. Okay, Dr. Anmol Patel, your presentation has been displayed. Kindly start.
Okay. Good morning, everyone. Today I'm going to present a paper on the topic of factors determining ossecular status in mucosal type of chronic otitis media under the guidance of Dr. Nitish Basakia, sir, HOD and Professor of Allen Medical College. Next slide, please. Next slide. As per introduction, chronic otitis media is a common condition in otorhinolaryngology. It leads to the wide range of pathologies in the middle ear that include mucosal changes, granulation tissue formation, colestoma, tympanal necrosis, and ossecular destruction. Next. Although ossecular necrosis can be seen in both types of chronic otitis media, its incidence is comparatively less common in mucosal type of disease. Ossecular necrosis due to the mucosal type of chronic otitis media may due to the increased osteoclastic activity or avascular necrosis by means of overproduction of cytokines like TNF-alpha, fibroblast growth factor, and PDGF. Necrosis of long process of incus, superstructure of stapes, body of incus, and manubrium occurs in decreasing order of frequency in chronic otitis media. Next, please. Surgery is the treatment of choice for COM. If the ossicular discontinuity is predicted before surgery, it helps the surgeon to know the possibility of performing an ossiculoplasty and to counsel the patient about the procedure, success, failure, and complications. Next, please. Aims and objective. Aims to determine the preoperative predictors for ossicular chain discontinuity by clinical and audiological evaluation in chronic otitis media. And for objectives, the clinical and audiological evaluation of chronic otitis media patients and intraoperative correlation of preoperative clinical, audiological, and radiological findings. Next, please. Next, please. Materials and methodology. This study has been conducted over a period of 8 months in Department of ENT in Allen Medical College, Bhopal. Total 75 patients with COM mucosal disease were studied during this period. Study design is the prospective study. Next slide. Inclusion criteria: patients of chronic otitis media with mucosal type disease, patient with age group 10 years to 65 years, patient willing for reconstructive surgery offered to them, and patient giving consent for the study. As per exclusion criteria, patient having squamosal type of chronic otitis media, patient not giving consent for a study, and patient not willing for surgery. Next, please. CT scans were done in some selected cases to exclude the middle ear and mastoid pathology, mainly to identify cholestoma, assess the ossicular chain status, and status of the facial canal and semicircular canals. Patients with dry central perforation in tympanic membrane, which were dry since more than 4 weeks with a normal eustachian tube function, were offered only tympanoplasty. Next. In patient with intermittent or continuous ear discharge, despite of medical treatment, we chose proper antibiotics by culture sensitivity tests and preferred to do cortical mastoidectomy and tympanoplasty as one-stage procedure. All the patients were evaluated under the microscope during surgery to confirm the preoperative findings. Next, please. As per results, the study group consists of 75 patients with a mucosal type of chronic otitis media. Overall ossicular necrosis was noted in 5 patients among the all total 75 patients. Next, please. Age distribution. Age range varied from 10 to 60 years, and the most common age group involved was 20 to 30 years, involving 30 cases. As per gender, the male to female ratio is 1:1.32 in the study. Next. There is no significantly association of the duration of discharge, hearing loss, and size of tympanic membrane perforation with ossicular necrosis seen in our study. Next, please. Middle ear mucosa was pale in 47 patients and polypoidal in 28 patients, and the necrosis erosion was significantly higher when the middle ear mucosa was polypoidal, that is p-value is 0.003. Next. The presence of granulation in a middle ear noted in 7 patients, which was significant for the ossicular necrosis. Next, please. Tympanoplasty was found in 27 patients and was significant for necrosis. Next, please. Mean airborne gap being significantly higher for ossicular necrosis with 39 decibel to that of the 25 decibel with intact ossicular chain. Next. As per discussion, although defect of ossicular chain is most commonly seen in mucosal type of chronic otitis media, it has been well established that it can also be seen in mucosal type of chronic otitis media. On analyzing the relationship between ossicular necrosis and preoperative factor in our study, age of patient and duration of discharge are not good predictor of ossicular necrosis. In contrast, according to Jayakumar C. et al., patients of age group 30 years and duration of disease for more than 10 years were significant indicator for ossicular necrosis. Next. In our study, airborne gap of more than 39 decibel was found to be the statistically significant preoperative indicator for ossicular necrosis. Presence of middle ear granulation was found to be the statistically significant predictor for ossicular necrosis in Ebenezer Z et al.
Dr. Anmol, your time is up. Kindly conclude.
Okay. As per conclusion, ossicular necrosis was best indicated in the presence of granulation in the middle ear and also in higher airborne gap. However, the presence of tympanosclerosis and polypoidal middle ear mucosa were also significant predictor of ossicular necrosis. Thank you.
Thank you so much, Dr. Anmol. It was a very nice presentation. Now, I would like to request the next candidate, Dr. Manasa Krishna, to kindly be ready. We are about to display your presentation shortly.
Hello.
Am I audible?
Yes, Dr. Manasa, you are audible. Kindly start your presentation.
Yes. Good morning, respected consultants. Today, I'm going to present paper on topic outcomes of mastoid cavity obliteration with bone patty in patients with chronic otitis media. Next slide. Next slide, please. The most widely practiced technique in aticoantral COM is an open cavity mastoidectomy, techniques like modified radical and radical mastoidectomies. The aim of open cavity procedure is to exteriorize the mastoid cavity for inspecting the recurrence of cholesteatoma in future to provide access for free drainage of intractable temporal bone infections. Open cavity procedures carries the potential of unhealed cavity resulting in chronically discharging ear with a hearing deficit of 30 to 40 decibels, water and hearing aid intolerance. Next slide. Hence, to reduce the incidence of chronic ear discharge and to create a small cavity with a better epithelialization, faster healing, the size of cavity is reduced by obliteration using either free grafts or local flaps. The current study is to evaluate the outcomes of mastoid cavity obliteration using bone patty in open mastoid cavity techniques. Next slide. Aims and objectives are to study the surgical outcomes of mastoid cavity obliteration and to study the efficacy of mastoid obliteration using bone patty in terms of cavity size, epithelialization, healing period, and presence of granulations. Next slide. Next slide, please. Our study was a prospective observational study done in 70 patients from January 2020 to previous slide, please. Previous slide. It was done in 70 patients from January 2020 to June 2021, and in all patients, canal wall down mastoidectomy was done, in which mastoid cavity was obliterated with bone patty in one group and the cavity was kept open in another group. Next slide. Coming to the results and observation, in the present study, previous slide, please. In the present study, the efficacy of mastoid cavity obliteration using bone patty is measured in terms of cavity size, epithelialization, healing period, and presence of granulation. The mean age in our study was 28.29 and majority were females and majority presented with mucopurulent ear discharge and most common 70% presented with moderate conductive hearing loss. Next slide, please. The most common complication we encountered was cholesteatoma in 74.3% patients, followed by meningitis, followed by subperiosteal abscess, and 9 patients presented with facial nerve palsy, 8 of them presented with brain abscess, and 4 of them presented with hydrocephalus. Next slide, please. This was a patient presented with facial nerve palsy with a grossly retracted grade 4 tympanic membrane with attic wax and HRCT showing soft tissue density in the mesotympanum with ossicular and mastoid erosions with a preoperative PTA of 51.6 decibel hearing loss. Next slide, please. Intraoperatively, we have obliterated mastoid cavity with bone patty in 45 patients, and in 25, we have kept the cavity open. Next slide, please. This is the intraoperative image of mastoid cavity that has been obliterated with bone patty. Next slide, please. Coming to our results, at the end of, we have followed up the patients at 6, 10 and 14 weeks. So at the end of 14 weeks, none of our patients presented with ear discharge in obliterated group, and from non-obliterated group, 24% patients presented with ear discharge. And 93.3% patients had a dry cavity from obliterated group, and 88.8% patients had a well-epithelialized cavity from obliterated group at the end of 14 weeks. But coming to the non-obliterated group, only 76% patients had a dry cavity and a well-epithelialized cavity at the end of 14 weeks. Coming to granulation tissues, 8% of patients from both the obliterated and non-obliterated groups presented with granulation tissues. Next slide, please. So in the present study, on the basis of all observations, we infer that cavity obliteration reduces the postoperative cavity problems in terms of better healing process and cavity epithelialization, smaller cavity size, thus decreasing the formation of granulation tissue and discharge. And we have obtained a statistically significant result of p-value less than 0.05. Next slide, please. This is a postoperative well epithelialized dry cavity and patty cavity filled with granulation tissue at 14 weeks in a patient with open mastoid cavity. Next slide, please. So our study was comparable with other studies in terms of ear discharge and cavity epithelialization, where both the parameters were improved or better in obliterated groups when compared with that of the non-obliterated group. And the healing period in our study was 12.67 weeks in obliterated, whereas it was more than 14 weeks in non-obliterated group, and it was comparable with other studies. Next slide, please. So to conclude, cavity obliteration with bone patty had a better surgical outcome with decreased incidence of discharge and other cavity problems. And the disadvantages noted are difficulty in sculpturing and the risk of trapping microscopic islands of cholesteatoma deep to the obliteration materials. Next slide, please. These are my references. Thank you.
Thank you so much, Dr. Manasa. It was a beautiful presentation. Now I would like to request the next candidate, Dr. Ankit Kumar, to kindly be ready. Your presentation will be displayed shortly. Your presentation has been displayed, Dr. Ankit Kumar. Kindly start.
Good morning to everyone. Today I am going to present my paper. The topic is evaluation of the eustachian tube function with impedance audiometry and its correlation with the tympanoplasty outcome. Next slide. Next, introduction. Eustachian tube maintain the air pressure between middle ear and the atmospheric pressure, drainage of the mucus, and protection of the middle ear from the pathogen. Dysfunction of the eustachian tube play a vital role between, for the pathogenesis of the middle ear cleft disease. For the normal function of the middle ear and better outcome of the reconstructive middle ear surgery and long-term prognosis, eustachian tube should be properly synced. Next. Impedance audiometry is a popular choice investigation to evaluate the eustachian function because of it is the easier, simpler, and user-friendly method. Modern impedance audiometer can evaluate the eustachian functioning in intact as well as perforated tympanic membrane. To achieve the satisfactory result of tympanoplasty, pre-operative testing of ETF should be done. Next, please. Next. The aim and objective of our study is the assess the previous slide, please. Aim and objective of our study is to evaluate the efficacy of impedance audiometry in evaluation of the eustachian tube function in perforated tympanic membrane, correlate the result of impedance audiometry with the outcome of the surgery, and assess the functional outcome of the middle ear reconstructive surgery. Next. Next, please. This is pre and material method. This is pre and post-operative interventional study in which 50 patients were included from January 2020 to July 2021 with age group from between 12 to 45 year, chronic otitis media with mucosal type, central perforation, and there is no active ear, nose, throat disease. And the patient which have less than 12 years and more than 45 years, chronic otitis with complications, squamosal type of disease, SNHL, congenital anomaly, COPD, and anemia, and revision cases and chronic otitis media with active ear, nose, throat disease, active ear, nose, throat infection were excluded from the study. Next. All patients underwent the complete ENT examination with audiological, followed by the audiological examination by the help of proton audiometry and impedance audiometry. Then all routine investigation to be done, and the underwent finally type 1 tympanoplasty with the post-oral route and underlay technique, and follow up by first week, then first, third, and sixth week after month after the surgery. Next. Toynbee test, it is done on the perforated tympanic membrane for the 40 seconds. The modern day impedance audiometer can change the middle ear pressure, and these pressure can be neutralized by the swallowing. After 4 to 5 swallow, the air pressure in the middle ear can be neutralized. These are the different graphs which were obtained by the different types of eustachian tube patency. The first graph showing the completely patent eustachian tube, second graph showing the partially impaired eustachian tube, and third graph showing the completely obstructed eustachian tube. Next, please. Next. Post-operatively, we will give the IV antibiotics, analgesic, and nasal decongestant. Suture Gulden, previous slide, please. Instruct the patient to sneeze with the open mouth and to avoid the rigorous work. Uptake of the graft is assessed by the microscopy and autoendoscopy. Impedance audiometry and proton audiometry was done at the first, third, and sixth month after the surgery. Next slide. Now coming to the observation and result. Age distribution 12 to 45 year, mean age is 29.32. Gender distribution 64% female and 36% male. Out of 50 patients, 27 had mild, 20 had moderate, and 3 had severe conductive hearing loss. Out of 50 patients, 33 has medium central perforation, 16 has large central, and 1 has subtotal perforation. Out of 50, 39 patients had the normal ETF, eustachian tube function, and 11 had partially impaired eustachian tube. Next, please. These are the associated uptake and eustachian tube functioning and the airborne gap mean hearing improvement versus eustachian tube functioning. First graph showing the 94% cases of the normal ETF and 63% cases of the partially impaired ETF, showing the graft uptake by 5% and 36% patient showing the graft failure in normal ETF and partially impaired ETF respectively. Now coming to the association between the ETF and airborne gap. In 64% cases and 6% cases of the normal ETF and partially impaired ETF respectively, showing the better outcome in the terms of airborne gap, and 4% and 4% patients showing the 15 to 20 decibel airborne gap, while 2% and 12% cases showing the more than 20 decibel airborne gap in normal and partially impaired ETF respectively. Next slide, please. Next. These are the picture of the same patient of the pre-operative and post-operative. First photograph showing the large central perforation, and below it this is the eustachian functioning of the same patient. After it, post-operative showing the graft uptake. Last images showing the below images showing the tympanometry of the same patient after 6 months. Next slide, please. Now coming to the result. Uptake of the graft and hearing improvement was more with the normal eustachian function as compared to the impaired function. Uptake of the graft and hearing improvement was also found in impaired tubal function with the more follow-up, extra care, and medication. The data was statistically significant, which is showing in the p-value is 0.05 and 0.001 respectively. Now,
Dr.
next.
Ankit, your time is up. Kindly conclude.
Conclusion. With the help of impedance audiometry, we can assess the eustachian function properly, and it should be done pre-operatively with the help of impedance audiometer, and it should be included in the routine investigation like PTA, and Tympanoplasty could be successfully intertubal function with the long-term follow-up and medication who had not taken graft in the initial visit. Thank you.
Thank you so much, Dr. Ankit Kumar. Now, I would like to request Dr. Rimsha Khan, the next candidate, to please be ready. Your presentation will be displayed shortly. Okay, Dr. Rimsha, your presentation has been displayed. Kindly start the presentation. Yes, yes, you are audible. Dr. Rimsha, am I audible to you? Dr. Rimsha, you are not audible right now. Kindly check your network connections. Hello, Dr. Rimsha. Am I audible to you? You are not audible clearly. Kindly check your network connections. We are not able to hear you, Dr. Rimsha Khan. Rimsha Khan, you are not at all audible.
Am I audible?
Now you
Yes,
are
now
audible, but the voice is echoing. Kindly please check it fast.
Am I audible now?
Yes, yes, you are audible, clearly audible. Start
Can I
speaking,
start?
please. Yes, start speaking.
Today I'm going to present my paper presentation on the topic pathological effects of personal listening devices, headphones, earplugs, and earbuds under the guidance of Dr. Sadat Qureshi, Professor. Next slide, please. Next slide, please. Next slide, please. Exposure to excessive noise is a major avoidable cause of permanent hearing impairment worldwide. Previous slide, please. Previous slide, please. Exposure to excessive noise is a major avoidable cause of permanent hearing impairment worldwide. Noise-induced hearing loss is the most prevalent irreversible industrial disease and occupational hazard. Come within the range of maximum levels for around 80 to 115 decibel directly. Next slide, please. The insertion depth of earbud of the earphone into the ear canal is maximum. Provide the device and the type of music are the factors affecting the amount of sound deposit, and particularly cochlear outer recess, and the higher frequencies are localized at the base of cochlea, and the lower frequencies localized at the cochlear apex. Next slide, please. As the use of personal listening devices has increased so far, the effects on the ranging of from otitis to mucomicosis to severe sensory hearing loss. So in this scenario, there is need to study the effects of prolonged exposure to loud noise due to personal listening devices. Next slide, please. The aim of this study is to increase the early detection of the otological disorders due to the use of prolonged personal listening devices. Next slide, please. The objective of my studies to identify the personal listening devices most commonly used and determine their users with regard to their listening habits, symptomatology, hearing function. And next slide, please. It was a cross-sectoral prospective observational study, and it will be obtained from the students of People's University and Research Institute after approval of institutional ethics. And my sample size is 200 students who are using personal listening devices. Next slide. Next slide. Next slide. Next slide, please. The inclusion criteria was age group of between 18 to 30, 18-30, and exclusion criteria is individuals who are above the age group of 30 with any pre-existing hearing disorder, any associated confounding factors, any history of toxic drug, history of any ear surgery, noise trauma, ear anomaly. Next slide, please. Next slide. In the results, 200 students were included in 110 per grade and 90 per grade. And the total the age group majority of students were between 24 to 28 years. That is 98 students were between 24 to 28 years, 85 students were between 18 to 23 years, and the 17 students were between 28 to 30 years. That is majority of students were 98 between 24 to 28 years. That is 42%. Next slide, please. The hearing loss in my study is most of the patients that 7.8% had normal audiometry, with 27.2% have mild conductive hearing loss. Next slide, please. In the condition of external auditory canal, the majority of patients has normal external auditory canal, with 15% had Mucomicosis, 17 has tortuous, 7 has tortuous EAC, and 18 had parapharyngeal EAC. Next slide, please. The duration of usage per day is majority of students, that is 113 students, use the personal listening device 3 to 4 hours per day, followed by that is more than 4 hours per day, then 2 hours per day, or less than 1 hour 90 students. Next slide, please. The type of device most of the students use was earphone, that is 146 the age distribution of students are using personal devices for majority was between 24 to 28 years, with mild conductive hearing loss, that is majority of patients 54 students, and the duration of exposure was between 3 to 4 hours, and the condition of ECG was normal in most patients, and also prefer earphones as a type of hearing the conclusion by study that was young conductive hearing loss, majority has cases as prolonged exposure by alternate listening devices. So the avoidance of the alternate listening device is important, and the duration of exposure is important in relation to the type and severity of hearing loss. Next slide, please. These are my references. Next slide, please. Thank you.
Thank you so much, Dr. Rimsha. Candidates, kindly check your network connections beforehand because time extension will not be possible. I would like to request the chairpersons of this session and the earlier session as well to kindly send the marks to Dr. Kavita Sachdeva ma'am. With this, now we have concluded the Mahadevaya session. We will be beginning with Dr. Renuka Brado's session shortly. I would like to welcome the chairpersons of Dr. Renuka Brado's session, Dr. V.P. Narve sir. He is the professor and HOD in the GRMC Medical College, Gwalior. He has a teaching experience of 18 years and his field of interests are otology and rhinology. I welcome you, sir, to this session. The next chairperson of this session is Dr. Anil Kumar Jain. Sir, I heartily welcome you to this session. Dr. Anil Kumar Jain is professor and HOD from Chirayu Medical College, Bhopal. He has a teaching experience of 15 years and his field of interests are otology, rhinology and laryngology. Sir, I welcome you to this session. Kindly grace us with chairing this session. Now, with this, I would like to request the candidates for the Renuka Brado session to please be ready. Dr. Amrita Shukla, your presentation will be displayed shortly. Kindly be ready.
Hello, may I speak few words please before starting the presentation?
Ji sir, ji sir.
Good morning all, I am Dr. Anil Jain. It's my humble request to all the participants to please be clear in presentation and remain with time limits. Please strictly follow that instruction. Thank you.
Thank you so much, sir.
Best wishes to all.
Candidates, kindly note that please be clear with your presentations as said by sir and kindly stick to the time limits. Dr. Amrita Shukla, kindly be ready. We will be displaying your presentation shortly. Dr. Amrita, kindly start with your presentation.
Am I audible?
Yes, yes, you are audible.
Good morning, everyone. My topic is COVID-associated mucormycosis and its etiological correlations. Next. Next slide, please. During COVID-19 pandemic, patients with diabetic mellitus and immunocompromised condition were at risk of the opportunistic infection, among which mucormycosis came with the most dreadful consequences. Mucormycosis is a potentially fatal and invasive fungal infection belonging to final zygomycetes, including mucor, rhizopus, rhizomucor, apophytomyces, apsitum. Invasive zygomycosis followed by aspergillosis is an important concern in India as highest number of cases being reported from here. The fungus is ubiquitous and cause disease in an altered immunity status. Patients that are more vulnerable to get the disease are the ones having uncontrolled diabetes with or without diabetic ketoacidosis. Despite aggressive and disfiguring surgeries paired with antifungal therapy, the modern
Dr. Amrita, kindly respond.
Voice is lost.
Dr. Amrita.
Coming to the pathogenesis, inhaled fungal spores converted from saprophyte to the pathogenic fungi in nasal blockage. Zygous spore germinate to produce hyphae in the presence of sinus obstruction with impaired sinus ventilation. The fungus germinates and invades neural and vascular structures that leads to vessel thrombosis and cause mucosal necrosis. Further and leads to furthermore deep bony destruction. Next slide. As the fungal spores are ubiquitous with favorable environment, they get changed into pathogenic form from sporophytic fungi and thrives in presence of occluded sinus ostium due to inflamed mucosa in arid hot weather. Initially, the infected mucosa may appear normal, discharge erythema only, but progressively with thrombosed vessel, and they invade nerves. Apparently healthy mucosa will turn into black necrotic nasal and palatal discharge secondary to evasculated tissue necrosis. Here's a slide showing tissue necrosis of the patient, zygomatic area, and the palatal discharge. This is CT-PNS showing left maxillary destruction, and a CBCT showing the destruction of osteolytic change in the left maxillary area. Clinical features may vary depending upon the site of the invasion, distributed among cutaneous, pulmonary, GIT, rhino-orbital cerebral site. Nasal symptoms may vary from nasal discharge, loss of sensation, discoloration of the nasal mucosa, granulation, ulceration, crusting to disruption, and osteolytic lesion in the paranasal sinus bony walls. Orbital symptoms may vary from periorbital discoloration, diplopia, proptosis, decreased vision to complete loss of vision. Ophthalmoplegia can spread the infection to cavernous sinus by various ways, and the consequences of the same in the form of central or brainstem infection may present as headache, neurological deficit, seizure, and coma. Angio invasion, if present, it will cause blackish discoloration of the affected part. Pulmonary mucomicosis will present with cough, fever, pleuritic chest pain, and dyspnea. Angio invasion will cause massive hepatitis followed by dissemination of the disease. Here is showing the endoscopic pictures showing mycotic debris within the mucosa, the excised part, and the macroscopic picture of the fungi. My aims and objectives were to determine correlation between the pathological agents and COVID-associated mucormycosis. The prospective cross-sectional study was conducted in our hospital. Over 160 patients who has given consent for participation having symptoms and signs of mucormycosis in early or in advanced stage during the time period of May to July 2021. Based on detailed history, clinical examination, endoscopic examination were performed, pathological investigation, including fungal culture, KH mount, HPR findings with other related blood and radiological investigation were done. Surgical management done, paired with medical management, samples sent to related post-operative investigations. Data was analyzed and was presented in the form of frequency and percentage tables shown by bars and pie charts. Coming to observational results, out of 160 patients, 127 patients, that is about 80%, came to the hospital with suspected mucormycosis, were either recovered from COVID-19 or were suffering from both the diseases simultaneously. The rest of the 33 patients were negative for COVID-19 but had suffered flu-like symptoms, thus from past 1 to 2 months, and thus were symptomatically treated as COVID suspect. The age was categorized into 3 groups: below 30, 30 to 50, or more than 50. Out of 160 patients, we observed elderly group were more affected. Male preponderance was noted. 60% patients were known diabetes with uncontrolled blood sugar ranging from 200 to 550 mg. 35% were newly diagnosed secondary to COVID steroid. A total of 80% patients received steroid. Among 160, 48% patients were reported positive for fungal hyphae in QH reports. 38 were negative. Report of 20 patients couldn't be obtained due to various reasons.
Dr. Amrita, kindly conclude. Your time is up.
The pathogen is ubiquitous. Portal of entry of the fungus post inhalation injured. Occurrence of period was between May to July. Majority of patients presented to mucorward with variety of the nasal symptoms, commonest being nasal. Coming to conclusion, a multidisciplinary approach, including early diagnosis with surgical intervention, paired with the medical management, including intravenous antifungal drug, is essential to ensure successful outcome. To improve survival rates, clinician must be aware of
so much, Dr. Amrita. Your time is up. Thank you so much. It was a very beautiful presentation. I would like to request the next candidate, Dr. Lakshmi Viraj, to please be ready. Your presentation will be displayed shortly. Dr. Lakshmi, your presentation has been shared. Kindly start.
Good morning, everyone. My topic is post-surgery mucor recurrence in COVID-19 associated mucomicosis patients of a tertiary care center. Introduction. We are in the middle of COVID-19 pandemic and the second wave has brought in the sudden surge of mucomicosis, a disease which was very rare once has now started to become endemic. Mucomicosis, the so-called black fungus, is an angio-invasive infection due to the filamentous fungi of the class Psychomyces and the order Mucorales. These patients were treated with antifungals, aggressive surgery, control of diabetes and other predisposing factors. Though treated aggressively, patients underwent relapses or recurrences. The aim of the study is to evaluate the causes and relevant factors predisposing to recurrence. Tools used to evaluate recurrence and the extent of disease in relation to primary disease. Methodology, study design, prospective observational study, study location, Department of Otolaryngology Tertiary Care Center, study period, April 2021 to September 2021, sample size, 160 CAM patients, which includes 21 recurrent cases, Institutional Ethical Committee clearance obtained. Inclusion criteria, patient giving consent, patient who received both surgical and medical treatment and discharged asymptomatically with recurrence at no site, patients with radiological evidence of recurrence of mucomicosis. Excluded, patients with negative consent, patients close to follow-up or succumbed to death. Data collection, written informed consent, a detailed history taking, ear, nose, throat and neck examination, endoscopy, KH, C-reactive protein, RBS, monitoring or HbA1c, radiological, MRI or CBCT. My research where our study group comprises of 160 follow-up cases of CAM, in which 21 patients had recurrence, 18 males and 3 females. The patients aged between 50 to 60 years were the most common affected and least affected were between 30 to 40 years. In the post-surgery follow-up, 67% of cases were having poorly controlled diabetes and 86% showed increasing trend of CRP that is greater than 5 mg per deciliter. Endoscopic follow-up was done in all patients. Findings such as yellow or extensive crushing, foul-smelling discharge, and any fungal debris were considered suspicious of recurrence. 81% of patients showed these findings in endoscopy. The first MRI showed disease in nasal cavity and paranasal sinuses in 20 patients with black turbinate sign, 2 patients involving pterygopalatine fat stranding, and 2 patients with intracranial extension. Orbital involvement was seen in 5 patients. The second MRI showed involvement of PPF or infratemporal fossa in 13 patients, orbital involvement in 7 patients, intracranial extension was seen in 9 patients, suspicion of erosions of bones such as maxilla in 16 patients. CBCT showed recurrence. Common site was maxilla 47%, followed by paranasal sinus 32%. 38% showed recurrence in MRI and 61.9% detected recurrence in CBCT. Discussion. The most significant aspect in dealing with CAM patients is the recurrent disease. We followed a protocol to follow up with endoscopy, CRP, RBS or HbA1c. Patients in whom endoscopy showed suspicion of recurrence, rising trend in TRP, uncontrolled diabetes were further evaluated using radiological investigations. We did MRI paranasal sinus or bit brain with T2 weighted gadolinium enhanced or CCT-PNS depending on the symptoms and CBCT in 19 patients. Though bone involvement cannot be fully evaluated by MRI, 30% showed suspicious of bone erosion. In such cases, and when patient refused MRI due to financial or personal reasons, CBCT was used as a cheaper alternative. CBCT comparatively recent scanning technology in dentistry, which was equivalent to CBT at reduced cost and radiation doses. Though maxillary necrosis occurs rarely compared to the mandible due to its high vascular supply, in our study, most common site of CAM recurrence was maxilla alveolus. That may be due to the necrosis of the greater palatine artery in CAM patients. The extent of surgery we did was PSC. 12 patients underwent total maxillectomy, 19 patients underwent endoscopic debridement. Disease. Foramen rotundum was affected in 7 patients. Greater wing was deceased and drilling done. Medial and lateral pterygoid plates were removed. Median nerve deceased and removed. Posterior bony part of septum pale and deceased. Blind eye includes 6 patients. Medial and inferior orbital bone removed and lamina propria explored. Intracranial extension was seen in 3 patients. Then, small disease was removed. Small defect in skull base covered with temporalis fascia and nasal mucosa in 1 patient. They were kept under neurosurgery follow-up. Probable causes of recurrence may be presence of disease in proximity to inaccessible vital structures, which was not dealt with. Unreported radiology investigation, CBC was just the initial line of investigation, which had bone involvement. Patient overlooked the symptoms, especially pain, confusing it with dental pain presented late to us, immunosuppression, uncontrolled diabetes, and inadequate antifungal therapy. All post-operative patients were subjected to regular saline irrigation, antifungals, regular nasal endoscopic examination with suction clearance, amphotericin-based the drug therapy of mucomicosis. CBCT, which was most bony recurrences, were MRA, whereas MRA detected disease in soft tissue. Since in the present study, alveolus was detected as the most common site of recurrence, CBCT was more effective. All the cases were given a total dose of 5 grams per person. Thus, I conclude, mucomicosis is an invasive fungal disease. COVID patients in whom immunological status was altered, diabetes, or immunocompromised patients should be kept under surveillance by endoscopic CP and blood sugar monitoring. Though CAM patients with surgery antifungals should be under regular follow-up for more than 6 months. Diabetes control has been with the spread of CAM. Suspected cases should undergo radiological investigation like MRI and CBCT. Recurrent or residual disease of mucomicosis can be tackled and treated successfully. These were my references. Thank you.
Thank you so much, Dr. Lakshmi. It was a beautiful presentation. Now, I would like to request the next candidate, Dr. Mayur V. Kabade, to please be ready. Your presentation will be displayed shortly.
Very good morning, everyone. Today, my topic for paper presentation is prevalence of hypokalemia in a patients of post-COVID-19 mucormycosis receiving injection liposomal amphotericin B at a tertiary care hospital. Coming to introduction, hypokalemia is one of the most common electrolyte disturbances seen in clinical practice. The guidance for mucormycosis strongly supports early complete surgical treatment in addition to adequate systemic antifungal treatments. Debridement should be as radical as possible. There may be requirement of revision surgery in some patients. The antifungal drug of choice is liposomal amphotericin B. Liposomal amphotericin B has a potential to cause some adverse events such as renal dysfunction, serum potassium abnormalities, that is hypokalemia. Methods. I have conducted this study as a retrospective study on 100 patients of post-COVID-19 mucormycosis who have received liposomal amphotericin B for the first time between May 2021 to August 2021. It was conducted at Department of ENT NSB Medical College, Jabalpur. Objective of this study were to evaluate prevalence of hypokalemia in patients of post-COVID-19 mucormycosis receiving injection liposomal amphotericin B and to evaluate common presenting symptoms of hypokalemia in them. Inclusion and exclusion criteria. All the patients were diagnosed who were diagnosed with COVID-19 associated mucormycosis were included in the study. And the patients who were having historical symptoms and allergic rhinosinusitis were kept apart from the study. Data collection. Data of 100 patients from the IPD records were reviewed for the following demographic data, that is dose of liposomal amphotericin B at which patient developed initial symptoms of hypokalemia, presenting symptoms of hypokalemia. These were recorded and analyzed with the help of SPSS software for the Windows. Coming to results, prevalence of hypokalemia. Out of the 100 patients included in the study, 23 patients developed hypokalemia, of which 21 patients were having symptoms and 2 were asymptomatic. Age distribution of the patients. Out of 23 patients who developed hypokalemia, majority of belong to middle age group. Coming to sex distribution of patients with hypokalemia, among 23 patients, 17 patients were male and rest were females. Severity of hypokalemia, 11 patients out of 23 developed mild hypokalemia, 11 patients developed moderate hypokalemia, and while only 1 patient developed with manifested with severe hypokalemia. Those at which hypokalemia manifested is most of the patients develop symptoms of hypokalemia in less than 2 grams of liposomal amphotericin B, while in the rest hypokalemia occurred after administration of more than 2 grams of liposomal amphotericin B. Presenting symptoms, majority of the patients who develop hypokalemia presented with generalized weakness, anorexia, muscle cramp, followed by nausea, which is seen in 82% patients, constipation, bloating, abdominal pain were being the other presenting symptoms. Coming to discussion, liposomal amphotericin B possesses broad spectrum antifungal activity, and it is the first line indication against unconfirmed fungal infection in empirical therapy. Competitive studies with other antifungal drugs have demonstrated the efficacy of liposomal amphotericin B. Liposomal amphotericin B induced renal dysfunction and serum potassium abnormality appear to result from a combination of glomerular ischemia and tubular toxicity. The incidence of hypokalemia in patients treated with liposomal amphotericin B was reported as 36% by Ringden and 51.3% by Sunakawa in 2012. While in the present study, hypokalemia of varying grades occurred in 23% of the patients, making an adverse event that requires an attention. To the date, 3 retrospective univariate and multivariate analysis demonstrated that older age, higher dose, diuretics, vasopressors, concomitant nephrotoxins were risk factors for liposomal amphotericin B induced nephrotoxicity and electrolyte imbalances. In the present study, hypokalemia is reported in middle-aged adults, more in males compared to females, and at doses less than 2 grams of liposomal amphotericin. The consequences of acute and chronic hypokalemia include muscle weakness, palpitations, cardiac dysrhythmias, and worsening of diabetic control. It also includes polyuria. Coming to cardiac changes, it causes early T wave flattening, STT depression, U wave, while prolongation of QU or QT interval. In the present study, majority of the patients of mucormycosis develop hypokalemia, presented with generalized weakness, anorexia, muscle cramps, followed by nausea, constipation, and abdominal pain. Management of hypokalemia. If the hypokalemia is due to depletion of potassium, a potassium deficit of 10% of the total body potassium stores is expected every 1 milliequivalent per liter decrease in the serum potassium. Solution for replacement is potassium chloride. It should be transfused at the rate of 20 milliequivalents of potassium in 100 ml of isotonic saline and infuse this mixture over 1 hour. If normally patients serum potassium may be slow to rise, full replacement usually takes few days, particularly if potassium losses are ongoing. If the hypokalemia seems refractory to replacement therapy, the serum magnesium levels should be checked. Magnesium depletion promotes urinary potassium losses and causes refractory hypokalemia. In present study, patients with mild hypokalemia were treated with oral potassium supplementation, that is potassium chloride oral solution, that is known as pot-chlor, while those with moderate and severe hypokalemia were treated with intravenous KCl. If there is hypomagnesemia, the standard intravenous preparation is magnesium sulfate. Coming to conclusion, hypokalemia is a common electrolyte disorder occurring in patients receiving liposomal amphotericin B, which if undetected can be life-threatening. In all patients receiving liposomal amphotericin B administration, serum potassium should be monitored right from day 1. Also, this patient can develop hypomagnesemia, which should be monitored. Invasive opportunistic fungal infections are a serious cause of morbidity and mortality in these patients. Therefore, adequate medical management of these patients not only requires proper antifungal administration, but also management of electrolyte imbalance. It be used judiciously and with utmost care. These are my references. Thank you everyone for patiently.
Thank you so much, Dr. Mayur Kabade. It was a beautiful presentation. Now, I would like to request the next candidate, Dr. Steffi Maria Tom, to kindly be ready. Your presentation will be displayed shortly. Dr. Steffi, your presentation has been displayed. Kindly start.
Good morning, everyone. I'm Dr. Steffi Mariato. I'm going to present on the topic Factors Contributing to Poor Outcome in COVID-Associated Mucormycosis. Mucormycosis is an uncommon but a fatal fungal infection that usually affects patients with altered immunity. It includes uncontrolled diabetes mellitus with or without DKA, organ transplantation, corticosteroid therapy, iron overload, etc. Mucor genus, which include Rhizopus, Mucor, and Rhizomucor, in which Rhizopus or Rhizae is the most common type and responsible for nearly 60% of mucormycosis and 90% of ROCM. Mode of contamination occurs through the inhalation of fungal spores. Mucormycosis can involve nose, GIT, and other system. It ranges from sinonasal tissue invasion to progression into orbit and also into CNS. This occurred in the Delta variant epidemic of coronavirus in India. It prompted us to conduct a systematic review of deaths in mucormycosis to know its temporal association in relation to comorbidities and the overall characteristics of patients with its outcome. Coming to methods, this is a retrospective study which conducted over 21 deaths out of 140 mucormycosis patients in a tertiary care center. Patients who were diagnosed to have mucormycosis got admitted in the hospital. Death occurred within the hospital stay were included in the study. Coming to results, the study was based on the data of 21 deaths. In this study, 19 patients were post-COVID and 2 were COVID positive at the time of admission. Most of the deaths occurred in the age group above 70 years. 15 out of 21 patients received oxygen supplementation and 17 received steroid supplementation. 20 were males and 1 were female. Blood sugar levels, 13 had above RBS above 300 milligram per deciliter and 8 had less than 300. The CRP value ranged between 1.33 and 200, PTNR between 0.99 and 1.3. Serum electrolytes were almost normal in 18 patients and 3 patients had electrolyte imbalance. According to CT-MRI findings, 12 had pansinusitis, 3 had pansinusitis with orbital cellulitis, 5 had pansinusitis with cavernous sinus thrombosis, 1 along had mandibular osteomyelitis. All patients had diabetes mellitus, in which 5 had both diabetes and hypertension. Out of 21 patients who succumbed to mucormycosis, 13 were fit for surgery and were operated, and 8 were critically ill. Coming to preoperative deaths, these patients, in spite of being supplemented with 8 to 10 liters of oxygen, were not able to maintain oxygen saturation above 75 to 80%, hence surgery could not be done. Out of these 8, 2 were intubated at the time of admission and unconscious. They were found to be COVID positive and developed signs and symptoms of mucormycosis while they were on oxygen supplementation. Sample collected from the nasal cavity of these patients and sent for fungal biopsy and KOH. It was positive for mucormycosis. They were managed with IV amphotericin B. Most of these deaths were the patients who presented with advanced disease and were unconscious at the time of admission. Lung functions were compromised in these patients. In spite of all the rigorous medical management, these 8 patients succumbed to death. The immediate cause of death in these patients were respiratory failure, sepsis, shock, and leading to cardiorespiratory failure, which was a terminal event. Post-operative deaths, the patients who were already on 8 to 10 liters of oxygen pre-operatively, when they were able to sustain without oxygen, were taken for surgery. Depending on the clinical condition, they were operated endoscopically and open surgery was done. They were kept on oxygen for 2 to 3 days immediate post-operative period. Out of 13, 10 underwent endoscopic debridement, 2 underwent unilateral maxillectomy, and 1 underwent hemimandibulectomy. Blood sugars and diabetic ketoacidosis were monitored and controlled. During the immediate post-operative period, they developed decrease in oxygen saturation and was intubated and started on noradrenaline. RFT were deranged in these patients, hence amphotericin B was stopped in these patients. 1 patient developed resistant hypokalemia, which was not responding to correction by injection potassium chloride. 2 patients had hyponatremia. Out of 13 operated patients, 1 patient had systemic mucormycosis with right parotid involvement along with nasal and orbital involvement. These patients' general condition was poor at the time of admission. Blood sugars were controlled. Extensive endoscopic debridement of nasal cavity. Infratemporal fossa and right frontal lobe was done. Right parotid abscess was drained. However, he could not survive more than 3 days post-operatively. 1 patient had developed hepatitis post-operatively, and this was suspected to have pulmonary mucormycosis. Sputum sent for KOH and was positive for broad non-septate fungi. 2 out of 13 operated patients developed unusual complaint of loose stools of over 12 episodes per day and abdominal distension which could not be controlled by medication. These patients succumbed to death within a day. Challenges: most of the mucormycosis patients were presented to the department at the advanced stage with comorbidities like diabetes mellitus and cardiac failure. An intensive multidisciplinary approach was done in the department. Most of the patients received 150 to 200 mg of amphotericin B per day. The time duration between admission of the patient and getting operated ranges from 1 to 5 days, depending on the deranged clinical parameters. 119 patients were successfully treated from the center. These are tabular form of cause of preoperative death, immediate post-op death, and delayed post-op death. Coming to conclusion, mucormycosis is a fatal fungal infection which led to death of many patients among the COVID pandemic. Multiple causes were found to be associated with deaths. There was sepsis, respiratory failure, cardiorespiratory failure, dyselectrolemia, systemic mucormycosis, and cavernous sinus thrombosis. Hemoptysis, loose stools were alarming signs of the systemic mucormycosis, which, if ignored, may lead to death of the patient. Early diagnosis, prompt treatment of comorbidities, and immediate surgical debridement prevents death in mucormycosis patients. There are many undetermined underlying factors which influence the treatment modalities in the management of mucormycosis patients. These are my references. Thank you.
Thank you so much, Dr. Steffi. It was a beautiful presentation. Judges, kindly excuse us for just 2 minutes. We will need there's a little glitch. Kindly excuse us for 2 minutes.
There's one more presentation pending.
Yes, sir. There's one more presentation
Sure.
pending.
No issues. Sure.
There's a little glitch in the PPT display. Just a second, sir.
Sure. Take your time, please. Take your time.
Dr. Anjali, your presentation has been displayed. You can start.
Good morning, everyone. I am Dr. Anjali. My topic is comparative study of the different types of fungal organisms identified using KOH mount test in post-COVID mucormycosis patients in a tertiary care center. First, introduction. Mucormycosis has been long recognized as a permanent, life-threatening disease belonging to mucorales. It may present in many forms, which include rhino-orbitocerebral, pulmonary, cutaneous, and gastrointestinal disease. Early diagnosis is the key to management. Nasal endoscopy with biopsy and swabs for KOH mount and fungal culture are the most economical and easily available tools for diagnosis. The mucormycosis is caused by species of Rhizopus, mucor, and Absidia. The other opportunistic fungal infections reported in COVID-19 patients are oropharyngeal candidiasis and respiratory tract aspergillosis. KOH mount is a simple, rapid, inexpensive test to perform which requires minimum infrastructure. Direct microscopy of the fresh tissue sample with KOH helps in identifying the fungus and is of utmost importance as early treatment with antifungals can prevent a fatal outcome. Aims and objectives: to find the different types of fungal organisms identified using KOH mount test, to assess the efficacy of KOH mount as a diagnostic tool in mucormycosis, to calculate the percentage of fungal organisms associated with mucormycosis, to evaluate the diagnostic validity, performance, and accuracy of KOH mount in detection of mucormycosis.
Materials and methods. It's a comparative study. A total of 145 cases admitted in ENT department following sinusitis during June to July 2021. Nasal endoscopy was done in all cases. FES or endoscopic debridement was done. The operated specimen was labeled and sent to lab in normal saline for fungal microscopy and KOH. Specimen was placed on a slide and a drop of 20% KOH was added. Cover slip applied and incubation done for 2 hours. KOH degrades keratin, which allows better visualization of fungal structures. The slides are microscopically then evaluated. The percentage of different organisms that are detected during KOH mount was calculated. Broad aseptate to sparsely septate wide-angled branching fungal hyphae were considered belonging to mucorales. Thin septate acute angled branching fungal hyphae were suggestive of aspergillus. The observations and results were expressed in means and percentages. Inclusion criteria. All clinically diagnosed cases, patients who are suspected for mucormycosis, patient who had history of COVID infection presenting with symptoms of sinusitis, patients giving consent for study, exclusion criteria, patients who already were treated with antifungals, and patients not giving consent for study. Results. Of the 145 patients examined, 94 of them showed no growth, 54 of them showed mucormycosis, and only 19 of them showed aspergillus. Conclusion. Out of 145 patients whose KOH mount were examined, 36% showed mucormycosis, 10% showed aspergillus, and 54% showed no growth. The results were compared with HPR of the patients, which showed high false negatives associated with KOH mount examination. Limitations are the small sample size. Results may vary depending upon the method of collection and preparation of specimen. The efficacy of the test must be confirmed using other diagnosis tests like HPR, PA, staining, and fungal culture. High chances of laboratory contamination, and there are also very high reported false negatives associated with KOH examination. Discussion. Mucormycosis is a fatal infection requiring multidisciplinary approach. Uncontrolled diabetes is the main predisposing factor. Early diagnosis, reversal of comorbidities, aggressive medical and surgical management is vital in managing this aggressive disease. It is necessary to confirm the clinical diagnosis with sufficient laboratory evidence due to side effects and cost associated with antifungal drugs. KOH mount examination, though inexpensive and cost-effective, can show high false negatives. There is need for alternative tests like HPR, fungal culture, PAS for the confirmation of diagnosis. In our hospital, all patients received IV liposomal amphotericin B and had undergone radical debridement of involved sciences. These are my references, and thank you everyone for patient listening.
Thank you so much, Dr. Anjali Krishna. It was a beautiful presentation. With this, we are concluding the Renuka Brado session. I would like to extend my heartiest thanks to the chairpersons for chairing this session. I would like to request Dr. VP Narvi sir and Dr. Anil Jain sir. Sorry, I would like to request Dr. VP Narve sir and Dr. Anil Jain sir to kindly send the marks allotted to the candidates of this session to Dr. Kavita Sachdeva ma'am. And once again, I would like to thank Dr. VP Narve sir and Dr. Anil Jain sir for chairing this session. Thank you so much, sir. Now,
thank you for giving this opportunity, and heartiest congratulations to Dr. Kavita madam and the team for conducting such a wonderful conference. Thank you.
Thank you so much, sir. Your kind words has lifted our spirits, sir. Thank you so much. Now, I would like to start and announce with the next session, the Dr. Renuka Brado session 2. Now, I would like to welcome the chairpersons of this session. The first chairperson, Dr. Sachdeva is a professor and HOD of Medical College in Netaji Subhash Chandra Bose Medical College, Jabalpur. She has a teaching experience of 18 years and her field of interests are otology. I extend heartiest welcome to you, ma'am. The next chairperson of this session is Dr. Vikas Gupta sir. Dr. Vikas Gupta sir is additional professor AIIMS Bhopal. He has a teaching experience of 13 years and his fields of interest are head and neck, cochlear implantation and otology, neurotology and skull-based surgeries. Sir, I welcome you to this session. Thank you so much for chairing this session. I would like to request the candidates to please be ready.
Thank you.
The first candidate for this session is Dr. Dipankar Chandrakapure. Dr. Dipankar Chandrakapure, kindly be ready. Your presentation will be displayed shortly.
Laptop? Right. Right. So we have Dr. Vikas Gupta from AIIMS and myself chairing the session. Now, Diksha, you can share the screen and you can share the CV of Dr. Vikas Gupta.
She has done that, I think.
Dr. Vikas Gupta sir has come? Yes.
Yeah,
he's
ma'am.
there. Right, right. Okay.
Yes.
Good morning.
Good morning,
So,
ma'am.
I
think, ma'am, we can go ahead. She has.
Right. Okay. Start it. Dipankar, next candidate can start the session.
Start. Dr. Dipankar, your presentation, kindly start the presentation. Dr. Dipankar Chandrakapure, your presentation has been displayed. Kindly start with the presentation.
Thank you. Thank you. Good afternoon, everyone. My presentation is for today's paper is challenges in administration of drug posaconazole during epidemic of COVID-associated mucormycosis in tertiary care center. My aim to evaluate the challenges in administration of drug posaconazole in a tertiary care or epidemic. Objective to compare the different forms of drug posaconazole, to compare the different way of administrating drug posaconazole with their advantages and disadvantages, to assess the side effects of drug posaconazole. Posaconazole is a novel lipophilic azole antifungal agent. It exhibits potent and broad spectrum antifungal activity. It actives against majority of yeast and filamentous fungi, especially in immunocompromised patients, and as a salvage therapy in patients with invasive fungal infections. Two routes of administration, oral route as well as intravenous route, indicated in patients of 18 years of age and above. Dosage form available are oral suspension 40 mg per ml. Dose is 400 mg twice a available in 100 mg, 300 mg, also in gastro-resistant form. Dose in loading dose of 300 mg twice a day on first day, then 300 mg once a day thereafter. Route is oral administration. Injection 300 mg per 16.7 ml. Loading dose is 300 mg intravenously twice a day on first day with maintenance dose of 300 mg once a day from second day onwards. IV administration of drug posaconazole, it is administered via a central venous line by slow intravenous infusion over approximately 90 minutes. If a central venous catheter is not available, posaconazole injection may be administered through a peripheral venous catheter by a slow intravenous infusion over 30 minutes only as a single dose in advance of the central venous line placement. When multiple dosing is required, the infusion should be done via central venous line. Never administer posaconazole injection as an intravenous bolus injection. The spike in mucormycosis along with the shortage of antifungal drugs pose a challenge to the healthcare system of our country. With the shortage of amphotericin B, posaconazole was used as a next alternative. This is a prospective observational study was done on the mucormycosis in NSCB Medical College from between May 21 to October 2021. Inclusion criteria: patients receiving drug posaconazole giving consent for the study and consent for the central line insertion. Exclusion criteria: with patients with renal and hepatic parameters. Results: out of 110 patients who received posaconazole injection via peripheral venous line, 72 developed adverse drug reaction, in which the maximum patients were in age group of 51 to 60 years of age. The adverse reactions were thrombophlebitis, fever, chills, headache, vomiting, sweating, stomach pain, diarrhea, retrosternal pain, erythematous skin lesion. Main reasons for discontinuation of injection posaconazole via peripheral line were thrombophlebitis associated with persistent edema and pain, along with retrosternal pain and stomach pain. 7 patients gave consent, following which injection posaconazole were administered via central venous line. It is well tolerated when given via central venous line, so that we were able to give them the drug for 10 days till the amphotericin B injection become available. Following are the drug reactions. On first day, 7 patients had 1 episodes of low-grade fever within 24 hours. 4 patients had chills and rigor. 1 patient developed erythematous skin lesion on the skin of thin leg, thigh, leg, arms after 7 days. The posaconazole oral suspension and delayed release tablet were approved for patients aged 18 years of age and above following administration of 300 milligram of posaconazole concentrate for solution of infusion over 90 minutes. Mean peak plasma concentration the end of infusion was 3280 nanogram per ml. In the present study, posaconazole injection had been administered to 110 patients, in which adverse drug reaction developed in 72 patients, majority of the patients in age group of 50 to 60 years. All patients who received IV posaconazole through central venous line doesn't show thrombophlebitis and better tolerated by the patients. Fever was the most common short-term side effects. Post-discharge, patients were advised for oral posaconazole tablets at least for 1 month. None of them shows any physical adverse side effects or deranged hepatic or renal profile on follow-up. Studies suggested that the posaconazole attains higher serum level during the treatment when administered through intravenous route as compared with the oral route. Limitation of studies, study of non-willing of the patient to give consent for the central line insertion, requirement of sufficient trained healthcare professionals, anesthetists, and limitation of resources in government tertiary care hospitals. Conclusion: different forms of drugs showing different adverse reactions, such as the male culprit is the adjuvants used for making different forms of posaconazole. Intravenous posaconazole most preferably given via central venous line than peripheral line, especially if the ratio of healthcare provider to the patient is good. It is difficult during the time of epidemic-like situation. Intravenous posaconazole is better than oral posaconazole in immediate post-op period to prevent recurrence or extension of the disease. Oral posaconazole can be given in discharged patient as maintenance without much side effects and well tolerability, given hepatic and renal functions monitored regularly. Thank you. These are my references. Thank you very much.
Thank you so much, Dr. Dipankar. It was a beautiful presentation. Now, next candidate, Dr. Manan Jhawar, to please be ready. Your presentation will be displayed shortly.
Good morning. Am I audible?
Yes, you are audible.
Yes. Thank you.
Okay, Dr. Manan, your presentation has been displayed. Kindly start with your presentation.
The title of my presentation is to assess the role of blood sugar monitoring in patients developing mucormycosis under the guidance of Dr. V.R. Munjal, sir. Next slide. Introduction. Next slide, please. Yes. Mucormycosis is an unusual and potentially lethally invasive fungal infection that most commonly affects diabetic and other immunocompromised individuals. It has high morbidity and mortality rate. Furthermore, it is a very rapidly spreading infection, and even a minor delay in the diagnosis can be very lethal. COVID-19 associated mucormycosis has been documented more frequently recently, more notably among cases with uncontrolled diabetes. Next slide. Next slide, please. In other fungal diseases, impairment with the immune system is the most important predisposing factor to these fungal infections. Most commonly, the immunocompromised patients, like patients with diabetes mellitus, hematological diseases like leukemia or lymphoma, IV drug abuse, or cytotoxic therapy are more prone to develop this disease. Other studies have also reported diabetes mellitus as a predisposing factor to mucormycosis in at least 36 to 88% of the cases. Next slide, please. Next slide, please. Besides the classical complications of the disease, diabetes has been associated with to reduce the response in T cell neutrophil function and responsible for disorders of the humoral immunity. Consequently, diabetes increases the susceptibility to infections by most common microbial pathogens and fungi. Next slide, please. Such infections, along with their repercussions, may trigger diabetes complications like hypoglycemia and ketoacidosis. As the prevalence of diabetes is increasing, the risk of this deadly infection is also dramatically increasing. In our study, we assessed the random blood sugars level in the patients who developed mucormycosis in order to find its association and prevent the development of progression of the disease. Next slide, please. Aims and objectives of our study. First, to evaluate the role of blood sugars in patients developing mucormycosis. Second, to identify the improvement and recovery of mucormycosis patients after sugar monitoring and early management. Next slide. Methodology. Around 63 patients who developed mucormycosis were collected between April to October 2021 from the Department of ENT of SAMES. A proper clinical history was taken and sugar levels were assessed, and based on that the patients were classified as non-diabetic, newly onset diabetic, diabetes mellitus with controlled sugars, and diabetes with uncontrolled sugars. They were assessed according to the American Diabetic Association criteria. Next slide, please. This slide has the definition of all the criteria. Next slide, please. Latest random blood sugars were taken at the time of enrollment into the study. The patients had developed mucormycosis, were admitted, started on IV antibiotics, and sugar monitoring was done on regular basis. After stabilizing the patient, they were posted for endoscopic debridement after clearance from medicine, ophthal, OMFS, and PAC checkup. And after the surgery, the patients were medically managed by IV liposomal amphotericin B and posaconazole. Next slide, please. This is a clinical pathway depicting the same. The patient, from when the patient presented to us till the time when the patient got discharged or was uneventfully transferred. Next slide, please. Findings of and the discussion. In us, as I told, 63 patients were taken and classified according to the ADA criteria. Increased synthesis of advanced glycation end products, AGEs, and pro-inflammatory cytokines, as well as oxidative stress, are all promoted by hyperglycemia and insulin resistance, in addition to increasing the development of addition molecules that mediate tissue inflammation. Next slide, please. These are pictures of patients who were with us with uncontrolled diabetes mellitus, newly onset diabetes, and controlled diabetes mellitus. Next slide, please. The inflammatory process could be the underlying mechanism that cause a higher proclivity for infections and worse outcomes for diabetic people. The most prevalent predisposing factor for inocerebral mucormycosis is diabetes mellitus. Other studies also showed the same. Next slide, please. Result: out of 63 patients, 45 were from diabetes with uncontrolled sugars, while 14 were diabetes, newly onset diabetes. 2 were diabetes with controlled sugars, and 2 were from non-diabetic. So 10 out of 63 patients had mortality. Please, previous slide only. And all of these were from diabetes with uncontrolled sugars, while the other three criteria showed very good response and good recovery. Next slide, please. Conclusion: our study highlights correcting the practice of monitoring blood sugar and its management. It was found that our practice of monitoring blood sugars was in line with that of the ADA. Next slide, please. Corrective action. Regular collaboration with medicine and TB chest department was done for taking nasal swabs and sugar management in high risk or clinically suspected patients of COVID-19 and mucormycosis. Early radiological assessments were made. A protocol for patients who were highly suspicious, like those in which nasal swabs came positive for fungal hyphae or those whose sugars were very high. A CT-PNS was done on early basis for these patients. Next slide, please. Preventive action. Early diagnosis and early monitoring is the key in preventing development of mucormycosis in patients, and judicious steroid usage is recommended in those of patients with COVID-19. Sensitization of staff, doctors, and administration for the same, and creating awareness in the patients as well, so as to make them present early to the health facilities. The next 3 slides are those of my references. Thank you so much.
Thank you so much, Dr. Manan.
Thank you.
Okay, now I would like to request the next candidate, Dr. Rakhi, to please be ready. We will be displaying your presentation shortly. Rakhi. Dr. Rakhi. Okay. Dr. Rakhi, your presentation has been displayed. Kindly start with your presentation.
Very good morning to one and all. I am Dr. Rakhi Kaushik, second year postgraduate student, Department of ENT, MGMMC, Indore. I am hereby presenting my paper on topic rhino-orbital cerebral mucormycosis and epidemic clinico-pathological picture management and its outcome. Next slide, please. Next slide. Introduction. Rhino-orbital cerebral mucormycosis is an emerging angioinvasive of the mucorales order of the class Zygomycetes. Factors associated with increase in COVID-19 patient include diabetes, steroid overdose, high iron levels, and immunosuppression combined with other possible factors such as prolonged hospitalization, use of ventilators, and leaky humidified oxygen. Next slide, please. The disease originated in the nasal sinus mucosa after inhalation of fungal spores and take a rapid progression course of neighboring tissues, including the orbit and brain. Histopathology is considered as the gold standard for diagnosis. New formulation of amphotericin B, like liposomal amphotericin B, is successful in the management of mucormycosis. Posaconazole may also be effective in mucormycosis patients who are refractory or intolerant to liposomal amphotericin B, including kidney impairment patients. Next slide, please. Aims and objective to study the clinical and demographic profile of patients diagnosed with rhino-orbital cerebral mucormycosis and to determine the importance of early medical as well as surgical management of patients with cerebral mucormycosis. Next slide. Materials and method. In the study, we took 500 patients for duration of 4 months from April 2021 to July 2021 at a study center, MGMMC and MI Hospital Indore. It is a prospective observational study. Study subjects are patients presented to the OPD of Department of ENT or Emergency Department of MI Hospital with complaints suggestive of mucormycosis, include facial symptoms like unilateral or bilateral facial pain, facial hypoesthesia, nasal symptoms like foul smelling, nasal discharge, nasal obstruction, bleeding from nose, orbital symptoms like periorbital pain, orbital swelling, and neurological symptoms like headache. In all patients, we have done diagnostic nasal endoscopy using 0° 4 mm nasal endoscope, CT and gadolinium enhanced MRI, PNS, orbit, and brain was done. The medical treatment using injection amphotericin B was given for 21 days, followed by tablet posaconazole for next 21 days. Surgical debridement was done in anesthetically fit patients. Next slide. Inclusion criteria: patient from age of 20 to 90 years presenting with symptoms of mucormycosis such as nasal symptoms or vital symptoms, palatal involvement, neurological symptoms, and were diagnosed with mucormycosis on basis of clinical features, diagnostic nasal endoscopy, radiology, and microbiological investigations. Exclusion criteria are patients below age of 20 years and above 90 years, patient not giving consent for this study, and patient of non-invasive sinusitis with chronic history of rhinosinusitis in whom definitive diagnosis of mucormycosis was not made. Next slide, please. Here are some pictures showing clinical presentation of mucormycosis with facial periorbital swelling, with palatal necrosis, with facial swelling, and with facial paralysis also. Next slide, please. These are some pictures of diagnostic nasal endoscopic finding, which showing the thick purulent secretions in choana, and the last picture showing the necrosis of the middle turbinate. Next slide. Along with the diagnostic nasal endoscopic findings and clinical presentation of patients, these are the radiological findings. Previous slide. Here are the results. According to our study, we found that out of 500 patients, there was male predominant in cases of mucormycosis. Out of 500, there were 341 males and 159 females. Next slide, please. Age distribution: 41 to 50 years of age group shows maximum prevalence of mucormycosis, and second comes 51 to 60 years of age group. 20 to 30 years of age group and 61 to 70 years of age group shows 9% of prevalence, and above 70 years there were only 4.5%. Next slide.
Ma'am, your presentation is about to end. Please come. Time is about to end, ma'am. Please conclude fast. Thank you, ma'am.
Yes. Yes. Conclusion state. We have concluded in a study that early diagnosis and early aggressive surgical debridement with concurrent antifungal treatment has limited the morbidity and mortality of the disease to a greater extent. In other words, surgical treatment associated with antifungal improves prognosis. At a minimum, patient should have resolution of radiographic signs of active disease on serial imaging, with the possible exception of radiographic findings which are thought to be result of post-inflammatory or post-operative scar formation. A multidisciplinary management offers a better approach to treat this life-threatening condition. Proper history of underlying systemic disease associated with the disease reduces the mortality and morbidity rate associated with the debilitating disease. Last two slides are my reference. Thank you.
Thank you so much. The presentation was really beautiful. I would like to call upon the next candidate, Dr. Sriharsha Gupta. Your presentation will be shared shortly.
Hello.
Dr. Shivanshu, your presentation has been displayed. Please start. Your time starts now. Thank you.
Good morning, everyone. Myself, Dr. Sriharsha Gupta. Today, I am going to present a paper on the topic Mucormycosis in COVID era, the role of nasal endoscopy. Next slide. Next slide. COVID-19 is an infectious disease caused by a novel severe acute respiratory syndrome affecting more than 20 million people in India. A wide range of bacterial and fungal co-infection may exist and may be associated with pre-existing morbidity. Additionally, the widespread use of steroids and monoclonal antibodies against the COVID-19 may lead to the development or exacerbation of the pre-existing fungal disease. During COVID-19 pandemic, the prevalence of the rhino-orbital cerebral mucormycosis is on the rise, probably due to the systemic immune alterations due to the COVID infection. There are various diagnostic modalities for the diagnosis of mucor infection. Nasal endoscopy in these cases is important diagnostics tool. Next. Next slide. Here we describe the approach for the management of the disease based on the nasal endoscopy that optimize the line, time, and appropriate management of the people in this epidemic. Aims and objective: to study the clinical profile of the patient with signs and symptoms of mucormycosis, timely and appropriate recognition of mucormycosis to help reduce morbidity and mortality, especially during the pandemic. Next slide. Materials method. There were total 150 number patients. Study duration was April 2021 to June 2021. The study type: prospective study. Study center: Department of ENT, MGM Medical College, and MY Hospital, Indore. All patients were subject to the nasal endoscopy and were classified into 5 categories. Then the patients were subjected to radiological and blood investigation and were taken for tests with nasal cavity development. And the tissue specimen were sent for histopathological examination in operated patient. Next slide. Inclusion criteria. These include the patient between 20 to 90 years of age, patient with or without the COVID-19 infection, patient with symptoms of the mucormycosis, patient with comorbidities like the diabetes and hypertension. Exclusion criteria: patients having benign and malignant lesion of the nasal cavity, patients of mucormycosis operated for first prior to study. So we developed a unique endoscopic classification system to segregate and triage the patient based on the nasal endoscopic findings. Next slide. Group A patients include a normal nasal mucosa. Group B includes the patient having congested and edematous nasal mucosa. Group C include the patients having thick purulent secretions in middle meatus and choana. Group D include the patients having blackening of nasal mucosa. Group E include the patients having black necrotic scar tissue with purulent exudates. Next slide, please. Next slide. Age results. Age distribution of the study population. In 20 to 30 years of age group, there were 6 patients. In 31 to 40, there were 16 patients. In 41 to 50 age group, there were 46 patients. In 51 to 60 years of age, there were 40 patients. In 61 to 70 years of age, there were 30 patients. In 71 to 80, there were 10 patients. In 81 to 90, there were 2 patients. Next slide. So as we can see, the maximum number of patients were in the age group of 41 to 50 years of age, followed by the 51 to 60, and then 61 to 70 years of age group. Next slide. Sex distribution. Out of the total population, which were studied, 74.7% were the male and 22.3% were the female, which basically correspond to the 3:1 ratio. Nasal endoscopic classification system. In group A, there were 3 patients. In group B, there were 63 patients. In group C, there were 43 patients. In group D, there were 25 patients. In group E, there were 16 patients. So we can see there maximum number of patients were in group B, followed by group C. Next slide. Based on the eye and palate involvement, the isolated eye involvement, there were in 20.7% of the population. In isolated palate involvement, there were 10.7% of the patient, and both eye and palate involvement, there were in 10.7% of the population. Maximum eye involvement, isolated eye involvement, was seen in group D patients, and maximum palate involvement was seen in group E patient, and both eye and palate involvement maximum was seen in group E patient. Next slide, please. In 81.3% of the patients were post-COVID infected one, and 18.7% were the non-COVID patient. Next slide. Next slide, please. 54% of the patient were have past history of diabetes mellitus. 34.7% of the patients were newly diagnosed diabetes mellitus post-COVID-19 infection, and 11.3% of the patient were have no history of diabetes mellitus. Based on the nasal endoscopic finding and MRI findings, 110 patients, which roughly correspond to 73.3% population, have maxillary sinus involvement. 62% patients have involving ethmoid sinus, 43.3% involved sphenoid sinus, and 20% patient involved frontal sinus. Next slide. Nasal endoscopy in the operated patient. In group A, none of the patients were operated, and in group B, 25.5% of patients were operated. In group C, 39.5% of patients were operated, and group D and E, all patients were operated. Next slide. So to conclude, we can say that the most common comorbidity associated with mucormycosis were diabetes mellitus. Out of 150 patients, roughly 122 were infected with COVID-19 and 28 were non-COVID patients. So does the COVID-19 infection, diabetes mellitus, and the mucormycosis, these forms are deadly, trio, and need early and effective management. So based on the grading system which we used, patients were then subjected to FES and nasal cavity debridement. In group E and D, all patients were operated. Group E, the patients were discharged. In group B and C, 25.54% and 39.5% patients were operated. So in this epidemic, this grading system makes the management of the large number of patients easier. Appropriate time, treatment, and resources can be given to the required patients. Next slide. Next slide. These are my references. Thank you.
Presentation. Thank you, Dr. Shivanshu, for your presentation. This is the end of Renuka Brada session 2. We thank the chairpersons, Dr. Kavita Sachdeva ma'am, HOD NSCB Medical College, Dr. Vikas Gupta, HOD AIMS Bhopal, for their chairing this session and your kind-hearted cooperation. Thank you so much, ma'am and sir. We are now starting our Dr. Hiranandani head and neck session. The chairpersons for this session are Dr. Yashveer JK, Associate Professor and Secretary AOI MP State Branch, Dr. Surendra Mapochi, HOD SSMC Riva.
I would like to thank Dr. Vikas Gupta for chairing the session. Diksha, mention that, and you have to give marks out of 10.
Dr. Vikas Gupta, please share your marks to Dr. Kavita Sachdeva ma'am.
I have shared marks.
Thank you, sir. Thank you so much. Next, the chairperson for the next Dr. Hiranandani head and neck session, Dr. Yashveer JK and Dr. Surendra Mapochi. Dr. Surendra Singh Mapochi, MSc ENT NSCB Jabalpur MP. He is Professor and HOD Department of Otorhinolaryngology and Head and Neck Surgery, SMC Medical College, Rewa, Madhya Pradesh. Sir had teaching experience of 15 years and attended about 4 conferences, CME and seminars. He has also contributed for many surgical workshops and hands-on surgeries. Dr. Yashveer JK, sir is an Associate Professor, Secretary of AOI MP State Branch. We invite both Dr. Yashveer sir and Dr. Surendra sir for chairing this session. I invite first candidate, Dr. Shobit Yadav, to present the slides.
Am I audible?
Yes, you are audible. Just a few seconds. We are sharing your presentation. Dr. Shobit Yadav, you can proceed with your presentation.
Under the guidance of Dr. Brajen Base, Director and Professor of Department of ENT SAMES, I'm going to present a case, endoscopic Cooperator assisted intraoral excision of large parapharyngeal space. Introduction. Previous slide, please. Parapharyngeal space tumors are rare and account for around 0.5% of head and neck tumors, and of these tumors, around 80% are benign. And the most frequent parapharyngeal space tumor is salivary neoplasm, followed by a neurogenic tumor. Salivary neoplasm in PPS, particularly the pleomorphic adenomas, are the most common lesion in the pre-styloid space, whereas the paragangliomas and schwannomas are the most common in the post-styloid space. Multiple surgical approaches have been seen for the parapharyngeal space and has been described for the tumor resection, and the choice of surgical approaches depend on the tumor size, location, its proximity to the important neurovascular structures. Next slide. Of the varying surgical approaches, approach has been the most criticized when compared to the well-established transcervical approaches, and this has been attributed to inadequate exposure leading to reportedly increasing rates of major vessels and nerve injuries when compared to the transcervical approaches. So we have endoscopic transoral resection of the tumor is one of the approaches, and the use of 0-degree and angled rigid endoscope allows a better and broader view of the surgical field. And here we present a case of large parapharyngeal tumor. The patient successfully underwent endoscopic cooperator assisted intraoral resection of the tumor without the transcervical incision or mandibulectomy, and with the aim of comparing the various approaches in this field. Next slide. As a case detail, there was a presented with in onset and progressive in nature, and the swelling over the right side parotid region since 3 weeks. There was no history of dysphagia, dyspnea, and change in voice, no history of oral fullness and reduced hearing, no history of epistaxis, nasal blockage, any nasal discharge. There was no involvement of any cranial nerve at present, and there was no and there was a history of tonsillectomy 16 years ago. Next slide. Next slide, please. Here are the clinical pictures of the oral cavity showing the right-sided intraoral swelling of the size around 5 by 5 centimeter across the soft palate, extending in the right tonsillar fossa, and present with the deviation of uvula towards the left due to the mass effect. And there was no pain or tenderness or palpation by the movement of neck. And over the neck, there is a non-tender swelling present of size of 2 into 1 centimeter in parotid region, which was formed to hard on palpation, and there were no lymph node palpable. Facial nerve was intact and no nystagmus was present, gag reflex was present, and other systemic examination was unremarkable. And FNAC was suggestive of the pleomorphic adenoma. Over CCT neck, it was suggestive of enhancing lobulated soft tissue density lesion over the right parapharyngeal space and masticator space along the deep segment of the right parotid gland of around 4.8 into 5.3 into 4.8 centimeter. And the lesion is causing moderate compression on the right lateral wall of nasopharynx, right medial pterygoid muscle, submandibular gland, distal right cervical, ICA, ECA, IGV, styloid process, right lateral pterygoid plate, and there were few subcentimetric lymph nodes are seen at the level of level 2 region, averaging size of 8 to 10 mm. Next slide. Here are the CT scans, CT scans showing the growth over the right parapharyngeal space and the masticator space. Next slide. Here are other level, axial, and other views showing the same tumor. Next slide. The diagnosis was pleomorphic adenoma of the minor salivary gland. Previous slide. Minor salivary gland of the right parapharyngeal space, and there was a plan to do the endoscopic cooperator assisted intraoral excision of the parapharyngeal space tumor under GA. And the 1 unit of blood was arranged as a pre-op with the consent of blood transfusion, tracheostomy, post-op ICU ventilator, conversion of the transoral approach into endoscopic into an open approach. And after the PEC clearance, the patient was taken for the surgery under GA. And the patient was taken for surgery under GA with nasotracheal intubation since it affords maximal exposure of the oropharynx and greater freedom of the transoral instrument. And nasotracheal intubation also allows for a full closure of the mouth to enable transcervical exposure if needed. Next slide. With a rose position, after a proper exposure of the oral cavity by using Boyle Davis gag with a tongue blade, a linear vertical incision was made with cooperator at the palatoglossal fold extending into superiorly between hard and the soft palate. Under direct endoscopic visualization, further dissection was done. Next slide. After identifying the capsule of the mass, carefully blunt dissection around the tumor was performed to release the facial attachment of the tumor with the cooperator, and care was taken not to rupture it. And with an advantage of sensory feedback and ability to adjust pressure, blunt dissection can be performed with gentle finger dissection, and careful identification of great vessel was done. Next slide. Tumor was delivered out and hemostasis was achieved. After ensuring there was no residual tumor, the pharyngotomy was repaired in layer with 30 vicryl lapid, and an area of around 1 centimeter of inferior portion of incision was left open to allow the gravity-dependent egress of the fluid from the wound. And the procedure was completed uneventfully Post-op care. Patient kept intubated overnight on spontaneous mechanical ventilation support in ICU. RT feed was started after 6 hours and patient was extubated next morning. On a histopath, the section shows capsulated tumor composed of dilated hyperplastic acinar line by epithelial and myothelial cells suggestive of pleomorphic adenoma. Next slide.
Your time is about to end. Kindly conclude fast. Kindly conclude fast. Thank you.
So traditionally, surgeons were considering transoral route to the parapharyngeal space as poor and unsafe, but with advent of video-assisted endoscopic assistance, transoral route provides direct and magnified visualization. Large tumors like this usually necessitate a combined approach like mandibular sewing with lipset, but the tumor was surgically excised by attempting a transoral approach by assessing the lateral wall of parapharyngeal space to avoid further complication. And the tumor was successfully debulked by the blunt dissection transoral. Thank you.
Thank you, Dr. Shobit, for your presentation. It was a nice presentation. Next candidate, I welcome Dr. Suryakant Sharma.
Yes, ma'am.
Presentation.
Hello. Hello.
मैं तुमसे ये पूछा था नौकरी वोकरी का क्या कैसा रहेगा बोलते हैं अरे ये समस्या है ही नहीं आपके जीवन में आप इस पे क्यों इतना विचार कर रही है बोलते हैं कि चैमिना कहाँ जाना चाहिए
Kindly share my slide.
उसमें लिखा भी है एक लाइन सरकारी
Yes. Can you hear me? I am Dr.
Yes, yes, you are audible. You are audible. We'll be sharing soon. Okay, Dr. Suryakant Sharma, you may proceed.
Slide should be कीजिए please. And then first slide. Good morning, everyone. Under the guidance of Dr. Sudhakar Vaid, Professor and Head Adhikari Medical College, today I present a paper on comparative clinico-pathological study of ultrasonography, fine needle aspiration cytology, and histopathology in diagnosis of various neck swelling. Next slide, please. Next. Diagnosis is not the end, but the beginning of the practices. Swellings and lumps in the neck are a very common clinical problems. Patients presenting with the neck swelling are likely to be fearful that they have some tumors. Neck lumps in children are common, although rarely malignant and commonly more congenital or benign, but the situation is quite different in adults. Evaluation of the patient in the ENT clinic begins with a careful detailed history, socioeconomic status, dietary status, and taking into account first the age of the patient and second whether the swelling is in the lateral, posterior, or anterior compartment of the neck. Thus, the need is the utilization of less invasive, cost-effective, and time-saving methods of diagnosis without resorting to a more painful and invasive surgical biopsy. The modality should also be acceptable to the patient accuracy, easy to apply, reproducible, and must not need too much preparation. Next slide, please. This study is proposed to evaluate the accuracy of ultrasonography and fine needle aspiration cytology in the diagnosis of newly detected clinically probable neck lumps in the comparison to the final histopathological reports of the biopsied specimen. Next slide, please. Aims and objectives. Number one, to study the clinical picture of the various disease presenting as neck swelling, to know the relationship with socioeconomic status, including variable like age, sex, occupation, and various habits of the disease presenting as swelling in the neck. To compare the diagnostic role of the ultrasonography of neck, fine needle aspiration cytology from swelling of the neck, histopathological study. Correlate their findings in the diagnosis of various neck swelling. Next slide, please. Inclusion criteria, patient of all ages and gender with neck lumps and swellings. Only those patients whose ultrasonography, fine needle aspiration cytology, and histopathological examination has been done. If it is a acute or chronic inflammatory lesion of the lymph node on fine needle aspiration cytology, then appropriate antimicrobial therapy will be given for 3 weeks. If it does not settle, then biopsy will be taken and sent for histological examination. In thyroid and salivary gland lesion, wide excisional biopsy is mandatory because it is the only treatment available in the most of the cases. In benign cases of neck like lipoma and fibroma, patient will require wide excision of the neck masses and histopathological examination of the excite lesion is mandatory. In case of thyroiditis and sialadenitis, appropriate treatment will be given and histopathological examination will be done if fine needle aspiration cytology is doubtful or inconclusive. If the fine needle aspiration cytology of the neck lesion comes out to be malignant, then biopsy will be taken from the drainage area of the lymph node in head and neck. Next slide, please. Next slide, please. Exclusion criteria. Patient coming with neck abscess or open infected wounds. A patient who underwent FNAC but did not undergo subsequent histopathological examination and other advised investigation. Next slide, please. Materials and method study by done on 100 cases of neck swelling of both sexes and of all age group. Source of data. Data for the study will be collected from the patient coming in the Department of Otorhinolaryngology at Adigadi Medical College, Ujjain. Sampling procedure. A pre-designed proforma will be used to record the relevant information, patient data, clinical findings, investigation reports from the individual patient selected with inclusion and exclusion criteria. Next slide, please. Study design. A prospective study, study period 2 years. Methodology. The patient will be selected consecutively as and when they are presented during the study period, considering the inclusion and exclusion criteria. Next slide, please. Ultrasonography imaging. After provisional diagnosis, patients were subjected to radiological imaging. The following features were considered in the describing the sonographic images of swelling in accordance with Simju et al. 82. Shape of swelling: oval, lobular, round, polygonal, irregular. Boundaries of swelling: very clear, relatively clear, partially unclear, ill-defined. Echogenicity: anoic, asechoic, hypoechoic, and hyperechoic. Ultrasound architecture of the lesion: homogeneous, heterogeneous. Presence of necrosis: eccentric, central. Presence of calcification: macrocalcification, microcalcification. Posterior echoes: enhanced, unchanged, attenuated. Ultrasound characteristic of the tissue: cystic, solid, or mixed. Next slide, please. Fine needle aspiration cytology. All the smear were examined systematically for the following: cellularity, scanty, adequate or rich. Background of the smear: presence of the inflammatory cells, blood necrosis. Detailed study of the cytomorphology of the cell population. Then histological examination. Histology is an area of science where art and science collide. Normal patterning of the tissue and artifact resulting from the tissue preparation process ensure that each histological section is unique. Next slide, please. Observations and result. Maximum number of patients in our study were in the age group of 21 to 30 years, 26%. And
Dr. Surikant, sir, your time is about to end. Please conclude fast.
Out of our 100 patients of neck swelling, 43% were male and 57% were female. With UAG in the age group less than 30 years, there were 47 neck swelling, out of which 4 were thyroid swelling, 21 lymph nodes, 5 salivary gland, and 70 miscellaneous swelling. In the age group greater than 30 years, 53 neck swelling were noted, out of which 30 reported as thyroid swelling, 10 lymph nodes, 3 salivary gland, and 10 miscellaneous. Inference: it signifies that with advancing age, there were more cases of the neck swelling as per USG report. In next slide, please.
Thank you. Thank you, sir. Your time is completed. Thank you very much for your beautiful presentation. Thank you, sir.
Thank you, Dr. Sriharsha Sharma.
पता नहीं इतनी देर से मैं भी नहीं देख रही ना, वो माखन भी आ गया, पता नहीं शायद नहीं हुआ होगा अभी। उसका क्या टॉपिक था कितना का? कंट्रोल। सोने ओ
Dr. Krishna, you may present your slide now.
Thank you, ma'am. Good afternoon, everyone. Myself, Dr. Krishna Valecha, second year PG student. I am going to present my paper on the topic foreign bodies in upper aerodigestive tract, our analysis and experience under the guidance of Dr. Jagram Verma sir, Associate Professor at MJ Medical College, Indore. Next. Next slide, please. Foreign body ingestion and aspiration are common childhood adverse events, hence are the commonest cause of morbidity and mortality in infants and children worldwide. They are the third leading cause of death in children under the age of 1 year and fourth leading cause in the age group of 1 to 6 years. The maximum prevalence is seen between the ages 1 and 2 years. Hence, it is important to develop a comprehensive approach to the early recognition as well as timely management of aspirated and ingested foreign bodies, as complications from delayed diagnosis can have significant health implications. The aim of my study is to study the role of clinical examination as well as radiological investigations in the diagnosis of foreign body in upper aerodigestive tract, also to study the plan of management of foreign bodies in upper aerodigestive tract. The present study is a prospective observational study which was carried out in the Department of ENT at MJ Medical College at Indore during January to December 2021. It is a prospective study carried out on 52 patients diagnosed as cases of foreign body in upper airway or digestive tract based on their detailed history, physical examination, and necessary investigations. All the cases with the provisional diagnosis of foreign body ingestion underwent radiological investigation. Appropriate procedure was followed for the removal of foreign body and the patients were observed post-operatively for complications and relief. We found that the maximum incidence of foreign body was present in the age group of 0 to 10 years. This result was also comparable with the other study done by the Mundra et al., where they also find the same incidence. Cricopharynx was the most common site of impaction of esophageal foreign body, constituting 95.55%. In the airway, right bronchus was the most common site of foreign body lodgement, and left main bronchus was involved in 20% cases. Please change the slide. Please change the slide. Next. Next. Please change the slide. Next.
Ma'am, this is the slide. This is the slide you want, or the next slide?
Next slide, please. I've studied till results. Please check out the results. Results, previous slide. Okay. In our study, we found that the maximum incidence was found in 0 to 10 years of age group. This result was comparable with the other studies also. Next. Cricopharynx was the most common site of impaction of esophageal foreign bodies, constituting 95.55%. In the airway, right bronchus was the common site of foreign body lodgement, and left main bronchus was involved only in 20% cases. Next slide, please. In our study, coins were the most common foreign bodies of digestive tract, seen in 90% of cases. Other foreign bodies we retrieved are as shown in these figures. Next. Next. Coming on the symptoms and signs, definitive history of foreign body aspiration was obtained in 70% of cases. The commonest symptom of presentation was choking and dyspnea, followed by coughing and sneezing. Majority of the cases presented with tachypnea, 80%, followed by decreased air entry on affected site in 7 cases. Stridor was noticed in half of the patients, and bronchi and crepitations were seen in 40% of cases. Intercostal and subcostal retractions were seen in 30% of cases. Next slide, please. Coming on the radiology part, coins were the most common radio-opaque foreign body seen in upper digestive tract. Dentures, rings, lockets, pins were also other radio-opaque objects. Thus, 95.56 foreign body ingestion cases were confirmed radiologically. Atelectasis was the common radiological evidence of foreign bodies in the airway. The other radiological changes included pneumonia, obstructive emphysema, and similar findings were seen in other cases. Next slide, please. 16 emergency bronchoscopies were done with successful removal. There was one case in which no foreign body was present. Some unusual cases were also there in which iron nail was found in the left main bronchus. 3 patients post-operative had bronchospasm which were managed with the oxygenation, nebulization, and steroids. Next slide, please. This is the picture showing 0-degree pediatric telescopic view in which metallic foreign body is seen, and on the left the foreign body which was retrieved from the left main bronchus is shown as foreign body LED bulb. Next, there was a iron nail which was removed using optical forceps and its picture. Next slide, please. So I conclude that the tracheobronchial foreign body aspiration is a serious and potentially fatal condition, especially when occurring in a small children. Foreign body aspiration should be strongly suspected in children presenting with the history of choking episodes or with the persistent or recurrent pulmonary infections, and without any delay, bronchoscopic evaluation should be done. Thank you. Next slide, please. These are my references. Thank you.
Thank you, Dr. Krishna Velecha, for your presentation. It was a nice presentation. Good afternoon, everyone. Now we are stopping for 15 minutes for the inaugural ceremony. We'll be projecting the inaugural ceremony soon in this screen. Please all cooperate.
Chandran?
Sharing.
I want to see the follow.
Good morning, everybody. Let us all begin this inaugural ceremony with lamp lighting. I would like to request respected Acting Dean Dr. Siddiqui sir and our new superintendent sir Dr. Arvind sir and respected HOD ma'am to begin this inaugural ceremony with lamp lighting.
देखो वो inauguration functions.
Please start this session. Please start.
ऑनलाइन स्टार्ट हो जाएगा
Just screen sharing.
सरस्वती भगवती शेष जात्या
सबको वॉट के लिए वेलकम करेंगे
थैंक यू अमृता
Yes, sir, I believe Thank you so much, respected Secretary sir and Dr. Arvind Sharma sir and HOD ma'am. Now, I would and welcome Dr. City sir. I would like to and Dr. Ritu ma'am. I would like to request Dr. Kavita Sachdeva ma'am to kindly Dr. Siddiqui sir. Thank you so much for gracing this occasion. Now, I would like to request HOD ma'am to please greet Dr. Arvind Sharma sir, our new superintendent sir. Thank you so much, sir. Now, I would like to request ma'am to greet Sethi sir. Thank you so much, sir, for being here and gracing this occasion. We welcome Dr. Ritu ma'am. Thank you so much, ma'am. Thank you so much. Thank you so much, HOD ma'am. Now we are starting with the with the speech. I would like to request Dr. Kavita Sachdeva ma'am to please grace this occasion and say a little few words for lifting our spirits.
स्टार्ट करके मेरा वीडियो चल रहा है माय वीडियो इज कमिंग काजल you just tilted take it vertical yes पूरा vertical horizontal telecast so respected dean sir Dr. Siddiqui our superintendent Dr. Arvind Sharma sir Dr. Ritu HOD medicine Dr. Sethi HOD anesthesia my respected teachers, fellow faculty surgeons. It is indeed that practice has played a pivotal role in sharing knowledge and research, especially it gives new horizons to consultants. This also can help in to treat the way. These aims are achieved ENT, and this has done enormous work in field of ENT and has brought Madhya Pradesh in national map of ENT. So I congratulate Dr. S.P. Dubey sir. He has been a past president and editor of Indian Journal of Otolaryngology. So we provide the Lifetime Achievement Award to Dr. S.P. Dubey sir. Heartiest congratulations, sir. Dubey sir. Now the next thank you is Dr. Namdev, Ellen Namdev sir. Special Achievement Award to Namdev sir. He has done a enormous work as an editor of Indian Journal of Otolaryngology, and twice he has been an editor. So I congratulate Ellen Namdev sir for
Thank you, madam. Thank you.
so we for this certificate.
Thank you. Thank you, madam.
Next, I would really like to felicitate Dr. Vikas Gupta from AIMS. नहीं हो रहा है ना? हो रहा है मैम, हो रहा है. From AIMS Bhopal for adding for the post of editor of Indian Journal of Otolaryngology. Now, annually, AOI MP chapter, so I congratulate all of them. Annually, AOI MP chapter facilitates and awards best performing candidate. So this year, I am happy to announce gold medal, MS ENT gold medal, which is in the name of Dr. H.H. Khan. So Dr. H.H. Khan Memorial MS ENT Topper Gold Medal Award to Dr. Surbhi from Ujjain Medical College. Congratulations, Dr. Vaidya. We are having Dr. Sabia Khan, and we welcome Sabia. She is daughter of Dr. H.H. Khan. He was also a great ENT surgeon of his time. And thank you, Sabia, for everything. Now, the second award is Dr. J.K. Sharma Sir Award, that is for ENT pre-final achiever of maximum marks in ENT. So this award we will be announcing soon, as we have not yet received our results of pre-final ENT from MP MSU. I am very thankful when this pandemic was going. And PG teaching was affected adversely. That time, a young otologist took initiative to bring PG education online by bringing together the best teachers on platform. Dr. Sriharsha Tikka and his team took this big project of spreading knowledge of ENT. They helped us to conduct many online teaching sessions. So a token of acknowledgement to Dr. Sriharsha Tikka also, and I'm very thankful for him to helping us to conduct this e-conference. Our conference is incomplete without our senior teacher, artist, Dr. Pagare sir, who hosts quiz by making all the questions interesting by his personalized slide. Thanks to Dr. Nishant sir's son to help us out. I appreciate all HOD chairperson for their effort and participation, all my colleagues in various medical college who helped us to carry out this program. I am thankful to Dean Dr. Siddiqui sir, Superintendent Dr. Sharma sir, Dr. Sethi sir for his constant support, and I am thankful to all the HODs of ENT. My in-depth thanks to all my ENT group team, Dr. Anirudh, Dr. Mahmooda, and all my PGs. Thank you. Why it was not clear that the slide क्यों
Respected HOD ma'am, for the kind words and the appreciation. This really lifted our spirits up.
I think he was.
Kindly give us 5 minutes to fix a little glitch in the software. Just 5 minutes. Please be patient. I would like to request either Dr.
I welcome all the superintendent of the college, Dr. Ayushi Gupta, Honorable Head of the Department of Anesthesiology, Dr. Gupta, Head of the Department of Medicine, and the backbone behind this particular event, Head of the Department of ENT, Dr. Kavita, whose endless pursuit and effort had led to see this particular event see the light of the day. I also congratulate Dr. Vikas, daughter of the well-known ENT surgeon, who has been not been knowing state cabinet minister in health education, as far as I remember. For bestowing a gold medal for this college student, and this will be an event to cherish for those who deserve it and those who get the gold medal. I suppose this year we didn't have the result delivered. I don't know the name of the recipient, but sooner or later this will be delivered on time to one of the recipients who has achieved the highest marks in ENT. Yes. Yeah, it's a undergraduate level. I also congratulate all my faculty of the ENT, Dr. Mahmooda, Dr. Ayushi Gupta, and all the PGs present over here, and all the ENT colleagues of this Jabalpur town for sparing their valuable time and gracing the occasion. In the end, I also congratulate all the PGs of the department who tireless work have seen. And I suppose this is an online event which is going on. So I also welcome and congratulate all the participants of this online event. And I thank Dr. Kavita for inviting me to grace this occasion. Thank you.
Thank you for coming, sir.
Thank you. Thank you so much, sir. Thank you for coming and gracing this occasion with your presence. And your words have inspired us a lot. Now, I would kindly request Superintendent Sir, Dr. Arvind Sharma, sir, to please come and say a few words to inspire us.
ये वीडियो वहाँ भी है क्या? उसको पेन ड्राइव में कॉपी करो, मुझे यहाँ बचा रहे हैं, वहाँ से हम शेयर करवा देते हैं।
Dean Dr. Siddiqui sir present, and Dr. Sethi sir, and Dr. Ritu, and Dr. Kavita, HOD. Thank you to all for this, and I congratulate to all and for participation, and welcome all participants in this e-conference, and welcome to all. Thank you.
Thank you so much, sir. Now, Dean sir could not be with us physically here, so we have a recorded message of Dean sir, and I would very happy like to play a message from the Dean desk. थैंक यू सो मच सर, आपके इन उत्साहित करने वाले शब्दों ने हमारा मनोबल बढ़ाया है। मैं डॉक्टर यशवीर सर से रिक्वेस्ट करूंगी कि वो एक वोट ऑफ थैंक्स प्लीज हम लोग को, सब लोग को, श्रोतागणों को दें।
He is AOI Secretary MP.
He is the AOI Secretary of the MP and Associate Professor in GMC Bhopal. We welcome you, sir.
ये बंद कर दो। कर लिया, एकदम। उनको स्केयर शेयर, उनको वो बनाना पड़ेगा ना, वीडियो ऑन करके वो बोलें।
Dean NSCB Medical College, Dr. Kasar sir, and also the Superintendent, Dr. Arvind sir, for taking time and inaugurating our MPE academic conference. I also thank Dr. Kavita Madam, HOD ENT Jabalpur, also President AOI MP Chapter, for taking so much of pains and efforts to make this e-conference a successful one.
Sir, sorry to interrupt, sir. Sir, sorry to interrupt, sir.
Head of the department.
Sir, you are not audible, sir. आपकी
which
आवाज
has
नहीं आ रही है, sir.
wave, so it was unpredicted. नहीं जा रहा।
ऑडियो का इशू आ रहा है।
जी सर, आ रही आवाज। Thank you, sir.
Make a quick adjustment to do an online conference and give benefit for the passing out postgraduates for this academic year. So next academic year, we are planning to do an offline conference. so that a better physical conference can be done. So thank you everyone who have contributed for this conference.
Thank you so much, sir.
Good afternoon, everyone. Welcome back. We will be continuing our sessions. Next is Dr. Hiranandani session में Dr. Ankita Kujur. She will be presenting her presentation. I welcome Dr. Yashveer sir and Dr. Surendra sir for chairing this session and to continue the session.
Good afternoon. I'm Dr.
Ankita
Ankita.
Kujur.
Hello. Yeah. Yes.
You
Hello?
may proceed with this.
Okay. Good afternoon. I'm Dr. Ankita Kujur, and I'm here to speak on accidental cutthroat injuries and its management at tertiary center. Cutthroat injuries are neck traumas, which are mostly homicidal, suicidal, and rarely accidental. Cutthroat injuries can be lacerated wounds or injury incised wounds, which may be superficial or deep. And if those are not treated on time, may lead to morbidity and mortality. Next slide, please. It is a life-threatening condition because of increased risk of injury to the vital structures which are present in such a small and confined area. It can cause injury to greater vessels, which can lead to profuse hemorrhage, shock, air embolism, or aspirated blood or surrounding tissue edema can lead to asphyxia and airway obstruction. Next slide, please. Aims and objective of the study was to understand the clinical profile of the patient with neck trauma and to study cause, type, pattern of injuries, and their consequences. Next slide, please. This study was carried out in MG Medical College Department of ENT. Study period was 1 year from October 2020 till 2021. In this study, four people were included. Data were categorized according to name, age, sex, address, mechanism of injury, cause of injury, site of injury, hospital arrival delay, duration of hospital stay, treatment given, and final outcome of the patient. Next slide, please. Etiology and factors for cutthroat injuries. Out of 4 patients, injury to 3 were caused due to road traffic accident, and one was from fall from height. Next slide, please. Severity of cutthroat injury. Out of those 4 patients, skin, soft tissue, and platysma was injured in 4 patients, whereas the larynx and hypopharynx was injured in only 1 patient. Trachea was involved in 3 cases, and thyroid gland and vessel was injured in 1 patient. Next slide, please. On the basis of anatomical zone of injury, 4 patients sustained injury in the zone 2, whereas no patients sustained injury in zone 1 or zone 3. Next slide, please. Surgical treatment methods. In 4 patients, wound debridement and repair was done, whereas tracheostomy was performed in all of the patients. Laryngeal and hyperpharyngeal repair was done in one patient, and there were no patients in simple repair was done. Next slide, please. Talking about the results. Post-op ward stay of all the patients were uneventful, and all improved in follow-up with one complaining of alteration in voice. No complaint or difficulty in breathing, neck mobility, limitation or difficulty in swallowing. Outcomes were better in patients who presented early to the emergency, and days of hospital stay were reduced accordingly. One patient stayed for less than 10 days, whereas one patient stayed for more than 21 days, and two patients were there in the hospital for 13 to 14 days. Next slide, please. As I said earlier, patients who attended emergency early and were repaired within 24 hours. In all those patients, treatment outcome were better. Major neck vessels and vital structures that goes through this area make these injuries potentially life-threatening. Such injuries have airway compromise. Investigations which we did was X-ray of neck, chest, CT neck, digital subtraction assay. Poor communication, inadequate first aid knowledge and facilities, and lack of skilled manpower were responsible for delayed presentation to the hospital. An evaluation always should start with ATLS ABC to secure the airway, and tracheostomy was done when needed. Next slide, please. Talking of the first case, he was a 25-year male admitted in Department of ENT AOI with chief complaint of cut throat injury. He sustained injury due to artery in which wound was 12 into 5 into 4 centimeter. In this patient, laryngopharynx was transected completely at the level of glottis. Wound was repaired and tracheostomy was done inferior to it. Next slide, please. This patient, 40-year male, was admitted in our department who sustained injury of 3.5 into 2 into 1 centimeter at the level of precut cartilage. In this, tracheostomy was done and wound repair was also done. Intraoperant of 2 millimeter was found at precotracheal joint and it was left to heal conservatively. Later, this patient developed leptospirosis and dengue and was further managed by the medicine department. Next slide, please. This 40-year male patient presented with cutthroat injury in emergency department who sustained 3 into 1 into 1 incised wound at the level of thyroid cartilage. In this patient, wound was repaired and airway was secured with tracheostomy. Next slide, please. 28 male year patient admitted in Department of ENT sustained injury of 5 into 2 into 2 and in which minor vessels were injured and the surrounding tissues became edematous. Wound was repaired and vessels were ligated and tracheostomy was done.
सर मुझे मेरी पेन ड्राइव चाहिए थी काजल के हाथ से भेज देंगे हाँ जी
Post of management, voice rest was advised, adequate humidification was given along with antibiotics and anti-reflux medications. Post-operatively, 3 patients were ventilated for at least 72 hours with tracheostomy in C2, Ryle's tube in C2 and Foley's catheter in C2. Regular suction, cleaning and dressing of tracheostomy tube was done. Patients were kept NBM for at least 4 to 5 days, gradually starting peritubal feed and then oral feeds. Tracheostomy tube was removed and the patient was decannulated after 2 weeks. With a good quality of life and ability to swallow, patients were discharged home 3 weeks within admission. Intravenous fluids and antibiotics were regularly given and vitals were monitored. Surgery in earlier phase resulted in shorter stay in hospital. Tracheostomy is a reliable method for reverting the progression of emphysema. Small tracheal ruptures can be managed non-surgically. Clinical examination and investigation played an important role to detect injuries to these structures. Laryngeal stenosis was the worst complication which was observed in one patient, and physiological state is more stable and might aid the overall healing. Unlike throat injury causes due to homicide and suicidal cause, patient supplementary needs can be managed with Ryle's tube feeding, and post-operative endoscopy can help in identifying nerve injury and stenosis, laryngotracheal stenosis. Thank you.
Thank you so much. Thank you so much, Dr. Anushka. Now, I would like to request Dr. Aditya Goyal. Dr. Aditya Goyal, please be ready. Your presentation will be displayed shortly.
Good afternoon, everyone.
Dr. Aditya,
Myself, Dr.
you can begin. Your presentation has been shared.
Thank you. Good afternoon, myself, Dr. Aditya Goel, postgraduate third year student, GMC Bhopal, is presenting a paper
Dr.
entitled
Aditya, am I
Correlation of
audible?
Extra. Yes. Hello.
Dr. Aditya?
Yes.
Dr. Aditya, we are not able to hear you. Kindly check your connections. As this is the last participant of the PG paper session, Dr. Aditya, kindly check your connection and please respond.
Hello. Can...
But we are able to
Hello.
hear him.
No, you are not audible. Please unmute your mic. You have been muted, I think.
Yeah. No. I have unmuted it. Can you hear me now?
Yes, we can hear you. You can go ahead.
Yes, we can hear. Yeah. Okay. So good afternoon, everyone. Myself, Dr. Aditya Goel, postgraduate third year student, presenting a paper on correlation of extrapulmonary tuberculosis and head and
Aditya,
neck
your
lesion.
video is visible, but you are not audible.
HIV/AIDS
I
patient
think there is some
on the
problem
basis
in
of
your end, madam. Because other people can hear him.
Yes, we can hear. I think there is some problem at the host mic.
Dr. Aditya, we are trying to contact you. Your video is visible, but your audio is not clear.
आप audible नहीं हो, आपको वीडियो आ रहा है, audible नहीं हो. वीडियो वॉइस नहीं आ रही है आपकी. वॉइस नहीं आ रही.
We can hear it. I think there is some problem at the level of host.
अरे तो मुझे काम करना.
बाकी लोग बाकी जगह आ रहा है ऐसे बोल रहे हैं.
Can you hear now?
Yes.
Yes, Aditya, we can hear you. Continue.
Thank you. Introduction. Human immunodeficiency virus. It is a retrovirus which previous slide which goes into human genome, incorporates with it and multiplies. It is said as an immunodeficiency virus because it decreases the patient's immunity and thus causing an acquired immunodeficiency syndrome. CD4 plus cell counts, which are responsible for body immunity, they are mildly decreased by this virus, and thus leaving our body prone to various pathogens like commensals and various extrinsic pathogens, causing opportunistic infections. Most common among the opportunistic infections is the tuberculosis, and nowadays extrapulmonary tuberculosis is on the rise rather than the pulmonary. Next slide, please. Next slide, please. Next. Aim of the study is to determine the association of CD4 plus cells count with head and neck extrapulmonary tuberculosis and opportunistic infection in AIDS patient. And second aim is the improvement in the quality of life of a patient taking combined antiretroviral therapy as well as the anti-tubercular therapy. Next slide, please. Methodology. It is a retrospective analysis conducted in a tertiary center Department of Otorhinolaryngology and Head and Neck Surgery. A total of 50 patients were studied for a period of 1 year. Confirmed cases of AIDS with extrapulmonary tuberculosis and head and neck lesions were studied, keeping all the ethical issues in mind. My inclusion criteria was patients having confirmed acquired immunodeficiency syndrome, patient diagnosed with extrapulmonary tuberculosis of head and neck lesion. My exclusion criteria were patients having only tuberculosis without any history of HIV, and patients having extrapulmonary tuberculosis other than the head and neck lesion, and patients having other opportunistic infections anywhere other than the head and neck. Next slide, please. After taking a detailed history of a patient in complete ear, nose, throat examinations, patients were asked for some specific tests like sputum for CB0, ultrasonography whole neck, chest X-ray, AP view, and CD4 plus cells count. CD4 plus cells count of the patients were noted at the time interval of 3 months, 6 months, and 12 months, and statistical test was applied to the observations and results were made. Next slide, please. Coming to the observations and results, According to this, the age group, in my observations, the maximum populations were from 20 to 40 years of age. In the occupations, were like businessman, driver, housewife, farmer, and among the male, most common occupation was driver, and among females, most common were housewife. Extrapulmonary tuberculosis, most commonly it was the cervical lymph nodes. And CD4 plus cell counts at the time of diagnosis, more than approximately 60% patients have more than 500 cells per mm3, and 40% patients have less than 500 cells per mm3. So remark is that patients with less number of CD4 cell counts are more prone for the apoptotic infections, and patients with more number of CD4 cell counts, that is more than 500, are less prone. CD4 plus cell count after the treatment is it is increased in 85% of cases post highly active antiretroviral therapy and anti-tubercular therapy. And quality of life, 78% of cases were resolved, seeing the sputum negativity of the CBNR. Next slide, please. This is the image showing the necrotic cervical lymph nodes, and the other image showing the burst neck node involving in the HIV/AIDS patient. Next slide, please. So coming to the discussions, according to our study and comparing to the other studies, there's a table showing the cervical tuberculosis is the most common type of extrapulmonary tuberculosis in PLHA patients. Next, other table is showing the incidence of extrapulmonary tuberculosis with the number of CD4 cell counts. Here, two studies are showing there is a less incidence of extrapulmonary tuberculosis in patients having CD4 cell counts at the rate of 500 to 1000 cells, and patients having CD4 cell counts less than 500, they are more prone. Next slide, please. Next slide. Next slide, please. There's another table showing the change in the CD4 cell counts after the combined therapy, and all the studies, previous studies, along with my studies, our study is showing the increase in the CD4 plus cell counts on the combined therapy of antiretroviral therapy plus anti-tubercular therapy. Here the other table showing the extrapulmonary tuberculosis resolution. Extrapulmonary tuberculosis resolution is on the basis of CBNAT negativity, and out of 50 patients, 43 patients extrapulmonary tuberculosis was resolved and the CBNAT was negative. Next, please. So summarizing is in our study, most common type of extrapulmonary tuberculosis head and neck lesion is cervical tuberculosis. There is a positive association between number of CD4 cells and the incidence of extrapulmonary tuberculosis. After combined therapy of anti-retroviral therapy and anti-tubercular therapy, number of CD4 cells count increase and thus decreasing the prevalence of extrapulmonary tuberculosis. Next slide, please. In concluding at the end, take home messages. It is important to do CD4 cell counts at the time of diagnosis so the disease prevalence is known and high risk population can be monitored. It is best to start anti-tubercular therapy along with highly active antiretroviral therapy as soon as possible and as soon as the diagnosis of the extrapulmonary tuberculosis to get the better outcome and improvement in quality of life. Previous slide, please. And serial monitoring of CD4 plus cell count is important to see the disease progression. Thank you.
Thank you. Thank you, Dr. Aditya. This is the end of PG paper session. We are proceeding with consultant paper session. We thank Dr. Yeshveer JK sir and Dr. Surendra sir for chairing the session. Thank you, sir and ma'am. Thank you, sir. Kindly share your marks to Dr. Kavita Sachdeva ma'am as soon as possible, sir. Thank you.
Now, as scheduled, SR paper has to be done, but we are postponing it, and the consultant paper will be starting soon. And thereafter, the SR paper will be starting. So, I would like to request the chairpersons of the consultant paper to please chair this session, and this session will start soon. I would like to request the participants of the consultant paper and all the consultants to be please ready with their presentations. We will be displaying the presentation soon.
Hello, good morning.
Good morning, sir.
I'm Dr. J.K. Sharma.
Ji, sir, very much welcome, sir. We are very glad to put you as the chairperson of this session. Dr. J.K. Sharma is MBBS and MS ENT, PG 1972 from GMC Bhopal. Lecturer, he has been a lecturer for 11 years, a reader for 8 years, and a professor of ENT for 14 years. He is the Dean of R.D. Gardi Medical College, Ujjain since 8 years and has continued as on. He's the professor since last 6 years, an ENT consultant at Avanti Hospital, Ujjain, and also ex-president of AOI MP State. Sir, we extend our heartiest welcome to you for chairing this session. The next consultant who will be chairing this session is Dr. R.D. Nanhoria, sir. He's MBBS and MS ENT, and he has paved a path for us as he was the past president of AOI MP State. Sir, I welcome both of you to chair this session. I would request the consultants to please be ready. The first participant for consultant paper presentation is Dr. Kirti Y.L. Ma'am. Ma'am, kindly be ready and please share the presentation.
Hello. Dr. Neetu?
You are audible, ma'am.
Yeah, can you please
They can unmute and start.
Ma'am, you can unmute and start, ma'am. You're audible, ma'am. You can unmute yourself and start the presentation, ma'am.
Yeah.
Dear participants,
कंसल्टेंट्स, आप लोग सब अपने आप को अनम्यूट और वीडियो ऑन करिए. यू कैन ऑल बिकम अ co-host and start your presentation. So Kirti, you can do that because that option is there.
They're all, it's showing that you are not a host, and that is why you have to allow host.
You are not able to share the screen. Okay, okay, I'll do that.
Hello. Hello.
हाँ, यशवी.
मैम जो प्रेजेंटर्स है उनको होस्ट बनाना पड़ेगा.
Can you see my presentation, ma'am?
Sorry, ma'am. Ma'am. Yes, ma'am. Yes, ma'am. Your presentation is visible, ma'am.
Yes.
Okay. Okay. Good afternoon. I'm Dr. Kirti, and today I'll be speaking about the role of tracheotomy in foreign body airway, the less traveled. When we are dealing with a child with foreign body airway, what comes to our mind is, do we have the correct equipment to reach it? Will we be able to grasp it with precision? And will we be able to extract it out through the glottis? So keeping this in mind, we did a study on our own patients. The aim was to evaluate the utility of various forceps and also to understand the indication of tracheotomy in foreign body airway. So we had 109 cases over 5 years, and there was 105 foreign bodies which were found. A majority of the children, 90 patients were children, and in 86% of the patients, we were using the optical forceps. Nonetheless, the standard forceps, that is the conventional forceps, was very useful in children below 1 year of age. In two adult patients, we did have to use the flexible fiber optic bronchoscope with forceps to get small pins which had migrated to the periphery. Now, why did we do a tracheotomy? Initially, in 2 cases, we did a tracheotomy because we really struggled to take out large and awkwardly placed foreign body, and we ended up doing a tracheotomy after the foreign body removal. Then we had 1 case in which there was an impacted supraglottic foreign body. Finally, eventually we progressed to understand when the cardiothoracic surgeon can do a thoracotomy to remove a peripheral foreign body, why not remove the foreign body which is difficult to extract through the glottis by doing a tracheotomy. So we had 3 patients in which we removed the foreign body through the tracheotomy. This is a video showing the difficulty that you actually encounter. We were told that the child had a pen cap in the right main bronchus, and we are trying to extract it with an optical forceps. And after multiple attempts also, we could not drag it out of the glottis. Now you see it is getting stuck at the glottis, and it falls back. With various maneuvers, we could not extract it.
See again, it's not. Whoever is speaking, please mute. Don't disturb.
We always use a tracheotomy, take a consent for tracheotomy control. But in this patient, we went ahead with infiltration, and a second surgeon did a tracheotomy, put paramedian silk ties like it's shown in the picture, and gave a vertical incision on the trachea. The primary surgeon who was holding the bronchoscope got the foreign body to the level of the tracheotomy, and the second surgeon removed the foreign body through the tracheotomy opening. After the patient was settled, we actually went in and did a primary closure of the trachea. This is a picture which shows the one surgeon is doing the bronchoscopy and another surgeon is doing a tracheotomy. After removal of the foreign body, we put an endotracheal tube. We didn't have a smaller tube, so we took an endotracheal tube through the tracheotomy opening. And once the child was settled, In the second picture, you can see that the anesthetist has taken over and is putting an endotracheal tube through the glottis, and the tracheotomy tube was removed. And in the third picture, you can see that the tracheotomy site is being repaired primarily. So post-operatively, in the 2 patients in which we had done a tracheotomy and put an tracheostomy tube, that could be removed only after 2 to 3 days, once the subglottic edema had subsided. Whereas in patients in which we did not struggle and primarily closed the trachea, the tube was removed in 1 day, next day, and the child did very well. So in all, we did 6 tracheotomies, and the tube was inserted in 2, and primary repair was done in 4 patients. All these patients were discharged uneventfully at the 7th post-op day. To conclude, optical forceps, standard forceps, fiber optic, all are very essential to have in your armamentarium, and you cannot replace one for another. Secondly, the tracheotomy should be always thought about early. There will always be incidents like you have a very swollen seed which has gone in easily but wouldn't come out. So in those patients, always think of tracheotomy and do not struggle at level and cause more damage. And once you have done a tracheotomy, always consider for a primary closure if there is no subglottic edema. These are my references, and thank you for patient listening.
Thank you so much, ma'am. It was a really enlightening presentation, ma'am.
Chairpersons are there so that can speak. Next.
Next, I would like to request Dr. Vikas Gupta, sir, to kindly start the presentation, sir.
Okay, sorry, Dr. Vikas Gupta is participating in How I Do. So we are going along with Dr. Shanil Kothari presenting her paper. So madam, please unmute and share your screen.
Screen is seen?
Yeah, screen is seen.
Yeah. And I'm audible? Am I audible?
Yes, ma'am. Yes, ma'am.
So this is about magnet replacement, the science and the art of it. Why do we want to replace a magnet is it may be disclosed due to a trauma, or we may have to remove it for an MRI, because the magnet of the MRI will damage our.
Excuse me, Shanil, your video is not shared. Video is not shared.
1 minute, I'll just check again.
Ma'am, your video is seen, but your screen sharing is not there, ma'am.
8 minutes. So now it is shared. Now is it shared?
Yes, ma'am. Yes, ma'am.
Yeah. So I'm going to talk about magnet replacement. We have got, this is a study on 3 patients where we have used non-magnetic self-designed instruments. So that is a science and an art behind this. So with an objective to safely replace the displaced magnet, non-magnetic instruments of adequate size and shape were designed out of plastic material to achieve a safe magnet replacement with unchanged impedances, unchanged NRTs, and unchanged. It has got 2 parts, external and the internal. Microphone picks up the sound, speech processor processes it, and through the transmitter coil, it goes to the inside receiver coil. And there is a magnet externally, there is a magnet internally through which the radio frequency link is established, and that is how the transmission happens. But if this magnet is displaced for some reason, either due to trauma or for MRI we have to remove, then this link does not work. Replace it, because this will be like a magic to restore the hearing mechanism. So materials and methods, given 31 patients operated, out of which 2 came to us with a displaced magnet. And as can be seen here, this is the magnet that has come out inferiorly, anteriorly. There was one more patient who came to me, operated somewhere else, but he had the problem for last 1 year.
So we can see that this skin is getting aberrated because he was using and that screen was getting crushed between the two magnets. So the first thing that came to our mind was displaced magnet, but we need to rule out any soft failures. So this was immediate post-implant NRTs and impedances. And we can see here there is a disturbance in the impedance and NRT also at the 10th electrode in case 1, because his electrode also got displaced due to trauma. The case 2 did not show any changes pre-trauma or post-trauma. This case was operated somewhere else, so I had only this impedance available with me, which is post-trauma, but it is normal. So you can see that in the X-rays case 1, here you can see that the electrode coil has the shape here is different and the shape here is different. So the electrode has come out a little bit, got disturbed. Case 2, it is as it is. You can see the displaced magnet. Case 3 also, displaced magnet can be seen. So these are the instruments that we have devised out of disposable forks. So we have used the handles to make retractors by heating them on a spirit lamp, and we have compressed and narrowed the ends of the forks. These are the narrow compressed ends which will be used to deposit the magnet. So the steps are like we first plan the clean drape, cover it with IOBand. Then with the silicone dummy, we will plan the incision. About 0.5 centimeter inside this, we will put the soft tissue incision. And we can see that the magnet has come out. Here the magnet is seen. This is the magnet that has been removed. And like we put the tube in a tire after a puncture, we will just place the magnet back into the silicone bag with the help of these thin, adequately sized depositors, and we are using plastic retractors. Otherwise, the magnet may get pulled out, and we have had an incidence like that.
जहाँ से आप देख लीजिए 2-3 जगह ट्राई करके, जहाँ से आपको चीपर वर्जन में मिले। डिजिटल हियरिंग एड लेना है, प्रेफरेबली जो पीछे लगाने वाली होती है वही ले लीजिए।
You can imagine how difficult it is to place it back if you have a magnetic instrument. So I'm using those plastic repositors to put the magnet back into the silicone pocket, just like the tire tube. So in all the cases, we achieved a very good post replacement magnet position, and impedances and NRTs were also good. So MRI scans were contraindicated because of the magnetic force generated, but newly inserted magnet tends to stick to magnetic instruments, so we need to devise something which is non-magnetic. Whenever you are doing a magnet replacement, the major concerns are proper replacement. The intracochlear electrode should not be disturbed. There should be no infection introduced, and we have to use an inert material. So in conclusion, non-magnetic instruments of right size shape can be easily designed. They are easily available, non-expensive plastic material and very effective. Decontamination and sterilization is possible with standard techniques. And we can reduce the post-op stress of pulling out the device or whether we will
कान के लिए लीजिए लेफ्ट।
or not. And we should, if possible, some research may be done if a ring magnet can be used instead of this circular disc magnet. So these are my references. Thank you so much.
Thank you so much, ma'am. It was a very interesting presentation. I would like to request the next participant, Dr. Nitin Kumar Jain, sir, to please be ready. Sir, we will be sharing your presentation, sir.
Hello.
Yes, sir, you are audible, sir.
Yeah. First of all, very good afternoon, my respected Sachdeva ma'am, and all of you. Am I audible?
Yes, sir.
Yes, sir, you are audible, sir.
Yeah, can I start?
So 1 minute, I am sharing your presentation, sir. Sir, I think it started. Ji, sir.
Please start, sir. The presentation has been shared, sir.
Okay. My topic is the foreign body in ear, nose, and throat. 3-year experience in a teaching hospital in Central India. Myself, Dr. Nitin Kumar Jain, assistant professor in ENT, SIMS Chhindwara. Next. The introduction part, the foreign body presentation in ENT clinics are very common, and it's almost 11% in emergency in emergency room. The foreign body is if the object is in a location in the body where it does not belong. Further, the foreign body can be classified is the living and non-living. The living foreign body includes the any insects, cockroach, ant, mice, honeybee, etc. And the non-living foreign body can be further classified into two: vegetative or non-vegetative, and hygroscopic and non-hygroscopic material like cotton, paper, eraser, thermocol, matchstick, and hygroscopic in grams, peanuts, bean seeds, coconut, groundnut, and corn seed. The pediatric population were more commonly suffered from the ENT foreign body, although sometimes adult were also suffered. Next. The presence of foreign body required prompt diagnosis and early treatment by experts. Otherwise, it may cause increased morbidity and mortality and also the cost burden. In earlier studies, have been found out the only prevalence, diagnosis, treatment, and complication of ENT foreign bodies. But in recent past, none study can in conducted in our region. So we planned the find out the prevalence among the pediatric and the adult population in our region. Next. Next slide, please. The objective in the of our study is to evaluate the prevalence of ENT foreign bodies in pediatric as well as adult population with types of foreign body, its lodgement in different sites, and important clinical findings. Next. In material method, the study conducted in the SIMS Chhindwara ENT department, in which the total of 354 patients come in the along with the ENT come into the ENT OPD and casualty. The duration of study between the May 2018 to May 2021, it is a 3-year study. In collected data, the demographic evaluation in terms of age, gender, and occupation, as well as the different type of foreign bodies, their lodgement in different sites, and clinical features were evaluated. The study protocol was approved by the Institutional Ethics Committee in SIMS Chhindwara. Next. In result, in our study, the maximum incidence were noted for the foreign body of nose, in which the total of 171 cases, near about the 48%, followed by ear and throat respectively. The nose foreign body shown in the table 1, in which the total of 171 cases, in total of 354 patients. Next. In ear cases, the ear foreign body in different age group, this table shows the total number of 143. Next. In table 3, the shows the foreign body in the throat region, which is 40 in number. Next. In all tables, the occurrence of ENT foreign bodies were evaluated. The more common age group of 0 to 10 year of age, that is in children. The higher percentage of nasal foreign bodies, which include 44% in all the foreign bodies. The type of foreign bodies which were common in both the children and adults, which are related to food stuff, and also the small size object like plastic toy, commonly in the children. Next. Now come to the clinical features and types of foreign body in the nose. Sometimes the history given by patient relatives and who saw the foreign body in the nose. This is the 120 cases and presented electoral, purulent, foul-smelling nasal discharge. With few patients also complained with the blood stain and complained of nasal obstruction. In remaining 10 cases present with the nasal bleed. The most commonly types of foreign body present in our cases, the seeds or nuts, that is the food stuff, food related, 67 cases, followed by the stone, cotton paper, plastic, chalk, metal, maggots, thermocol, woods, and other cases also included. The table 4, next slide. The table 4 shows the type of foreign body in nose in which the seed and nuts is the most commonly present in foreign body in our cases. That is almost 40% in all foreign body related. Other is stone, cotton, paper, is already discussed. Next one. This beautiful picture shows a 2-year-old female child, shows in the foreign body in the nose, right nasal cavity, removed in the OPD basis. This is a plastic toy. Next. This 3-year-old female present in the vegetative foreign body in left nasal cavity. Green vegetative foreign body. It's a peas. The next foreign body is in nose in the battery. This presentation came with us with the bleeding from the left nasal cavity. Removal under GA. Next. The clinical finding in the ear, the most patient of the asymptomatic, rest of the patient present with the history of elite foreign body in the ear with chief complaint of ear itching, otalgia, otorrhea and sometimes blocked ear. The cotton was the most commonly foreign body encountered in our cases. This is the 41 in number. This is followed by matchsticks, insect, pencil tip, plastic toy, and seed or nuts also included in foreign body in the ear. Next. Throat, in most of the time patient were asymptomatic. History given by patient guardian shows the suspicion of any missing object. Rest of the patient complain of pain during deglutition, foreign body sensation in throat, and hypersalivation. In our cases, fish bone is almost 60% is most often found esophageal foreign body, and tonsillar crypts is the most common site of lodgement, followed by vallecula, base of tongue, piriform fossa, and least commonly in the cricopharynx. The quine constitutes the 12 cases in our study is the second most common found foreign body in throat, and its site of lodgement is the cricopharynx. Next one. This picture shows the quine in the cricopharynx C5, C6 level, round metallic foreign body. Next. This picture also shows the fish bone. Fish bone present in the tonsillar crypts. Next. In our discussion part, in our study, the nasal foreign body is the highest incidence, followed by ear and throat, which was similar to the finding of the other studies. Although some studies have been shown the oral foreign body were more common. The most commonly affected age group were 0 to 10 years of age in our study. These observations were similar to other study also. Due to the insufficient mastication with improper deglutition and exploratory behavior in form of putting object in the mouth and different body orifices, so that more vulnerable to affected foreign body in the children. In our study, observation revealed that in pediatric age groups, seeds or nuts represent the commonest foreign body in nose and ear, which were similar to accordance in the study by Barreto et al. And Leskene et al. The population which were affected most belong to the farmers due to the availability of vegetative and grain seed in their houses. Although Higo et al. In their study have been found higher incidence of plastic made toy in pediatric population. The observation in present study showed that the cotton and matchstick were commonly foreign body present in the ear, and adults along with the insect inside the ear were also frequently seen, which was similar study founding in the Antonelli, Pizze et al. For adult cases in our study, the percentage of throat foreign body were exceeding the ear and nose foreign body. In throat foreign body, the fish bone and the quine is the most common foreign body, which was age for finding study by Endican S. et al. Management of foreign body in terms of removal were successfully done in majority of cases in OPD basis with detailed history and thorough examination. Although in some cases the general anesthetic support were taken to removal of foreign body. For throat foreign body is found, site of lodgement was tonsillar crypt and the cricopharynx, which were more common, which was similar in accordance with the other study also. Next. In conclusion part, the presence of ENT foreign bodies were more common in the children, and the type and site of lodgement of foreign bodies were varies in the different age group. Hence, early diagnosis and early referral the reduced complications related to these foreign body and help in the appropriate management. These are the references. Thank you. Next
Thank
slide.
you so much, sir, for the wonderful presentation.
Okay, thank you all.
I would like to request the next candidate, Dr. Pranay sir, to please be ready and share the presentation. And it is a very humble request, respected consultants, please stick to the time limits as we are running short of time. Dr. Pranay, please present the presentation.
Pranay, any issues?
Hello.
You are audible, sir.
Okay, is it my okay?
Yes.
Hello everyone. My name is Dr. Pranay, and I am presenting my presentation on supraclavicular artery flap for head and neck reconstructions in our experience. This study is being done in CBCC Cancer Hospital in North. So head and neck oncologic resections leave complex defects of mucosal or skin surfaces, which are often difficult to reconstruct and are very time consuming. Many regional flaps are available like PMMC, but they are very bulky flap and they are not very aesthetic and functional. So the free flaps have become the workhouse for head and neck oncologic reconstruction, but they require very expertise surgeries like microvascular surgeries, and we need an extra surgeon, plastic surgeons to do that. So we need a flap which could have the benefits of both a regional flap and a free flap. So according to the Gillies concept, the more adjacent the donor site is, the better the skin will match the recipient site. So an ideal one, which has the benefits of both a regional flap, reliable and easy to harvest, and free flap, thin, pliable, and good color match. So we look to the regional flaps, and we found supraclavicular artery flap matches almost all the criteria to it. So we started doing some of the supraclavicular artery flap in some of the head and neck reconstructions, and what we see, I'm going to show it. It's a fasciocutaneous flap. It's supplied by supraclavicular artery. It's a branch of transverse cervical artery, which is less frequently it arises from suprascapular artery. The venous drainage is usually accompanied by transverse cervical vein. It is harvested as vascularized pedicle flap, and it is more accordance to the Gillies concept. That is, the more the nearer the skin will be, it will match the recipient site. Objectives of study was to emphasize the benefits of supraclavicular artery flap and the good alternative to free fasciocutaneous flap, regional pedicle myocutaneous flap, and the deltopectoral flap. So we did supraclavicular artery flaps in head and neck oncologic resection in 7 cases. The age groups were from 30 to 55 years. There were 5 males and 2 females. All cases were of buccal mucosa.
Sorry, sir. Pranay sir. Sorry, sir. आपका slide share नहीं हो पा रहा है, sir. Slide share हो रहा है, but it is not changing. Now it has changed to first slide only.
Okay.
Methodology. Now it is on the methodology, sir.
Okay. So
okay, thank you,
going,
sir.
okay. So the flap design was as follows. The outline of the flap was centered over the deltoid acromial prominence, with the size of the defect being designed lateral to the anterior border of the trapezius muscle. The pedicle length with the arc of disposition is calculated from this point. The supraclavicular artery lies into a triangle which lies between sternocleidomastoid, external jugular vein, and clavicle. So is it changed? Is it on technique? So one of the drawbacks of this supraclavicular artery flap is there should not be no nodes in the supraclavicular and posterior triangle. So we have to we have to do the pre-op investigation like CT scan and all, and we have to be 100% sure there are no nodes in supraclavicular and posterior triangle. The pedicle of supraclavicular artery flap lies in the triangle deep to the belly of omohyoid, parallel to the clavicle. The flap outline is marked posteriorly 2 cm anterior to the spinal scapula, anteriorly a line parallel to the posterior line in front of clavicle, while lateral margin can be extended up to 2 cm lateral to the DP groove. So the flap is elevated from distal to proximal in subphysical plane, avoiding damage to the pedicle. It's more like a DP flap, but it will give a much broader area, and DP flaps can only be it has to be cut at the end of the 21 days, and it would be provide only skin, usually skin areas, but it can be used for the reconstruction of both buccal mucosa and the skin. So it will provide a much larger area, supraclavicular artery flap. So near the point of the exit of the supraclavicular vessels, the dissection is done, preserving the fascicle pedicle of about 3 to 5 centimeters in width. What we saw that 5 cases were absolutely successful, no complication we see in post-op cases. In one case, there was a partial necrosis, and in one more case, there was a distal marginal necrosis. All were managed conservatively, and the patient recovered in next 2 to 3 months. The wood dehiscence was also seen in one case, which is described above. So in conclusion, the advantages of the supraclavicular artery flap is it requires less time to harvest. It's a pedicle flap, so the chances of like a free flap to devascularize to failure of flap is much less in a pedicle.
Pranay, Pranay, your slides are not changing.
Oh, sorry, sir. So
only first slide methodology is there. Other slides are not visible.
So it has changed to technique, sir. Is it on technique? Oh,
now it is on technique.
Okay. So what should I do now?
Okay, we proceed.
I proceed. Okay. So in conclusion, what I want to say is the supraclavicular artery flaps, they are the pedicle flaps. They have a constant anatomy. They are pliable, and they can be raised up to 20 into 8 centimeters, and they are very good alternatives to the free flaps like FRAF. The only disadvantages is that you have to be 100% sure there is no level 4 and level 5 lymph nodes are there. And there is also, we have to do skin grafting at sometimes when we cannot able to close the supraclavicular artery flap by primary closures. If you are taking a big graft, you have to do a skin grafting. So there will be one more morbidity on his thigh or somewhere else if you take a flap. So it's a much better flap according to the Gillies concept. So as the PMMC is being used very frequently in head and neck oncological reconstruction, if you want to go and search for another flap, supraclavicular artery flap can be a very good, better option and alternative to PMMC. Thank you. That's it. Hello.
Yes. Okay.
Yes, sir. Thank you so much, sir. Now, I would like to request the next participant, Dr. Aparajita ma'am, to kindly be ready and share the presentation. Ma'am, Aparajita ma'am, Dr. Aparajita ma'am.
Yeah, just give me a minute. Yeah.
जी मैम, जी मैम.
Yeah. It's not opening actually. I'm just.
So you require some time, 5 minutes?
Yeah, ma'am.
Okay, then
I
I'll
can do
start.
it in the next time. Yeah.
Yeah, next.
Okay, ma'am.
Okay, ma'am. Thank you, ma'am. Now, I would like to request Dr. Kavita Sachdeva, ma'am, to please present the presentation.
Sharing him. So good afternoon, chairpersons, respected Dr. J.K. Sharma sir and Dr. Nanoria sir. I'm just sharing a small experience of CAM, COVID-associated mucormycosis at Jabalpur Center. So we all know that mucormycosis was affecting almost 10 to 30% of the fungal cases, and in that the rhinocerebral was one of the variety which was affecting us all, and we were dealing the cases. So Spellberg classified it into 3 stages: early rhino-maxillary fungal sinusitis. The stage 2 was rhino-orbital fungal sinusitis, and stage 3 was rhino-orbitocerebral invasive fungal sinusitis. So we all know that the fungus forms a layer inside the paranasal sinuses, and then it starts invading the blood vessel, and you can see the black avascular necrosis is because of thrombosis of the vessels. Now, 40 to 70% manifestations are of facial and oral structure, with black necrotic eschar being common, and it can involve other facial structures. Maxilla is not that much involved because of its rich vascularity. So these are the clinical picture, extensive cases which are difficult to survive. These are the orbital presentations, and you can see bilateral orbital involvement. This lady has ophthalmoplegia, facial nerve palsy. So the disease gone right into the brain. So many patients report to ophthalmologist also. So it was aim was to evaluate the pattern of destruction in nose, paranasal sinus, and orbit. So we had done a prospective observational study on the diabetic patients, and this was the investigation tools were CT, MRI, and sometimes CBCT. And these are the MRI finding in which fungus is very nicely seen, including the orbital involvement. So we have most commonly involvement of 40 to 60 years of age with male predominance, and unilateral disease was in 60% of the cases, bilateral in 26%, and right side was commonly involved. And you can see the laterality of involvement. And in stage 3 disease, I have 58 patients, stage 2, 19, and stage 3 were 9 patients. Now the symptoms varied according to involvement, and the orbital involvement was signified by ptosis, proptosis, ophthalmoplegia, and loss of vision. Now in nose, if we see the turbinate, middle turbinate was commonly involved, followed by inferior and superior turbinate. The septum posterior part was commonly involved, and floor of nose in 4% of the cases. And in the paranasal sinuses, it was mostly right maxillary sinus, dead macrotic debris, like when we used to open, there were fungal spores flying in the OT, and then anterior and medial wall were commonly involved. Posterior ethmoid was involved in 62% cases, 62 patient, and frontal sinus was in 29 cases. Now, out of 86 patients, pterygopalatine fossa was involved in 18 patients and infratemporal fossa in 12 cases. So this is what is the involvement of paranasal sinuses and adjoining bone. So orbit was involved in 28 cases. Commonly, it was going through nasolacrimal duct or through the lamina papyracea. And once it involved, it was involving the muscles, the optic nerve, and retroorbital structure. So lamina papyracea was the commonest route, and what was significant that nasolacrimal duct and nasolacrimal sac was also involved. Now when we saw the retroorbital structure, the orbital muscles were involved in 9 and optic nerve was engulfed with all fungatic debris in 7 patients. The cribriform plate was eroded in 3 patients. And infraorbital nerve was commonly found involved in majority of the cases, and frank white pus sitting the periorbita was present in 6 patients. So this is the orbital and extent of. So lacrimal sac was involved in 12 cases, and in 3 patients we can see that patient was eye was badly involved, so they required orbital accentration. So this is the pattern of involvement of mucomicosis in rhino-orbitocerebral vein. Subcutaneous phycomycosis was identified in 10 patients in which skin was also involved. So this is the extent of involvement. This is a black necrotic debris in the nose with the fungus, and we all know that it requires a multidisciplinary approach. So it is a summary of the surgery which is required. So we have to do Caldwell-Luck, uncinectomy was done, septectomy was done, turbinectomy was done, and anterior and posterior approaches were used. So with the surgical approaches are like we have to, in some patients, other than endoscopically, we have to go by sublabial approach, and in through that we have to go and debride the lateral wall. Now we were doing post debridement washing with amphotericin. This was a necrotic bone removed from the sublabial approach. This was how it was presenting. So radical surgery was required, in which the disease was difficult to remove, and perineural spread was present in 10 cases going up to the foramen rotundum, and you can see the fungal debris eroding the foramen rotundum and median canal in 6 cases. So take home messages: do endoscopic examination, plan surgery with CT, MRI, endoscopic finding, and inspect pterygopalatine fossa by removing the posterior wall of the maxilla. Lacrimal sac should be explored as it is the pathway of spread, and posterior bony septum is mostly involved if sphenoid sinus is involved. So thanks for the patience and giving me this opportunity to present the paper. Thank you, sir. So now, Aprajita, you can log in and present your paper.
And there is some issue with the display of my PPT. So I think I'll be sending it to you, and then
Thank
I
you,
will
ma'am,
be
for
able to.
the wonderful presentation.
Share करने में तो अपन we are going for the how I do. ठीक है, how I do पे चले जाओ. इधर आज आ रहा है. Can we become host?
आपने क्या
नहीं आ रहा है कुछ. I do, who is telling now? Forum.
All the concept and papers are over. Hello.
Good afternoon, sir. Now, I would like to announce that we are starting the session of How I Do It. For this session, I would like to welcome the chairpersons. Dr. Yashveer, sir, you are the first participant for this one. Please kindly start the presentation, sir.
Can you hear me?
Yes, sir, you are audible, sir.
Okay. So good afternoon, respected chairpersons. I'll be presenting a topic of endoscopic repair of nasal septal perforation, how I have managed few of the cases in past few years. So septal perforations, as you all know, the posteriorly placed ones are less symptomatic, whereas anterior perforations are more symptomatic, complaining of nasal obstruction, crusting, intermittent epistaxis, and some malodorous discharge. And the smaller the perforation in the anterior part, the patient might have troublesome whistling sound while breathing. Most septal perforations are due to injuries, that is either iatrogenic, that is post-septal or nasal surgeries, or sometimes accidental injuries. Then there are other granulomatous diseases and sniffing addictions, especially cocaine, though it is less commoner in India, but that can also cause septal perforation. We have to do a nasal endoscopic examination of all these patients. And if you see any kind of granulations at the edge of the perforation, it's better to take a biopsy before we plan any surgical intervention. Also, investigations to rule out active infection and granulomatous diseases like syphilis, tuberculosis, vaginals, and sarcoidosis. All these investigation pertaining to these diseases has to be done. We have multiple treatment options. Medical treatment is mainly keeping the maintaining the nasal hygiene, that is by doing alkaline nasal wash and providing humidification, and some antibiotic ointments can be tried. I have offered septal prosthesis in the form of septal button to these patients. One of the patient is using septal button, and surgical repair options can be endoscopic or open surgical through lateral rhinotomy, and even single stage or sometimes two-stage surgery can be planned. The endoscopic part, also open surgical part, can be either done by local flap. The local flap, which is an advancement flap, can be either unilateral or bilateral, or with the interposition cartilage in between the two flaps. Autologous and biocompatible grafts can be used. Also, free flaps can be used. So this is the surgical video. I have cut short the video and also increased the speed of the video so that in 5 minutes I can cover up the maximum part of the surgery. So we start with the infiltration. Infiltration to the floor of the nasal cavity, septum, and inferior meatus, that is the lateral wall of inferior meatus. All these areas are infiltrated with the xylocaine and adrenaline. Also, the edge of the perforation also is infiltrated very well to get a bloodless feel. Hope you all can see the video. So after complete infiltration, then we start making a flap. So the flap, I have specially designed a insulated ball probe. This actually I got it designed by Kalilkar for use in otological surgeries. So I have got it insulated so that we can use cautery. So the first step is making, marks for the flap. So first we start with the posterior and superior portion of the septum. We have to be around 5 mm below the roof to prevent injury to the olfactory epithelium. The second incision is an horizontal incision at the floor of the nasal cavity. So this can go up to the around 0.5 centimeter up to the nasal septum. And this part of the flap is left. Another incision is given, horizontal incision connecting that point at the apex of the inferior meatus anteriorly up to the anterior edge of the septal perforation. So again, this incision, you should make sure that you don't damage the nasolacrimal duct. And this incision is given in the anterior part up to the septal perforation. Even in this incision, you should make sure that you are away from the squamocutaneous junction, because damaging that area might cause problems. And finally, this is the area which will be vascular and will help in the vascularization of the flap. And finally, we also freshen the margin of the septal perforation. So it's important to freshen the margin, otherwise the graft or the flap will not take up. So once the flap is elevated, once the incision is completed, then we start elevating the flap. You can use a sharp Cotles elevator or a suction elevator. Doing a good infiltration and giving incision with the help of a cautery, it gives us a very good bloodless field. Don't worry, it will still maintain a good amount of blood supply. Blood supply will be to the flap will be from anterior ethmoidal and sphenopalatine. Both of them gives a good blood supply. So we are going to elevate the flap from all around. I have used unilateral septal advancement mucoperichondrial flap for reconstruction and kept the opposite side for rescue purpose. In case of any recurrent or revision surgery is required, then I have done a opposite side flap for those cases. You can do both sides together also and stitch it up. Also, you can use septal cartilage or cartilage from the concha and put it in between the two flaps. So here we are elevating the flap right from the lateral wall of inferior meatus, then along the floor. And the flap is elevated from all sides. This is a special upcutting scissors. This has been, patented by the name of Dr. Milind Navlake, from whom I have used very nicely. You can manipulate in all areas of the nasal cavity and you can make a nice flap. So once the flap is done, you see how much of length is achieved by doing that. So by increasing the area in the inferior meatus and going more and more posterior, you can also increase the flap size if you think it is required. So then after that, the tucking is done. Now while tucking, we should make sure that the edge of the flap is little bit into the anterior edge of the perforation. Even if you do not tuck in and just stitch it up, that also will take up. It's not a problem. But if you can tuck it a little bit, it will be better. So once that is done, we will be doing stitching of the flap. Flap is stitched at 3 points, anteriorly, superiorly. Mind you, actually, the initial cases, what I did, the suturing was done not through the endoscope. So this particular suturing, the flap is on the opposite side. So because this is of another patient. So just to show how you can stitch through endoscope, I've just put this part in between the surgery. So figure of 8 stitches taken. Use the small needle, either Vicryl is a better one to use, and slightly straighten up the needle because the curvature can create problem for manipulation within the nasal cavity. Points, 2 sutures here, 2 sutures on top and 2 on anterior part of the perforation. So once that is done, we put an internal nasal splint made of Teflon, and this splint remains for 21 days. So this is a splint what is being put. So we keep this splint for 21 days. It helps for the flap to come in more contact to the septal perforation. So this is 2 weeks post surgery. This is on the left nasal cavity, and on the right, from where the flap was taken up, you can some crusting is seen at the exposed bone area. So once the mucosa comes over there, this crusting will come down. This is the follow-up after 2 months of surgery. So you can see a well-healed perforation. So this is the right nasal cavity, and that was the left nasal cavity. So journey so far, I have managed 6 patients in last 6 or 7 years or so. 2 patients had history of septoplasty done elsewhere in a different center. 2 patients surprisingly had clear history. 2 were idiopathic. They could not give a proper history. So 1 patient refused to go undergo surgery, and around 1 centimeter perforation, I offered him a septal button. So you can see the septal button in place. He's very happy with that, and he has refused for any kind of surgery. And we have managed the size of perforation from 0.5 to 2.5 centimeter. 3 patients completely healed, and 2 had recurrent or residual small perforations, which we managed with the rescue flap from the opposite side. The longest follow-up is the patient what you all saw in the video, that is of 4 years, and she is very happy and is doing well. So these are the other patients. That is case number 5, a smaller perforation around 0.5 centimeter. This is the immediate on the left nasal cavity and right nasal cavity. You can see how the perforation has been repaired. And here you can see case number 6. This is again a 1.5 centimeter sized perforation. Flap stitched on the left nasal cavity, on the right nasal cavity. So this patient had a recurrent perforation. We managed again with a small rescue flap from the opposite side. So that's it. Thank you for patient listening. I have chosen this topic because this is a kind of a untouched area, though it is quite rare, but there are patients who come with such problems, and we should not hesitate to give them a trial of flap surgery, because once perforation heals, patient is the comfort level is much higher. So don't hesitate, don't fear for the failure of flap or any recurrent perforation. You can always go ahead and do such surgeries. It is not going to be difficult. Those who do normal endoscopic surgeries can do this as well. So thank you one and all. Thank you chairpersons and host for giving me opportunity to present here. Thank you once again.
Presentation, Yashvir. Congratulations. It's nice presentation.
Thank you so much,
Thank you,
sir.
sir. Thank you.
Presentation was very interesting, sir. Now, I would like to request the next candidate, Dr. Shinal Kothari, ma'am, to kindly present her presentation. Welcome, ma'am.
Thank you. Good afternoon, Chairman, sir. I am just presenting the whole video of a case of tympanosclerosis grade 3A, and I've put the subtitles for understanding. So I'm sharing the video. It is seen on the screen? The video is seen?
Ma'am, your video is visible, but your screen sharing is not there, ma'am.
Just a minute, I'll do that. Okay.
Ji, ma'am.
Now it's playing, no? So when we reach the annulus, we have to be a little gentle. And we scrape the bone to lift the annulus.
सब एक ही साथ क्यों इतने सारे लोग? करते लाइट बंद. टाइम हो गया है.
टाइम हो गया ना, तो डॉक्टर साहब आओ गाँव में लगे निकल आई नहीं है, तो हम किसी को तो दिखाएं, बहुत स्कूल से ले जाओ.
Once we disconnect the IS joint, we do the cortical mastoidectomy, open the antrum, and then we look for the tympanosclerotic patch because the ossicles were sclerotic patch. So head of stapes is seen on which we will place the cartilage. So thank
Thank you so much, ma'am. Now I would like to request Dr. Vikas Gupta, sir, to kindly present his presentation. Sir, we welcome you, sir.
Hello, thank you. Thank you very much. I'll be, hello.
Ji sir, you're audible, sir.
Okay, my screen is there.
Sir, your video is being played, but the screen sharing is not there.
Okay, just a minute. The screen. हाँ नहीं मैंने शेयर किया है।
The screen has been shared, sir.
Okay, good. So this is a highly modified video. Basically, we have compressed it too much. But it's a video of a common procedure, that's the laryngoplasty. So we start with the plaster technique for the local anesthesia, as we inject from the same entry point along the superior and inferiorly into the canal. And this is inside the canal, the 4 points, how we inject. So this, we are giving the local patient with xylocaine. With the insulin syringe, we prefer using the insulin syringe. So 0.5 ml into the each quadrant. So this is the superior inferior quadrant, and this is the superior quadrant, and similarly we'll give the local into the posterior quadrant. So once it is complete, then we'll go for the thorough cleaning of the external auditory canal. And before giving the post-oral incision, what we prefer is we go for a Rosen's incision. That is, we incise the inside, and then now when we have given the incision, very important, because this ensures that you are entering into the canal at the right point. So your posterior tympanomeatal flap will be of the right size. So you'll be opening close to the annular margin. Annular margin. So now we have taken the pinna along with the flap anteriorly with the help of so this remove the epithelium from the canal wall and as well as from over the fibrous annulus. So it will be a 360-degree incision. So we start from anteriorly. So this is also important when we are doing an overlay tympanoplasty, that we start from the anterior end, because anteriorly the annulus is more firmly adhered than it is posteriorly. And that is from there we start also removing the skin from over the annulus. So similarly, like anterior, we have come posteriorly, and as you can see that we are reflecting the small skin flap onto the up to the annulus, but we are not removing the annulus. Now here we are removing the epithelium from the handle of malleus, handle and neck of malleus, so that it is properly denuded. There shouldn't be any epithelium. So we have to ensure that what are the fallacies in the overlaid tympanoplasty, we should not be doing those things. So it is very important to remove all the epithelium from the malleus. So now annulus all along, so that in the final what we will be seeing will be a fibrous annulus, but very well in its place into the bony annulus. So you have to use the small suction and a smaller size round knife. So the round knife we are using is, we have two round knives for this procedure. Initially we use a larger round knife for giving the skin incision, and for these steps we use a smaller round knife. So what we are seeing over here is actually the fibrous annulus into which is there in the bony annulus, and this is the part of fibrous layer and the mucosa from inside. So this is how the bed for the graft is being made. So now you can see that there's the annulus and there is the part of fibrous epithelium, which is fibrous layer, which is there. So now we'll go for the graft replacement. We always use a fresh graft. So that means that we take a graft just, so this is actually 4x. So this is actually going at a 4x speed so that we can finish it in time. So we have modified the video actually like that. So we have to place the graft first all along the bony canal, and slowly we go inside, and we have to then go inside and as deep or as medial, so that we are almost up to the medial end or the floor of the canal or the medial wall of the middle ear cavity. So now you can see that we have gone deep to the annulus, deep to the handle of malleus, and there are two ends. There are two ends of, we have given a smaller cut over this part of the graft. So now we'll take this one end anteriorly and the anterior end posteriorly, so that which we call as the double breasting. So that this, what happens is that this graft stucks it over it very well. So this is almost towards the end of the procedure, then where we are placing and we are ensuring that our graft is not onto the remnant skin into the canal. So it is just very well onto the margins of the cut skin. And you can see that the shape of the graft at the end of the procedure is very well a concave, and is almost similar to the tympanic membrane which we have. So we use a flag knife. As you are seeing that we are using a flag knife, just lifting it up and then placing it back, and we just tap the margins with the flag knife, so that if there is any rolled margins over here, that rolling up of the margin is removed, and it helps in creating a capillary force, because there is always a blood around. So it creates a capillary force which further helps to stick your graft onto the bone. So the instruments which are very helpful or which we use in all from the beginning to the end is, one is a long curved needle, another is a small circular knife, and then it's a slightly curved flag knife or the lateral knife. Now this step is also very important, where we initially what we do is that we put in the gel foams all along the margins. So this is the margin of the graft with the skin. So these gel foams are being placed so that they cover the margin fully. So it is half on the graft and half on the skin. And once it is done, then we put in a lot of medicated gel foams. We don't put a pack in our tympanoplasties. Thank you.
Thank you so much, sir. The video was really, the whole presentation was very informative, sir. Thank you so much. Now I would like to paper which was missed earlier due to some connection error. Dr. Aparajita, ma'am.
Yeah.
Kindly start the presentation, ma'am.
So the video will be shared by you. Actually, the video is not being played by this laptop. Something has happened with the player. It's not running. So I send it to you. Yes. So am I audible? Am I audible?
Ji ma'am, you are audible, but your voice is little bit low, ma'am.
Okay.
Ma'am, you are audible, ma'am, perfectly.
Okay. Okay, so I'll start. So my topic is our experience with the two-handed endoscopic tympanoplasty. Next slide, please. Endoscopic tympanoplasty is a minimally invasive procedure, and it may be an alternative to the conventional microscopic tympanoplasty that may use the less operative time, producing similarly complete uptake of the graft. A microscope offers a straight line view, which limits the visual field in a narrow canal and the deep recesses of the middle ear. Therefore, the surgery of the ear is increasingly being performed endoscopically, as they offer a wide field of view with the magnification. Next slide, please. So this was a study which was carried out in the period of April 2018 up to April 2019, and we are still doing it. The two-handed endoscopic tympanoplasty was done in 20 patients with CSOM. So the inclusion criteria is the usual one, with the age group of 15 years to 60 years, the safe type of CSOM, the dry ear with no eustachian tube dysfunction, and a good cochlear reserve. The exclusion criteria included the age less than 5 years and more than 60 years, the wet ear, the unsafe CSOM, suspected ossicular chin discontinuity, and the patients with the mixed deafness. Next slide. In this study, we have adopted a novel concept of the two-handed technique using Dr. Khan's just touch endo holder described and designed by the renowned ENT surgeon Dr. Mubarak Khan. So the transcanal approach was adopted using the endoscope of the 0-degree 4 mm endoscope of Karl Storz. The stave stitch, which is seen in the first picture, the Tarabichi suture, was applied to retract the pinna and widen the external auditory canal. Now, the second picture shows the setup. Now you can see the surgeon has the two hands free to hold the instruments in each hand. The graft with the perichondrium was harvested and shaped with the slicer. Next slide. Margins of the perforation were freshened and the tympanomeatal flap was raised. With the help of the 0-degree endoscope, the important areas like the Eustachian tube area, the ossecular chain status and the mobility, the round window reflex, the hypotympanum was thoroughly inspected. The graft was placed into the cavity via the palisading and it was adopted by the underlay technique, medial to the membrane. Next slide. The perigondium graft, and in 5 of the cases, we also use the temporalis fascia graft, was then placed by the underlay technique over the palisades. The flap was reposited and secured with the antibiotic soaked with gel foam backing and a small dressing. So the average operating time was recorded to be 1 hour and 15 minutes. Next slide. So all patients had uneventful post-operative period and discharged with the standard tympanoplasty post-op instructions. They were followed up on the 5th day and were called every 15 days for a month and then monthly for the next 3 months. The post-op follow-up was done at 3rd month's period. The status of the graft and the hearing evaluation was done with all frequencies of 500,000, 2,000, 4,000 Hertz with the air conduction and the bone conduction thresholds. Next slide. So as you can see, this is the pre-op picture, and on the left side is the post-op picture of the large central perforations. Next slide. Yeah, in the sex distribution, we found the male is to female ratio of the females were more. In the age distribution, the young patients were more. The laterality was unilateral cases were more seen. In the size, I want to emphasize on this part, with the two-handed approach, we were able to do the transcanal approach in all kinds of the perforations, be it small, medium, large, or subtotal. Only in the large and the subtotal one, we extended the incision using the Lempert's approach, and we were able to do the surgery with a minimal scar. Next slide. This is yeah, the graft uptake was very successful. It was intact in the 95% of the cases, and only 5% of the cases had shown the failure rate. Next slide. So the endoscopes, they have a wider and angled view of the hidden deep regions like the anterior tympanic regions, the facial recess, the hypotympanum. These can be directly seen with a smaller incision, and it gives a very excellent cosmetic result and very less post-operative pain. The operative time is shorter, and the screen that we use during the endoscopic surgery, it also gives a very high resolution. And the tracheal cartilage, this is also easily available at the site of operation, and the incision is also very less. And it also tolerates the conditions like the negative one, the less extrusion, minimal shrinkage, and the lateralization. Next slide. The success rate of the tracheal cartilage uptake is very good in our study. With the two-handed approach. We compared it with the Ambani et al. Study, the HSU et al. Study, and it was almost corresponding with them. The mean duration for the operative time was 1 hour 15 minutes in our setup, and in the other study, the mean duration time was 62 minutes. That is approximately 1 hour. So it is very close. Next slide. There are only two safety issues. First, the heat generated by the light source and the trauma. So the lower settings of the regular light source, the regular cleaning of the tip of the endoscope with the anti-fog solution, and intermittent irrigation with the normal saline or the Ringer lactate solution, it helps to prevent the thermal damage. And the head holding by the assistant, it also helps avoiding the trauma. And I want to emphasize here on that, we did all the cases in the local anesthesia only. Next slide. So the conclusion from our study, we conclude that the endoscope, it has many advantages in performing the surgeries. It gives the surgeon a clear and the magnified view of the cavity. The two-handed endoscopic tympanoplasty is an emerging technique which can overcome almost all the major issues related with the single-handed technique with the high uptake and very good outcomes. Endoscope holder is a valuable adjunct to the conventional endoscopic surgery, and it will be a step further for the minimally invasive otologic surgeries. These are my references. Thanks a lot for the patient hearing.
Nice presentation, Aparajita.
Thank you, sir.
Thank you so much, ma'am, for the wonderful presentation. And now I would like to request Dr. Kavita Sachdeva, ma'am, to kindly present her presentation.
So, good afternoon, sir. Respected chairperson, I will be sharing a short experience. We get epiphora patients in OPD, and when we treat them, they resolve it and they become asymptomatic. So we do investigation by doing syringing, and if it is inconclusive, then we do a DCG. So we can know whether it is an upper canacular block or whether it is a nasolacrimal drug block. So we can select a patient for endoscopic DCR. So you can do it under general anesthesia. Mostly we prefer local anesthesia. So basically we are supposed to explore the area above the inferior turbinate up to the sac. So this is the part which we are supposed to explore. And in that there is a soft block or a hard block. So when we do a cannula, when we put a cannula, when it strucks the bone, then there is no problem at the common canalicular area. But if it is hitting and having a soft block, then we may think that this patient will not respond with a normal endoscopic DCR. So there are three techniques to do DCR. One is laser assisted, that is C1. Endoscopically, we explore the B area, and when it is external, it is mostly the A part which is being done through external approach. Now, when we do endoscopic, so you can see the anatomy. This is the middle turbinate, and this is the area of maxillary crest. So, and here is the uncinate process. So, you have to give an incision, and everyone, the same incision is same. It is slightly tilted incision. So, you can give two incisions along the maxillary crest. So, this is what I did. So, you can make a tilted H-shaped incision. H-shaped incision is tilted, and the horizontal stem of this H is a bit at the junction of upper 2/3 and lower 1/3. So you develop two flaps, upper mucosal flap and lower mucosal flap, and you expose this maxillary bone. Once you remove the maxillary bone, you get the lacrimal sac, and then you give an elongated I-shaped incision on this sac. So when you give an I-shaped incision on this sac, you get four flaps, one and two small superior inferior flap, and a bigger posterior flap and a smaller anterior flap. But when you give this H incision, you remove through the posterior incision, you remove this uncinate bone. Removing the uncinate bone gives a good approximation between the lower mucosal flap and the posterior flap of the lacrimal sac. So you have removed the lacrimal bone. So this is what I do. I give a H-shaped incision starting HMM above the axilla. We develop two mucosal flaps, superior and inferiorly based. We dissect submucosally the anterior and posterior margin of this H, and through posterior leg, we dissect the uncinate process submucosally and remove the bone. Give releasing incision on the mucosa of uncinate so that it lies properly and it doesn't erect, as we are leaving the mucosa behind to prevent the synechia. And this is what the uncinate we can remove. We remove. This is removal of the maxillary crest. So you can, we give a elongated eye incision on the sac, and there is a small video. I'll just play and इसको mute video कैसे play हो पाए? 3 minutes. 3 minutes. Fast forward नहीं. So I'll just show you the step. This is the incision which we are giving, the H-shaped incision I have given. And then you are dissecting and elevating and exposing. This is the elevation of the posterior flap to expose the uncinate maxillary crest. And then we are exposing to remove the uncinate bone. This is the uncinate bone we are removing. And then we are approximating the eye-shaped incision. And once we have given eye-shaped incision, then we can do overlapping of the posterior flap. You can see by removing uncinate, I can bring the posterior flap nicely over the mucolacrymous bag. This is the overlapping of it. So this is the end result. Sometimes the mucosal bridges are formed. So if it is not hampering, we can leave it. So this is what it is, a simple technique with good overlap of mucosal flap and less signic. And thank you so much to chairperson and audience.
Thank you so much, ma'am.
ऐसा जल्दी करो, ऐसा पेपर.
Nice presentation, Kavita. Good.
थैंक यू सो मच सर. सर आप लोग के सामने बोलना अच्छा लगता है, अभी भी बच्चे टाइप लगता है. थैंक यू सर फॉर योर ब्लेसिंग्स.
Thank you. I would request the chairpersons to kindly share their views on this session.
वीडियो नहीं है.
Consultant paper. Right. I would request the chairpersons to kindly share their views on the consultant paper session.
Consultation paper session was nice, and most of the papers were nice. In some papers, there were some glitches in the presentation, but otherwise it was good presentation.
हाँ दीपांकर.
So it was a nicely
हाँ जी
prepared.
हूँ मैं.
I think some papers are prepared very hurriedly, but it is good papers. And also how I do it, it was nice by Yashveer, Shenal, Dr. Vikas Gupta, and Kavita. They all presented nicely their presentations. Good.
मेरा बैग लाते ना मम्मी. Thank you so much.
Thank you so much, sir, for the kind words. So I would like to continue with the case series and the case SR paper presentation, which was postponed. I would like to request the SR participants to be ready, and their presentations will be shared shortly.
Good afternoon to all. This is my topic of the paper, effect of mastoid drilling on hearing sensitivity and otoacoustic emission in normal ear in patient undergoing mastoid surgery. Next slide. The aim of a study to evaluate the effect of drill-generated high-intensity noise on hearing sensitivity in contralateral ear, determining the nature of hearing loss, if any, by establishing whether it is temporary or persistent, and to find out the duration of hearing loss if temporary. The introduction. New noise can be considered as a toxin which results its fatal effect in proportion to the total dose. Acoustic trauma has been used to describe the situation where a single exposure to an intense sound leads to an immediate hearing loss. Exposure to the short duration, high level noise can cause either temporary or permanent hearing loss depending on the level of duration, spectral content of the traumatizing insult. Methodology. Sample size. This study includes 60 patients who had underwent mastoidectomy between 2019 to 20. Inclusion criteria was all patients attending in the ENT OPD with the complaint of unilateral ear discharge, including unsafe with cholecystoma and unsafe with the complication with normal hearing and intact tympanic membrane in contralateral ear preoperatively. Exclusion criteria was patient above the age of 60 years, previous history of ear surgery, abnormal hearing in the contralateral ear, patient with the contraindication to the surgery. Procedure and investigation. All patients underwent mastoidectomy and their PTA and OE were recorded preoperatively as well as POD 1, 3, 5, 7 and 30. These results were compared with the paired sample t-test using SPP statistics. 50% patients were male and 50% were female. 30% patient belongs to 0 to 15 years of age, 43 belongs to 16 to 30 years of age, 15% belongs to 31 to 45 years, 11% belongs to 46 to 60 years. Minimum age was 7 years and maximum was 60. 78% patient underwent modified radical mastoidectomy, 11 patient underwent canal wall up mastoidectomy, 10% patient underwent radical mastoidectomy. Average drilling duration was 1 hour 18 minutes minimum and maximum drilling duration was 30 hours and 22 hours 40 minutes hours respectively, and 45% required less than 1 hour of drilling time and 38% required drilling time between 1 hour to 2 hours, and 16% patient required drilling time 2 hours and 3 hours. This is the line diagram showing the result. It shows that there is no significant hearing loss for 0.25 kHz and 0.5 kHz for all PODs. For 1 kHz and 2 kHz average PTA, there is significant temporary hearing loss from POD 1 to POD 7, which normalize around POD 30. However, there is a significant temporary threshold shift for 4 kHz and 8 kHz from POD 1 to POD 5, and it's regained the hearing sensitivity as preoperative value at POD 7. This is the line diagram showing the results. It shows that for 1 kHz, 4 kHz and average OE, there is a significant temporary hearing loss from POD 1 to POD 7, which normalize around POD 30. However, there is a significant temporary threshold shift for 2 kHz and 6 kHz from POD 1 to POD 5, and it's regained at POD 7. There is a significant correlation between the drilling duration and PTA-OE average of POD 1, 3, 5, non-significant correlation with POD 7 and 30. The level of noise generated during drilling was different in Parkin and Yetel and Kalin Allinger studies. Temporary hearing loss duration in our study from POD 1 to 7 similar with Jaratal, Priya B and Latif et al. Study. Correlation between drilling duration and temporary threshold shift is significant in our study with similar result seen by Palwa, Shenoy and B. Singh et al. Study. The conclusion of this study is the sensory neural hearing loss can occur following mastoidectomy, especially modified radical and radical loss compared to the canal wall of mastoidectomy. The fact contributing for post-operative contralateral ear sensory neural hearing loss are the type of burr, size, duration of burr used, which produce significant amount of noise, vibration, and heat. ENT surgeons should use appropriate size and type of burr and also limit its duration as much as possible. The temporary threshold shift in post-operative normal contralateral ear may become permanent if control measures are not taken into account. ENT surgeons should limit the drilling time during mastoidectomy to minimize the acoustic trauma to the ear, and it can be achieved by practicing this surgery on cadavers. Thank you.
Thank you so much, ma'am. Now I would like to request Dr. Priyanka Verma to kindly present her presentation. Dr. Priyanka Verma, am I audible?
Yes, please. Yes, please. Yes.
I'll be presenting, displaying your presentation shortly.
Yes, ma'am.
Ma'am, your slide has been displayed, ma'am.
Yes. Thank you. Good afternoon, everybody. Myself is Dr. Priyanka Verma, senior resident. Today's my topic of presentation is study of clinico-pathological profile of hoarseness of voice. It is a retrospective study done on 100 patients. Next slide, please. In introductory part, actually slides is not fully visible. Yes. Now it's visible. Yes. In introduction part, voice is an integral part of human attribute known as speech. Markle and his colleagues have shown that the pitch, loudness, and tempo of the voice can use to reflect the personality of the individual. A person with voice problem may present with hoarseness of voice, fatigue, breathy voice, decreased phonation range, pitch break, etc. Hoarseness is just a symptom, but dysphonia is a diagnosis. Hoarseness is a coarse, scratchy sound most often associated with abnormality of vibratory margin of the vocal fold. In 1930, Jackson and Jackson felt the hoarseness is the most common and important symptom of laryngeal disease, includes both benign as well as malignant. All age group person and both gender can present with this symptom. If hoarseness of voice present more than 2 weeks, then it should be investigated properly to find the cause. The present study is an attempt to analyze the clinical profile, incidence of common etiological factor which has been associated with hoarseness of voice. Next slide, please. Next slide, please. The aim of previous one. Previous slide, please. Aims and objective. The aim of the study is clinico-pathological profile of hoarseness of voice. Next, to find out the incidence of the common causative factor lead to change in voice. Third is various modality of treatment, how you treat the patient, how to approach the patient. And the fourth one, what are the etiological factor which has been associated with the hoarseness of voice. Next slide, please. Next slide. Hello. Next slide, please.
The next
Material
slide
method. It is a retrospective study done on 100 cases in ENT department who has presented in ENT OPD as well as emergency from August 2020 to February 22. All age group patients, both genders were included, but acute laryngitis and voice disorder due to central nervous system abnormality like bulbar palsy, Parkinson disease were excluded. Each patient were examined by flexible nasopharyngoscopy or 70-degree Hopkins rigid endoscope, history taking, clinical examination, and if it is required, diagnosis is confirmed by HP, histopathological finding. Next slide, please. Next slide, please. Next, yeah. Now comes to the result. The first foremost is gender-wise distribution. It's typically shown by the pie chart: 66% male and 34% female. Male predominance is seen in this diagram. Next slide. Age-wise presentation, the most common age group present with the 5th to 6th decade, followed by 4th to 5th decade%, and third most is adulthood, 3rd to 4th decade%. The minimum age group is less than 10 years. It is grouped from the pediatric age group patient. Next slide, please. Symptom-wise presentation, mostly 100% patient came with the hoarseness of voice. Along with hoarseness, dysphagia comes with 25%. Then the neck swelling to 15%, between 10 to 15%. Neck swelling means cervical lymphadenopathy. Third is coughing or nasal regurgitation might be due to vocal cord palsy. Fourth is foreign body sensation, and the third least one is with stridor or hemoptysis. Next slide, please. Occupation-wise, in total, 82% patients belong from the non-vocal professional group, that is laborer, followed by the farmers, and in females, housewife account for 10%. Next slide, please. Habit-wise, most common smoking, 30% seen in individual, followed by tobacco chewing, alcohol seen in 10%, and vocal abuse seen in between 25 to 30%. Next slide, please. Etiological factor, this is the most importantly, 40% patient will in the 70 degree, when we do 70 degree rigid Hopkins endoscopy, 40% patients have been seen laryngeal growth, whether it is supraglottic, glottic or subglottic, followed by gastroesophageal reflux disease or laryngopharyngeal reflux disease patient. Third most is vocal cord polyps. It is a unilateral vocal cord polyps. And fourth most common is a vocal cord nodule, followed by TB of larynx, vocal cord papilloma. In least one case is laryngeal trauma. Next slide. Discussion: out of 1100 patients who attended ENT department in past 1.5 year, out of which 100 cases were presented with change in voice. So incidence is 0.9% in our study. This incidence is Shambhu and Betha with they also study on the same topic and 1.32%. Majority of the patients were around 5th to 6th decade, followed 31%. Study by same Shambhu, 28.1. They found 4th decade. Swapna Ghosh, 28%, 3rd decade. Our study, male predominance, 66%. And similar study done by the Parikh, they also found male predominance. Next slide, please. Non-vocal professional, as I already stated, 82%, and in female, housewife account for 10%. Hoarseness of voice present in already 100% cases, followed by 25% cases who, along with hoarseness, present with dysphagia. Next slide, please. Management part. Basically, what we found most common is growth larynx, whether it is supraglottic, glottic, or subglottic. Approach for the diagnosis, we do the endoscopy followed by fitness of the patient, and then we go for DLScopy and biopsy under LA plus IV sedation. And if it is necessary, pre-operatively tracheostomy also done. LPRD patient managed conservatively by lifestyle changes, modification, proton pump inhibitor, antacid, and if not relieved, then upper GI endoscopy well advised for H. pylori infection. Vocal cord nodule or polyp, which is the third most common reason cases, they were, if not cause respiratory distress, managed conservatively by advising voice rest and followed by steroid. Conclusion: hoarseness of voice should never be ignored as it is the most common symptom of most dreadful diagnosis. Any patient came with change in voice for more than 2 weeks should thoroughly investigated to rule out the malignancy. Next slide, please. These are my references. Thank you.
Thank you so much. I would like to thank both the SRs for the wonderful presentations. Now I'm very happy to announce that the most interesting part of the conference is about to start, the quiz, which will be headed by Dr. Pagare sir and Dr. Kirti ma'am. I extend a very warm welcome to both the chairpersons. Welcome sir, welcome ma'am.
Can you please unshare the PPT?
Yes, sir. Yes, sir. We are working on that.
तुम सर का स्क्रीन सेवर लगा रहे हो?
चाहते हैं ना तो यही दिक्कत होती है। नहीं नहीं ठीक है, अब वो मुझे समझ में नहीं आया कि
We have stopped sharing the screen, sir.
Okay, thank you. ठीक है, थोड़ा सा आगे आ सकते हैं।
Good afternoon, everybody. It's a pleasure to be with you this afternoon for the quiz. I always enjoy interacting with young and charming people like you and also Dr. Kavita. Hello, madam. How are you? Dr. Kavita.
Sir, thank you, sir. We are all waiting to see your quiz.
Am I looking okay on the
सर आपको
screen?
देखकर ही enthusiasm आ रहा है. Thank you, sir.
I'm Kavita. Am I looking okay on the screen?
Smart, sir.
Oh, thank you.
Very
Do you know
smart.
the difference between a beautiful girl and a charming girl? Kavita ma'am,
जी sir.
do you know the difference between a beautiful girl and a charming girl?
No, sir. I just want to know the difference between it.
The
पढ़ाई
difference
में रह रहे
between
सर, कुछ सीखा नहीं अभी तक.
the difference between a beautiful girl and a charming girl is very clear to see. I always notice a beautiful girl. A charming girl notices me. Okay.
Yes,
So
sir.
welcome you all. We start with the introduction of the participants. Team A. Team A to start introducing.
Good afternoon, respected teachers. I'm Dr. Rimsha.
Team
I'm
A,
Dr.
name
Ayushi.
and the college.
We are from People's Medical College, Bhopal.
Please put on your videos. Videos have to be on all the time, please.
Team A.
Our video is on, sir.
Okay, can you please talk a little loudly, please?
Sir, our video is on.
Okay, okay, thank you. We show this. I think they will be able to see us, but you will be able to see the. Okay, okay. So you can start up. दूसरा जो बताना. Are you ready?
Team A, Team B.
Please, I think we can continue with the introduction. Are you getting me?
Yes, sir.
Yes. So Team B.
आप लोग रेज कर सकते हैं हैंड.
Yes, please raise your hand so that we identify your faces.
Team B. Anyway, I think we can read up. Okay.
There seems to be two devices in the room. Please mute one device.
अर्जेंट क्वेश्चन करते हैं हमारा अर्जेंट क्वेश्चन
In all, please mute yourself. Hello, check. Okay. Can you please read out the names and then we can start? Huh? You have the names. Okay.
Team A, I'll be reading out your names. Please raise your hands. Team A from People's Medical College, Ayushi and Rimsha. Okay. Team B from NSCP Medical College, Jabalpur, Dr. Lakshmi and Dr. Stephanie. Dr. Lakshmi?
Yes, ma'am.
Okay. Team C from GMC Bhopal, Dr. Mansa and Dr. Ankit. Okay. Team D, Dr. Rushil and Dr. Samiksha from RD Kari Medical College.
Yes, ma'am.
Team E, Dr. Piyush and Dr. Shruti from Bundelkhand Medical College, Sagar. Team E. Team E is not there.
Let's go to the F. Then.
Okay.
Yes, ma'am.
Yes, ma'am. Are we audible?
Yes, now you're audible. Please raise your hand. Raise your hand. You have two devices. Please put off one device. You have two devices. Put off one device. Team F. Team F and Dr. Manan. Dr. Manan. Arvind. Arvind. Team F, please respond. Team F, please.
Yes, ma'am. We are here. Yes, ma'am. We are here.
Yes. Survi and Dr. Harshit. Okay. From SSMC Riva. Okay. SSMC Riva.
Okay. Please mute all mics there. Mute all.
This quiz is for ENT PGs. It is not only ENT, so enjoy it. Rules. We are projecting the rules. I think everybody knows about it. 10 marks. 10 seconds. 10 seconds. Mention not. Mention not.
Can all the teams please mute themselves? Okay, we are
starting. With what team A? Why the head mirror has a hole at the center? Team A.
Time up.
Team A.
You have only 10 seconds to answer. If you do not answer,
the visual axis and the axis if you see the opening of the head mirror. Next question for team A.
Team B. Team B, are you ready?
Yes, sir.
Quick.
Bone conduction test. Bone conduction test. Autosclerosis.
Rats notch.
The in autosclerosis, 2K dipper, bone
Okay.
Okay, next for team C now.
For team C. What is Tulio phenomena? What is Tulio phenomena?
It is drop attack seen in Meniere's disease.
It is drop attack seen in Meniere's disease.
Meniere's disease due to a sudden exposure to loud noise.
Exposure.
Okay, correct. Now,
Okay,
team
correct.
B.
Now, team B.
Yes, sir.
D.
D for dog.
Can we just fix the echo issue? Savita ma'am से बात है कोई?
There's a lot of echo.
Dr. Piyush, please.
Dr. Piyush, please. On.
Yes, ma'am.
Okay, team D.
D, RD Garden Medical College.
D. RD Garden.
Still some issue. We are just trying to fix this.
Just trying.
Hello, check.
Hello, check.
Dr. Piyush, you from your end there is some echo coming.
From your end there is some echo coming.
ये फोन पे तो बंद है ना?
Mute yourself.
Phone पे तो बंद है ना? Not speaking.
Hello.
इसमें से लॉग आउट कर लो. हेलो.
नहीं अभी मगर ये आपको इसमें
अभी मगर ये आपको
see at our end there is no other
at our end no other
can everyone please mute and
please and then
because in the beginning when we came in
Sir, from Dr. Piyush side there is an echo coming. They have to mute themselves speaking.
Okay.
I think they're playing some another device also in the same room.
इसमें से लॉग आउट करो.
Dr. Piyush, you are requested to please mute the device.
Yes, sir.
Please mute one of the device.
Yes, sir.
Okay, thank you.
Okay, thank you.
Yes, sir.
Okay, we are just checking again if the muting problem. No, there is still some devices in the same room.
There is still some devices in the same room.
Push is on.
Piyush,
Dr. Piyush, your device is on.
On.
hello, check. Hello, check.
Hello, check.
Yes, sir.
Hello, check.
Yes, sir. Are we audible?
Yes, you're audible. Please put your mic on mute.
Yes, you're audible. Mic on mute.
Mic. Sir, on.
Mute, बंद कर दे माइक को. हुआ क्या? अच्छा, चलिए. This is now which team?
Team D. RD Medical College.
Team D हो गया ना?
Team D.
Team D. D for RD Medical College. Team D.
Team D. The question now is for you.
Okay. What is white noise?
Time is up.
Next, please. It is broadband noise, contains all frequencies in audible spectrum. It is used usually for masking.
Which team? Team E now.
E now.
Yes, sir.
When is the ear called a dead? When the ear is called a dead ear.
When is the called a
Time up.
Sir, hello.
Okay, say please.
Hello.
okay, say.
Sir, when there is hearing lower than 90 decibel.
No.
No.
When there is no caloric response, even
When there is no caloric response
of 40 ml of ice cold water, then the ear is called a dead ear.
Next,
F.
Team F.
What is the other term of this tympanoplasty? Ulstein type 3.
Columeloplasty. Columeloplasty.
Columeloplasty.
Okay.
Type 3.
Why there is a bud here?
Because birds are also they also have this beak type of structure, sir, and the columella is a single bone. It appears like a single bone, sir. The
Okay,
avians
good.
are.
That's why the bird is here.
Yes, yes.
So are we done with the first round?
No, one more question.
The next team.
Team G.
Team G.
What is Schwartz operation? What is Schwartz operation?
Time up.
Extra time, 5 more seconds.
Okay. It's the cortical mastoidectomy called Schwartz operation.
Okay, first round done. Okay, so you want to share the...
The scores at the end of round 1 are Team A 0 points, Team B from Jabalpur 10 points, Team C Bhopal 10 points, Team D Ujjain 0, Team E Sagar 0, Team F Indore 10, Team G Riva 0.
So which teams go ahead now?
3 teams only.
Okay.
All the team with 0 will have to have a tiebreaker.
Achha, okay. So
The 3 teams which are going ahead is NSCB Jabalpur, GMC Bhopal, and Aurobindo. There will be a tiebreaker for Peoples and Adigadi Ujjain, Sagar, BNC Sagar, and SSMC Riva. So be ready for the tiebreaker. 4 teams for tiebreaker.
Okay, we'll show it. Let's see. So which team first?
Okay, so same order.
Same order.
So we go by the same order. Team A, People's Medical College, are you ready?
Yes, ma'am. Yes, ma'am. Are we prepared now?
Okay, here's the question.
Team A.
What is dysphagia ludoria?
Subclavian artery decompression of subclavian artery. Esophagus due to subclavian.
Okay.
Okay, team.
Compression of esophagus by aberrant subclavian artery. That is the right subclavian artery arising from thoracic aorta.
Next team.
Next.
Team D, RD Gadi Medical College, be ready.
What are the 2 main ingredients of Mandel's paint?
Carbylfuscin and phenol.
Carbylfuscin and phenol.
Mandel's paint. Where it is used?
Sir, it's used to relieve the pain caused by generally tonsillitis.
The main ingredients.
Okay, you get the points.
No,
Acha,
no.
Okay, no points. Okay. Okay, this is the answer.
Iodine and potassium iodide. They are the main ingredients.
Next team.
Team E, BNC Sagar.
Here's the question.
What is Carrigan's?
What is
Oregon's sign?
Oregon's
Sign. A man is dancing here.
A man is here. Any cue?
The time up.
Time
Time up. Time up.
It's a dancing carotid.
It's a dancing
Prominent pulsating carotid. Aortic wall regurgitation.
Next team.
Team G, SSMC, Reva, be ready.
What is Ram Haran sign? Widening of parotid veins seen in CT image occurs in juvenile nasopharyngeal angiofibroma. It has a significant diagnostic value.
Okay, done.
So next, so People's Medical College Team A is also going into the next round. The other teams, thank you so much for your participation. So Team A, Team B, Team C, and Team F. Are you ready for the round 2?
Yes, ma'am.
Yes, ma'am.
So we come back again to Team A for round 2.
Okay, so 8 question. We had 14. Actually, हमने एक ही कर दिया उसमें, but ठीक है. एक ही कह दिया. ठीक है, not an issue. So we are going in the next. ठीक है. Oh. Are you able to see the presentation? Okay, next team.
Team A, People's Medical College, round 2.
Yeah, here is the question.
No, ये हो गया.
नहीं आ रहा है.
Alias and incus. Alias and incus. Alias and incus.
Okay.
Okay. Team B, are you ready?
Yes, ma'am.
What is organ of Jacobson?
Vomeronasal organ. It is the vestigial organ, VNO.
Okay.
Team C, are you ready?
Yes.
What produces thumb sign in an X-ray film?
Thumb sign is seen in acute epiglottitis in an seen in lateral view X-ray in pediatric patients.
Right.
Okay. Team F, are you ready?
Yes, ma'am. What is the Arnold's nerve?
Auricular branch of vagus nerve, which is also responsible for the cuff reflex.
Please repeat your question.
It is the auricular branch of vagus nerve.
Okay.
Okay, so at the end of round 2, Team A is at 20 points, Team B 20 points, Team C 20 points, and Team F also 20 points. So congratulations, you are going to round 3.
Team A. Team A, next question.
Yes, sir.
By whose name the butterfly charge goes? By whose name the butterfly charge goes?
Time up.
It is Snellen's Clausen's method of representing caloric response. It goes by the name of Clausen.
Team B, are you ready?
Yes, ma'am.
What does type B tympanogram indicates?
Middle effusion.
Okay.
Middle.
Okay, Team C, are you ready?
Yes, ma'am.
What is Gillette's space?
It is retropharyngeal space.
Okay.
Retropharyngeal space of Gillette. Between the buccopharyngeal
and prevertebral fascia, retropharyngeal space. Okay.
Team F. Team F, are you ready?
Yes, ma'am.
Okay.
What is PAHA?
Bone anchoring hearing aids.
Okay.
Okay, now we are at the end of round 3. Team A is at 20 points. Team B is at 30 points. Team C is at 30 points. And Team F is also at 30 points. So now we are going to the last round. And the teams which are going forward will be Team B, NSCB Jabalpur, Team C, GMC Bhopal, and Team F, Sri Aurobindo Indore. So these 3 teams will be going to round 4.
Next question for Team B.
Yeah. So the next question will be starting with Team B.
Team B ready?
Yes, sir. Yes, sir.
What are Onodi cells?
So posterior ethmoidal cell, which is pneumatized into sphenoid cell, sphenoid sinus.
Good.
Team C, are you ready?
Yes, ma'am.
Name this incision.
Sphenoid cells. Apron's incision given in a total laryngectomy.
Name this incision.
Glug Sorensen's incision.
Okay.
Team F, are you ready? Team F, are you ready? Team F, we cannot hear you.
Ma'am, yes, we are ready.
Yeah, okay.
What is Hitzelberger sign?
There is a anesthesia of posterior superior quadrant of ESC.
Okay.
Which team now? Acha, done. Okay.
So there's a neck-to-neck battle for the winner. We are all equal. So you're at Team B is at 40 points, Team C 40 points, and Team F also at 40 points. So there's going to be a tiebreaker again.
Okay. So which team now?
Team B.
Team B, here is your tiebreaker question.
Team B, ready?
Yes, ma'am.
What is this instrument? Time's up. Okay. This is McNaught's key used to repair linear fracture of the thyroid cartilage kept in between the cords.
Okay, next question for team C.
What is this instrument?
Jennings mouth gag.
Okay.
Now team F.
Yes.
Yes, ma'am.
Yes, ma'am.
Why the petrous part of temporal bone is called so? Why the petrous part of temporal bone is called so?
Shield-like, because it is shield-like.
Time up.
Ma'am, he said,
Shield-like.
ma'am, he said that it is like shield-like.
Voice break.
Yeah, we got that, but then that's the wrong answer.
Petrous means like stone. It is a solid like stone.
Shield or stone.
Sir, वो I think meaning same.
So now there's going to be another tiebreaker between team B and team F. Okay, so we'll have team B again.
Team B ready?
Yes, sir.
What is Donaldson's line?
A line which is drawn through the posterior semicircular canal through the lateral semicircular canal bisecting the posterior semicircular canal, which is endolymphatic sac. Inferior to this line is endolymphatic sac.
Okay, okay.
Okay, so team now we are having team F for the tiebreaker question.
What is Bell's Island?
Team F.
What is
Time
Bell's
up.
Island? Time
Time
up.
Cochlear implant.
No.
A thin plate of bone left of sigmoid sinus when it is retracted during surgery. That is the Bell's Island. So how everybody is going? Interesting?
Yes, sir.
Okay.
अभी हो गया ना?
नहीं
हाँ हो गया complete.
Results here.
Well, the quiz is over, but I am fortunate to have two of my colleagues here who have helped me in this quiz. Dr. Kirti, who is from Bhopal, is assisting me, and the technical part of this quiz is handled by my son, without whose help this would not have been possible.
Thank you.
So here is Kirti, here is Nishant.
Thank you. Okay.
So according to the results, the third place goes to Arbindo Indore. Please can we have a round of applause?
Thank you.
And second place goes to NSCB Jabalpur. Well done, guys. And the first place goes to GMC Bhopal.
Congratulations.
Yeah. If there is some time, we can talk about something.
पूछ लो आप अभी तो वैसे तो they are
I
probably
would
right.
really like to thank Pagare sir for
such an entertaining session, sir. हम लोग को भी बहुत मजा आया and it was so nicely made illustrations. हर illustration was unique. Very nice, sir. Very interesting. Sir, can I request you on this platform one thing, if you permit me? Bagare, sir, I want to ask you something.
Please go ahead.
Sir, what I was thinking that you are full of talent, sir, and you have beautiful illustrations. So we are doing this beautiful event for only MS ENT students. Can we do it annually for our undergraduate students also, sir?
It would be a pleasure for me, ma'am.
It can be planned as per your convenience, but it will be a state level quiz between the undergraduate students, sir.
Yes, yes. It would be a pleasure. I would be very happy to manage it.
Right, sir. So their exams date have not come. So I will personally talk to you if we can organize only quiz for undergraduates, sir. Thank you, sir, for being with us and
1 minute.
educating us, sir.
1 minute.
Thank
I have
you
a
so
few
much.
questions.
Thank you, Nishant.
So please wait.
देखो तो उनका टाइम कम है.
Have you got some time?
Very much, sir.
Okay.
We can all be enlightened with your kind words.
Okay, so we can show you some of the questions which I have omitted. What is okay? No, it's all right.
Anybody can answer.
What is thyroplasty type 2?
Lateralization of vocal cords.
Done in cases of. Okay.
Jabalpur answered.
What is corkscrew esophagus?
Esophageal spasm. Diffuse esophageal spasm.
Okay.
Radiological finding.
और भी होंगे.
टाइम ब्रेकर है.
हाँ, नहीं.
It was a very interesting session, just like the last year. Last year also we enjoyed it very much, sir.
So I have some more slides,
Ji sir, ji sir.
What is one? What is prion?
Sir, it is a only proteinaceous infectious material lacking the outer only nucleics.
Only proteins without any genetic material.
Right. Jeez.
Okay. What is CRISPR?
बताओ ना. Palindromic.
Sequential palindromic repair.
नहीं.
This is a genetic recombination technique done in
palindromic
repair.
Cluster
Short palindromic repair.
It's the latest. Okay. What is complication caused by Zika virus? Zika virus.
Encephalopathy, sir.
No. Fetal abnormalities.
Hemorrhage.
Okay, who was the first Indian lady doctor trained in Western medicine?
Anandibai Joshi.
Anandibai Joshi from Pune. It is a very tragic story related to this doctor, Married at the age of 8 years.
What's wrong with
Married at the age of 8 years. Married to Gopal Rao, who was 20 years older. And had a child, 10 days old, who died. And this prompted her, motivated her to have study of medicine. She went to United States, University of Pennsylvania, returned back, and after a couple of years died of tuberculosis. But Anandibai Joshi was the first lady who was trained in Western medicine.
Very good answer, whoever has given it. Jabalpur.
What's wrong with this picture of Yogi Adityanath? Very, very.
Brook nose. यहाँ hair.
What is wrong with this picture?
No lotus.
Yogis.
Yes, madam.
And why this is okay? Why this is?
Because
इन तीसरा टर्मिनलिस पे हेयर्स करा है शायद इनने
योगी आदित्यनाथ किस पंथ के योगी हैं?
गोरखनाथ मंदिर
पंथ अलग होता है. ये गोरखपंथी योगी which is also called Kanphata yogis.
Very good.
What is this?
Caduceus.
this is the symbol.
Yes, the Greek god of health and medicine. Rods of Clavius.
What is
नहीं.
आ गए, आ जाओ आ जाओ, तुम्हारे इंतजार कर रही थी. बैठो. Nickname given to a subortical particle, a Higgs boson particle.
Dr. Satyendranath Bose. The particle is named after this great scientist who was very close to Einstein.
particle physics?
Okay, so wish you all the best. Thank you very much.
Thank you so much, sir.
Thank you.
सर सबसे इंटरेस्टिंग लास्ट पार्ट था ओपन सेशन. It has energized everyone is starting smiling and energetic, so that positivity has flown from Bhopal to every medical college. Keep on spreading this positivity, sir. Thank you.
Thank you, ma'am, for giving us the opportunity to be with you for the quiz. Thank you very much. Okay.
Thank you, quiz masters, Dr. Pagari sir and Dr. Kirti ma'am, and all the teams who have participated so wonderfully in this session. And I congratulate all the winners for this session. And also those who have not won, but still we all had fun. So in the spirit of the game, let's move ahead and move on to the session of the case series. We will take around 1 minute for that.
Hello.
Hello.
Invite the chairperson.
I would like to welcome the chairpersons for the case series session, Dr. Smita Soni ma'am and Dr. Nitish Baisakia sir. Now, I would take some time to read their CVs. Dr. Smita Soni ma'am is the professor and HOD GMC Bhopal, teaching experience of 15 years, and her field of interest is head and neck surgery. Welcome, ma'am, and thank you for chairing this session. Next, Dr. Nitish Baisakia, sir. He is the HOD and professor and HOD of LNMC Bhopal, and he has a teaching experience of 17 years. His field of interests are FES, cochlear implant, and thyroid surgeries. I welcome you, sir, and I thank you for chairing this session. Now, I would like to request the participants in the case series session to please be ready. Your presentations will be shared shortly. The first participant in this session is Dr. Samiksha. Dr. Samiksha, we will be sharing your presentation shortly. Kindly be ready to present it.
Yes, ma'am. Good afternoon, respected faculty members, my seniors and my colleagues. The topic is presentation of mucormycosis in post-COVID-19 infected patients and an approach to its management. Next, please. So mucormycosis, or commonly termed as black fungus, is a fungal infection caused by a group of fungi called Mucormycetes. And these are naturally found in air, water, and even food. It enters in the body after inhaling fungal spores from the air and commonly affects sinuses and lungs. It infects the nose, orbit of eye, oral cavity, and can even spread to the brain. The patient comes with complaints of headache, nasal congestion, nasal discharge, bleeding, nose, crusting in nose, swelling on face, lack of sensation on face, and skin discoloration. Other variants are pulmonary and cutaneous. Next. Next, please. Causes. So as we already know that the patients who are either recovering or recovered from COVID-19 are the main cause in this category. And also Indian government has issued an advisory, that is Indian Council of Medical Research, which states that the patients which are more susceptible are who have uncontrolled diabetes, weakening of immune system due to use of steroids, prolonged ICU or hospital stay, comorbidities, post-organ transplant, or cancer. Next, please. Pathogenesis. So the asexual spores, these spores land on the nasal and oral mucosa, and if the host is immunologically competent, there is no disease. And if the host is compromised, then germination occurs, which result in hyphae invasion into the blood vessels, and thereby causing thrombosis, ischemia, infarction, and resulting in dry gangrene and necrosis. Next, please. So in my study, it was conducted on 70 cases in our tertiary care center. And after admission of these cases, we again screened them for COVID infections and comorbidities like diabetes mellitus, hypertension, and any other immunocompromised state. And the level of involvement like nasal cavity, septum, turbinates, sinuses, palate, orbit, or any other cerebral involvement was noted. And the protocol of medical and surgical management was decided in accordance to that. Post-surgery, KH mount, HP report, CT, and MRI findings were the major pillars in this regard. Next, please. Next slide, please. Next slide, please. So the aim of my study is to study the presentation of mucormycosis in different age groups, gender, and patients with comorbidities,
post-COVID-19 infection and its management on medical and surgical grounds. So we can see, though we cannot see the slides on the screen here, but I'll continue. Out of 70 cases, we found that 65 patients were COVID positive in the recent past, and diabetes mellitus history was present in 55 patients, and steroid use history was given by 68 cases. And if we talk about area of involvement, almost all patients, that is 70 patients, came with nasal involvement. Sinuses were involved in 60 patients, ocular involvement in 21 patients, cerebral involvement in 24 patients, and palatal involvement in 13 patients. Now coming to management. If we talk about investigation part, CT-PNS and MRI-PNS were the mainstay. And after that, we could identify. Please come on slide 8. Yes. So sinuses involved. In almost all cases, maxillary sinus was involved, followed by ethmoid, frontal, and sphenoid. Next slide, please. So the surgical procedure. 70 patients, that is our 70 cases, middle meatus enterostomy with partial middle turbinectomy was performed. In 15 cases, middle meatus mega enterostomy with ethmoidectomy with partial middle turbinectomy was performed. Medial maxillectomy with Denkers was performed in 40, and in around 15 patients, full house test. Yes, next please. The post-surgical workup, which is like the most important part of our mucormycosis management. It includes repeated debridement, alternate day suction and cleaning, local application of amphotericin ointment and packing, KH mount and HB saline nasal wash, every third day suction and cleaning, even after discharge, followed by weekly follow-up and then monthly. Post-surgery CT MRI, ocular involvement was taken care of, and if required, exenteration was done in excessive involvement cases by ophthalmology department. Patients with extensive palatal involvement were provided with obturator or prosthesis from the dental department. Next, please. So if we talk about the results, as I have already shown in the previous slides, that 100% came with maxillary sinus involvement. Next, please. And we have also talked about the surgical part, that what surgeries we performed in how much cases. Next, please. Also, the medical management was very important, which comprised of amphotericin B and posaconazole. And other than these, the management of blood glucose levels and other comorbidities was of utmost importance. Next, please. So, mucormycosis is the third and most common life-threatening fungal infection and frequently caused by Rhizopus, Lysithemia, or mucor. And we have read in the starting slides that it occurs from spore inhalation or direct inoculation. Diabetics with ketoacidosis are especially prone because they prefer hyperglycemic environment. The spores prefer hyperglycemic environment. After infecting the paranasal sinuses, they spread inferiorly to involve palate, posteriorly sphenoid sinus, or cranially to attack the brain. Treatment was
Ma'am, your time is about to end, ma'am. Please conclude fast. Thank you, ma'am.
The treatment involves amphotericin B and surgical debridement. Repeated suction and cleaning is the mainstay for the disease. Next, please. Just conclusion is left. So hereby concluding my presentation, that rhinoorbital cerebral mucormycosis is a super infection that has been dreadful to the society in this COVID era, and it was an epidemic in an undergoing pandemic. Drug played an important role in this infection. Like steroid intake was seen in majority of cases, though it was a two-edged sword, and post-COVID, immense use of amphotericin B drug has dramatically affected the renal status of the patients, though it was the only mainstay. Next slide, please. Here are my references. Thank you.
Thank you, Dr. Samiksha. Next candidate is Dr. Dhaval. We'll be sharing Dr. Dhaval's slides soon. Dr. Dhaval, are you ready?
Dr. Dawal?
Yes, ma'am. So, good afternoon, respected faculty members. Today I present the mucormycosis. Actually, Today I present the mucormycosis and its correlation to the steroid therapy and high plasma glucose level, oxygen therapy, and vaccination status in post-COVID patients. Next. So, COVID-19 infection caused by the severe acute respiratory syndrome has been associated with a wide range of opportunistic bacterial and fungal infections. Both Aspergillus and Candida have been reported as the main fungal pathogen for co-infection in people with the COVID-19. A COVID-19 pandemic where the corticosteroids are often being used, there has been a steep rise in a case report of the mucormycosis in people with the COVID-19, especially in India. A fatality rate of mucormycosis is very high, especially when the intracranial involvement of mucormycosis increase the fatality rate by more than 90%. Next. So, mucormycosis, a fungal infection caused by the ubiquitous environmental molds, such as a Rhizopus eryzus, Rhizomucor pusillus, and Apophysomyces variabilis. Searching COVID-19 associated infection at the unpredictable rate throughout the India and rising alarm bell around the world. Next. So coming to the risk factor, it is most occur in immunocompromised patients and person who was suffering with diabetes mellitus and organ transplanted patients, stem cell transplanted patients, and intravenous drug abuse patients, and etc. Next. Coming to the pathogenesis, once the mucormycosis once the mucor release the spores, spore inhaled by the persons and it settle down in the paranasal sinuses of the nose. And epithelium of the paranasal sinuses, there is some receptors present, and it catch or its penetration of the COT H protein into this epithelial cell and epithelial cell receptor and making the fungal to germination and reproduce. Once the mature hyphae produce its attack on neutrophils and immunomodulator cells, T cells, and it's produced the interleukins like 4, 10, and 17 interferon gamma. Then it's form a cytokine storm and damage the cell and causes severe infection. Next. So aim is to study the relation of the steroid intake during the COVID-19 infection, high blood glucose level, oxygen requirement during the COVID-19 infections, and the COVID vaccination status of the patients presenting with the mucormycosis, and thus the establishing relations. Next. I did 100 cases admitted in our hospital. All are almost post-COVID-19 infections with the different complaints and signs and symptoms indicating the rhino-orbital cerebral mucormycosis. Complete histories in regard to steroid, diabetic, oxygen requirement, and vaccination status was taken, and all the cases were again screened for the COVID infection and comorbidities like diabetes and hypertension. Next. So history of steroid use, comorbidity is another factor. So out of the 100 cases, I find 92% of the cases who was taken a steroid therapy during her COVID infections. 65% cases, 65% cases are diabetic mellitus patients, and 46% cases who has received oxygen therapy during the COVID infections, and 52% cases are vaccinated. Who has taken one dose or either a 2 dose. Next. So results data from this study show the already
Sir,
we have.
your time is about to end, sir. Please conclude fast. Thank you.
Okay. So results we can also see in previous slide. Just next. 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 Okay, discussion. Mucormycosis is life-threatening infections that. Conclusion. This is the opportunistic fungal infection that is caused due to the mucor hyphae that are commonly available in the soil, plants and ducts, etc. The COVID-19 affected patients who are more susceptible to these infections are immunocompromised, have a diabetic, and are prescribed heavy steroid. Mucormycosis is an angioinvasive property. Once inhaled, its spores begin to grow and fungal hyphae invade the blood vessels, further contributing to the tissue infections, necrosis, and the thrombosis. Next. Okay, so thank you.
Candidate is Dr. Shirin.
Thank you, Principal. Thank you.
Thank you, Dr. Dhaval. Next candidate is Dr. Shirin. Dr. Shirin, please be ready.
Am I audible to you guys? Hello, am I audible? Yes, you are.
Yes, ma'am, you are audible, ma'am.
Thank you. Good afternoon, everyone. I am Dr. Shirin Ansari from SAMES Indore, and under the guidance of Dr. Brajen Desai, sir, I'll be presenting a case report of frontal ethmoidal mucocele with orbital and intracranial extensions.
Excuse me for a minute. We are sharing the slide shortly.
What happened, Shirin? Hello? Hello, Shirin? Yes, ma'am.
Ma'am,
There is some
ma'am,
technical
we are
issue from my side.
sharing her slide shortly, ma'am.
There is a delay.
Kavita? Hello?
Ma'am,
Hello?
we are sharing her slide shortly, ma'am.
Yes.
Ma'am,
Ma'am, there is some glitch, ma'am. It will take 1-2 minutes, ma'am. Please bear with us, ma'am.
Is there any other person after this, or she's the last one?
ma'am, she is the last for this chairing session. Next participants of case series will be chaired by the other judges, ma'am.
So we can start with them only.
Next session start. Okay, there is some delay for Dr. Shirin's presentation. Ma'am, can we start with the next participant for the next session? She will present it later.
No issue. Go ahead.
Ji, ma'am. Thank you, ma'am.
Okay.
We welcome the chairpersons for the next session, Dr. Rima Goswami, Associate Professor HOD BMC Sagar, and Dr. Ritu Nikam, Associate Professor GRMC Gwalior.
Hello? Hello?
Yes, ma'am. Dr. Rima Goswami.
I'm professor. I'm not associate professor.
Sorry, ma'am. Dr. Rima Goswami, Professor of Otorhinolaryngology, joined as the first faculty in Bundelkhand Medical College, the fifth government medical college in state, and since then they played a pivotal role in the setting up of the department and getting postgraduate ENT course started in the department of BMC along with Dr. S.K. People. Next. Dr. Ritu Nikam, Associate Professor GMC Bhopal, MBBS from JNM Medical College Raipur, ENT from GRMC Gwalior, 18.5 years of UG and PG teaching experience, around 15 paper publication, international and national journals. We welcome you, ma'am, for this case series, sharing this session, ma'am. First candidate for this session, Dr. Soumya.
Your PPT has been shared, Dr. Soumya. You can start.
Good afternoon, everyone. I'm presenting my case series on external auditory canal mass lesions and its underlying diseases. Mass lesions within the external auditory canal may cause progressive conjunctive hearing loss, otalgia, or otorium. Primary tumors involving the EAC are extremely rare. Early and accurate diagnosis through histopathological examinations is important for the treatment. Type of study: retrospective study done in the tertiary center Netaji Subhash Chandra Bose Medical College, Jabalpur. The clinical, radiological, and histopathological aspects and surgical interventions taken into account. Introduction: three admitted cases with the EAC lesions are considered. These cases taken are female irrespective of their ages. All patients presented with friable irregular mass which bleeds on touch and obliterating the EAC, post-auricular swelling, otalgia, otoria, and hearing loss. All cases presented with a symptomatic history of 10 to 14 days. First case is taken of the 27-year female with the mass lesion in left ear. Symptoms presented with other common symptoms along with the facial nerve palsy, grade 4, and vertigo. Found dry type on white bone aspiration of the post-auricular swelling. PTA findings were left ear moderately severe conductive hearing loss, right ear mild conductive hearing loss. Radiological findings in HRCT temporal bone were erosion of the anterior wall of EAC, erosion of the petrous part of the temporal bone, erosion of sigmoid plate of the jugular bulb, tegmentum, scutum, and clavus on left side. Soft tissue extension was seen in intracranial region. Its impression was likely towards carcinoma with intracranial extension. Surgery performed was left canal wall down with major columella under GA. OT findings for Tympanomystoidectomy was found carcinoma sac seen with granulation tissue filling in attic, antrum, and Otitis. Middle ear cycles absent, facial nerve canal was eroded. Histopathological findings were consistent with cholesteatoma. Second case taken was 42-year female with the EAC mass in right ear, presented with common symptoms along with a discharging sinus on the post-auricular swelling. 2 ml was aspirated by void-bore needle aspiration from the pluctant point of the post-auricular swelling. PTA finding: right ear moderately severe conductive hearing loss with left ear moderate conductive hearing loss. Radiological findings were erosion of the right mastoid bone extending in etic prosax space and epitympanum, erosion of middle ear cycles, and findings were suggestive of bilateral unsafe or cholesteatoma. Surgery performed was right canal wall down modified radical mastectomy under GA. OT findings were granulation tissue filling in the middle ear cleft, dural dehiscence seen, facial nerve canal was eroded, and all the cycles were absent. Dural pulsations were seen. His HPR findings were granulation tissue consistent with the grade 2 squamous cell carcinoma. Third case taken is of 8-year-old female along with the common symptoms. Patient has the grade 4 facial nerve palsy. Dry type was found in right bone area aspiration. PTA findings were left ear hearing sensitivity within normal limits. Right ear could not be done due to active infection. Radiological findings were erosion of the EAC walls, erosion of the middle ear cycles, tendon of tensor tympani, cochlea, vestibule, semicircular canal, facial nerve canal, mastoid bone, and tegment tympani. Multiple calcific specs seen in mass lesion. Imaging suggestive of neoplastic etiology or unsafe CSOM. Surgery performed was cortical mastoidectomy under GM. Erosion of the mastoid cavity was found. Mastoid cavity filled with granulation tissue, erosion present in the posterior EAC wall, and EAC found atresia. HP is suggestive of of foreign body type granulomatous inflammation. Differential diagnosis of external auditory canal mass lesions. Inflammatory lesions such as cholesteatoma, oral polyp, and granulation tissue are more common diagnoses than the tumorous lesion like mass-like lesions are observed in the EAC. Malignant tumors such as squamous cell carcinoma, lymphoma, basal cell carcinoma, adenoid cystic carcinoma, adenocarcinoma, seromellous carcinoma, and malignant fibrous histiocytoma, or benign tumors such as hemangioma, pleomorphic adenoma, and scleroma should be considered as a differential diagnosis. Hemangioma is one of the most common soft tissue tumor and can be classified into capillary, cavernous, and venous. 26 cases with hemangioma arising with the EAC has been reported in the literature, and most of these cases with histologic type was capillary or cavernous. Lymphomas arising from the EAC extremely rare. To our knowledge, only 10 cases of primary lymphomas arising from the EAC have been reported. Besides the EAC, primary lymphomas have been reported to develop in the internal auditory canal, middle ear, and mastoid cavity in the temporal bone area. And among these, the mastoid and middle ear cavity are known as the most common primary focus of origin. Conclusion: the symptom of EAC mass lesions should be promptly considered for the treatment as the delay may lead to intracranial extension causing irreversible facial nerve palsy. Histological examination is mandatory for the correct diagnosis, and high-resolution temporal bone computed tomography is of great help in delineating the tumor involvement. In some cases, angiography is necessary. Complete surgical excision is the treatment of choice. Here are the references. Thank you.
Thank you so much, Dr. Soumya. It was a very crisp, precise, and nice presentation. Thank you so much. Now, I would like to request the next participant, Dr. Krishna. Kindly be ready with your presentation. We will be displaying your presentation shortly. कौन बचा है? Dr. Monica Barkhane. Am I audible, Dr. Monica?
Yes, ma'am.
Okay, are you ready for your presentation?
Yes, ma'am.
Okay, we are displaying your presentation. Please present it.
A very good afternoon to all the faculty members and consultant. I'm Dr. Monica, presenting case report on bilateral facial palsy in golden heart syndrome. Next slide, please. Next slide, please. In golden eye syndrome, also known as ocular auricular vertebral spectrum or OAV, it was first documented in 1952 by Maurice Goldenhair. He was an ophthalmologist and a general practitioner. The disease is rare congenital condition and it is characterized by abnormal development of the eye, ear, and spine. Next slide, please. The prevalence of the disease is as follows. In worldwide, it is 1 is to 35,000 to 1 is to 56,000 with a male to female predominance of 3 is to 2. In Indian population, it is very low. Out of a study was conducted in which 1073 children were observed, and out of these, only one case was observed as golden hair syndrome. That concludes that the prevalence in Indian population is 0.09%. The abnormalities are found in the unilateral 85% of cases, and in that the right side is more frequently affected, and in 10 to 33% cases, bilateral involvement in C. It is present in 1 is to 1,000 children with congenital deafness. Next slide, please. The ocular abnormalities, especially the bilateral dermoids, are seen in 60% of cases, whereas the vertebral abnormalities, the ear abnormalities are seen in 40% of cases. In most of the cases, deformities only affects one side of the body. The underdevelopment along with the eye, ear abnormalities leads to distinctive facial features for the children with golden hair syndrome. Next slide, please. The etiology of this condition is not yet fully established. Abnormalities of chromosome, neuronuclear cells, the environmental factors including pregnancy, like ingestion of drugs like cocaine, thalidomide, retinoic acid, alcohol, as well as maternal diabetes also has been suggested as an etiological factor. Clinically, the patient will present with a variety of features ranging from the facial abnormalities, ear abnormalities, and vertebral defects and congenital heart problems. Most of the cases have been sporadic, autosomal dominant, autosomal recessive, and multifactorial modes of inheritance have also been suggested. Next slide, please. In this case report, a 35-year-old male reported to our Department of Otorhinolaryngology and Head and Neck Surgery in Canal Medical College, Bhopal. He had a complaint of left ear ache and examination. Bilateral necrosis was present along with left side post-auricular tract. On examination of left side EAC, there was white discharge, which on dry mopping revealed a small central percolation, which was in anterior inferior quadrant. On examination of nose, it was found to be unusually enlarged and normal, and on anterior endoscopy, nothing abnormal was detected. On extraoral examination, bilateral facial palsy was present, bilateral hypoplastic maxilla, as well as bilateral hypoplastic zygoma arch was present. On intraoral examination, there was no cleft palate, no malocclusion was seen. Next slide, please. This is a video. Can you please move to the previous slide? It is a video slide. Can you please play? Previous slide, please. Next slide, please. On ophthalmic examination, the patient revealed the bilateral epicanthus inversus, and on cervical examination, there was soft tissue thickening and mild osteophytic changes were seen. Next slide, please. Next slide, please. Next slide, please. On radiological examination, bilateral nasal cavity was seen, which was found to be sclerosed. There was no history. Previous slide, please. Previous slide, please. This one only. This one only. There was no history of trauma, no head and neck region or maternal exposure to teratogenic agent. No signs of mental retardation or improvement of cognitive function was seen. There is no history of heart disease. The patient has been kept on the regular follow-up and observation for other possible malformation of the craniofacial region or the systemic organs. Next slide, please.
On discussing the disease, the symptoms of the cold heart syndrome can vary, which includes more than one of these features. It can include any spinal abnormality, any thoracic insufficiency, any hemifacial macrosmia, where the tissue of one or both the sides of the face are underdeveloped, particularly in area affecting the ear, mouth, jaws, or area, cleft lip, cleft palate, or any ocular dermoid cyst, microtia, hearing loss, usually 1 year. It can be partial or full deafness at the affected site, any cardiac defects, respiratory issues, kidney or urogenital issues, or any central nervous system defects. Next slide, please. On treating the patient,
Sorry to interrupt,
priority is
but
always
You're running out of time, Dr. Monica.
Yes, ma'am. Our priority is always to minimize the stress of the treatment of the patient. At times, there are careful monitoring to be required. So, at times there can be non-surgical as well as surgical intervention. Facial deformities tends to be less sensitive and can wait until the patient is older and for better prepared. Can you skip to the next slide? Can you go next slide, please? The follow-up is essential. Next slide, please. The follow-up is essential to ensure any problem that is spotted. Next slide, please. The prognosis is good. To conclude, in conclusion, the timely detection and intervention can lead to the satisfactory surgical outcomes. This case has rarely reported features such as congenital bilateral facial nerve palsy, bilateral hypoplastic maxilla, and bilateral hypoplastic zygoma arch, which was present, epicanthus inversus, and ear abnormalities with short stretcher, thus prompting me to report this case. Thank you.
Okay. Thank you so much, Dr. Monica. Now I would like to request Dr. Krishna. Dr. Krishna, am I audible to you? Dr. Krishna, are you there?
Yes.
Okay. Can you, yes, you are audible. You can share your screen yourself and you can present. Dr. Krishna and Dr. Shirin, both of you, you can share your PPTs from your PC only.
Are the slides visible?
Krishna to present, and then after that, Dr. Shirin.
Is the slide visible?
It's under process. It's not visible yet. So do you have a black page, right? You don't have anything on it.
No, it's not a blank page.
Yes, it is visible. Yes, it
No,
is
it's
visible.
not a black page. It's not a black page.
No, you are not visible. Please check your connection whenever. Okay, if you are having connection issues, we cannot extend much.
Please, can you project my slides from here?
I will do that from my laptop, but then first I will call upon Dr. Shirin. It will take time for me to do that, okay? Dr. Shirin, are you ready with your presentation?
Yes, ma'am, I am ready. Am I audible?
Kindly share your screen. Yes, you are audible.
Are
Kindly
my
share
slides
your
visible to you guys?
Yes, your slides are visible.
Okay, good evening, everyone. I'll be presenting a case of frontoethmoidal mucostil with orbital and intracranial extensions under the guidance of Dr.
की वजह से भी कई बार ऐसा होता है
अरे नहीं हो गया ना ये तो my slides are
अरे
visible to
शेयर
you
तो तेरा
guys,
तब
right?
भी हो रहा था लेकिन उनको नहीं दिखाई दे रहा था ग्रे पेज पे कर्सर चल रहा था
It is visible. Somebody else is also speaking. Other people please mute.
Dr. Krishna, please mute yourself. Dr. Krishna, please mute yourself. Okay, Dr. Shirin, now there's no disturbance. You can continue.
Can I continue?
Yes, you can.
Yes, you can continue.
A 61-year-old female came to the ENT OPD with the complaint of left-sided nasal pain, headache, and protrusion of eye since 2 years and left-sided reduced vision since 8 months. The left-sided nasal pain was on and off type aching, neither aggravated or relieved by any factor
associated with anosmia and sneezing. The left-sided headache was predominantly over the left frontal region, dull aching and neither aggravated or relieved by any factor. The left eye protrusion was also insidious in onset, gradual in progression, associated with restriction in eye movements in the left side and drooping of the eyelid in the left side. There was no history of hyperthyroidism. The left eye reduced vision was gradually progressive in nature, not sudden in onset, not associated with redness, pain, or diplopia. There was no history of rhinorrhea or any other associated complaints. Past medical history, the patient was known case of diabetes mellitus since 4 years and had been on medication and follow-up for the same. She also had a history of pterygium surgery in the left eye in April 2021. There was no relevant family or personal history. General examination of the patient was fine. The vitals were okay. There was no signs of pallor, sinus clubbing, lymphadenopathy, or edema. Coming on to the external examination of the nose, there were no obvious deformities or of nasal form seen. No scar, sinus, ulcer, cystic growths. There was broadening of nose on the left side, telecanthus. Cotton wool tests were bilaterally equal, and Cottl's test was negative. We performed a diagnostic nasal endoscopy to see the right and left nasal cavities, and we found that the middle turbinate was bulky and medially pushed. The uncinate process was also prominent. There are others in other examination we found out there was inferior turbinate hypertrophy bilaterally. There was no septal deviation, hematoma, abscess, or perforation seen. The other paranasal sinuses were normal. The ear examination consisted of a right ear large central perforation. The patient did not have any complaint and did not want to get any surgery done for the same. Throat examination, neck examination were normal, and indirect laryngoscopy was also normal. Coming on to the orbital and ocular examination, the left eye, there was proptosis, ptosis present. The visual acuity was reduced to finger counting close to face. And in the right eye, there was 6 by 36, and after dilatation, 6 by 18. The extraocular movements were restricted, as you can see on the small diagram that I have made. There was a keratectomy scar present, and the cataract was also present in the left eye. These are the preoperative pictures of the patient, and there is a small video showing the restricted eye movement in the left eye. In all directions, on all cardinal signs, we can see the patient's eye movement in the left eye is restricted. Coming on to the investigations, the CT paranasal sinus and orbit was done, and the contrast revealed that there was a well-circumscribed lesion, in cystic lesion in the left ethmoidofrontal sinus region, measuring approximately 4 into 5 into 3.2 centimeter. It was causing mass effect and superiorly causing thinning of the indentation of the left half of the cribriform plate protruding into anterior cranial fossa, causing compression of the left basifrontal lobe, medially eroding crista galli, causing remodeling of the nasal septum and pushing it towards narrowing of the right frontal recess. Laterally, it was eroding the medial wall of the orbit, protruding into the extracorneal compartment of the left orbit, compressing laterally and displacing the globe and optic nerve. There was scalloping of the posterior wall of the left frontal bone and extending up to the orbital apex, part of the pterygopalatine fossa and right sphenoid sinus. You can see the diagram showing the abrasion, cribriform plate being eroded and the extracorneal compartments and the orbital compression in this section. So the case summary was an elderly female presented to the ENT OPD with complaints of progressive left nasal pain, headache since 2 years, and left eye protrusion, reduced vision. The examination shows left nasal cavity bulky, pushing medial turbinate, medially confirmed by DNE, showing prominent ulcinate process along with left eye proptosis, ptosis, reduced vision, restricted eye movements, and also a known case of diabetes mellitus. Coming on to the management, complete OT profile was done, and after the pre-anesthetic checkup and final fitness, the patient was planned for endoscopic excision of the frontal ethmoidomucocele. She was kept supine, and a general anesthesia was introduced. Painting and draping was done. Local infiltration was done on the left nasal cavity, axilla, middle turbinate, uncinate. A 0-degree endoscope was introduced for the left nasal cavity.
Please conclude soon. Dr. Shirin, please conclude soon.
I'm showing the video of the uncinectomy. Here you can see the mucocele cavity was opened and all the pus was drained out. We also used a micro debrider to clear the cavity contents. Here I am showing the picture of the dura, a small image showing the dura on the medial side, the anterior ethmoidal artery and the pulsating orbit. On regular follow-up, we found out that the patient had improved vision and proptosis was also improved. And on follow-up, the patient was advised a cataract surgery, which will also improve the vision further. And the final diagnosis was histopathology was chronic sinusitis or frontal ethmoid sinus. Here is the healing mucosa after follow-up. This is the preoperative and post-operative picture of the patient. And this is a video showing the post-op eye movement of the patient, which has markedly improved.
Conclude your time up.
Thank you. Thank you.
Thank you so much, Shri. And I would like to request Dr. Smita Soni ma'am. Since she was the contestant of the last session, I would like to request Dr. Smita Soni ma'am and Dr. Nitish Besakia sir to kindly consider her and give her marks. The next candidate is and I would also like to extend my thank you note to Dr. Smita Soni ma'am and Dr. Nitish Besakia sir for chairing the last case series session. Thank you so much, ma'am and sir, for chairing the session. Now, I would like to request the last candidate of the second case series session, that is Dr. Krishna, to kindly present the presentation. We have displayed the presentation.
Good afternoon, everyone. Myself, Dr. Krishna Valecha, second year PG resident. I am going to present on the topic measuring outcome of cold knife endolaryngeal microsurgery by video stroboscopy as an investigating tool under the guidance of Dr. Yamini Gupta, ma'am, Professor and HOD, MJ Medical College, Indore. Benign vocal fold lesions are the most common cause of hoarseness of voice. The voice function is a multidimensional and any single parameter is not enough to analyze the problem in voice accurately. Hence, we are analyzing video stroboscope as an investigating tool. Stroboscopic imaging of vocal fold vibratory function during phonation continues to play a central role in diagnostic, therapeutic, and surgical decisions during the management and treatment of voice disorders. It is a highly sensitive to detect mucosal vibratory changes. Easy documentation can be done, and hence easy assessment during follow-up can be done. It is repeatable, minimally invasive, acceptable to the population, and comparatively economical. It is a prospective study from study period from 2020 to 2021 with a sample size of 55 patients attending OPD referrals and admissions with the complaint of hoarseness of voice, including the cases from age group of 18 years to 60 years. Participants of study had a history of change in voice, hoarseness of voice, heaviness of voice as a predominant symptom for minimum 3 months. They all underwent voice analysis and stroboscopy and were diagnosed with benign vocal fold lesions. All included cases underwent cold knife endolaryngeal microsurgery with microflap technique. After voice rest for 7 days and voice therapy for 7 weeks, patients were followed till 3 months and reassessed by video stroboscopy. All patients underwent endolaryngeal microsurgery on vocal fold that was performed using controversy operating laryngoscope and 15-degree Strauss endoscope fixed with chest piece over Mayo's chin. 3-chip camera attached with monitor placed in front of the surgeon for wider and clear vision as it is shown in figure 1 and figure 2. In all cases, hydrodissection was done and microflap incision technique was used. After blunt dissection, lesion was excised, remaining mucosa was rewrapped over the vocal fold. The first case is of a 42-year female who was a tailor by occupation with a complaint of change in voice since 1 year. The patient described voice as hoarse, brittle, heavy, and sound of voice varies throughout the day. She cannot talk in phone or customers as people are unable to understand her. History of regurgitation was present. She underwent video-assisted cold knife endolaryngeal surgery, and here are the pictures showing the before and after treatment. On stroboscopic analysis before treatment, we found that the mucosal asymmetry was present, focal absence of mucosal wave at the lesion, and reduced amplitude. Glottic closure was incomplete in the form of hourglass shape. After treatment, after the cold knife endolaryngeal surgery, on stroboscopic analysis, we found that the mucosal symmetry was present. Presence of mucosal wave was there with the normal amplitude, and the glottis closure was complete as shown in the picture. Second case is the case of vocal fold mucus retention cyst. A 34-year male with a complaint of change in voice since 24 months with a history of voice abuse, throat pain, and chest burn. The patient described voice as hoarse, husky, breathy. Sound of voice does not vary throughout the day. His voice was incomprehensible in phone. The patient underwent video-assisted cold knife endolaryngeal surgery. On HPE cyst of the right vocal fold was found.
On stroboscopic analysis before treatment, we found that the mucosal asymmetry was present, focal absence of mucosal wave was there, reduced amplitude on right side, and glottic closure was incomplete in the hourglass shape. After treatment, on stroboscopic analysis, we found that the mucosal symmetry was there. There was a presence of mucosal wave with the normal amplitude, and also the glottic closure was complete with a slight posterior chin as shown. Next is the case of left focal fold nodule. A 30-year male with a complaint of change in voice is 18 months with a history of voice abuse, throat pain, and chest burn. He also underwent video-assisted cold knife endolaryngeal surgery. In this, on stroboscopic analysis also, mucosal asymmetry was present, focal absence of mucosal wave at the site of lesion, reduced amplitude on right side, and also the glottic closure was incomplete. But after the surgery, on stroboscopic analysis, we found that the mucosal symmetry was there, presence of mucosal wave with the normal amplitude, and also there was complete glottic closure, as it is shown in the endoscopic images. So, in this study, we found that the maximum cases were of the vocal fold cyst, and the site of benign vocal fold lesion was the anterior 1/3. The p-value was significant in all the parameters of stroboscopic analysis, and as it is shown in this table and in the graph. Hence, we conclude that video stroboscopy allows high definition, actual visualization of health of vocal cord, minimal instrumentation, and video documentation, which is utmost importance for follow-up of these cases. Here are my references. Thank you so much.
Thank you so much, ma'am. It was a good presentation. With this, we conclude with our case series session. I would like to thank Dr. Reema Goswami, ma'am, and I would also like to thank Dr. Ritu Nigam, ma'am, to chair who spared their time to chair this session. Thank you so much, ma'am. Kindly forward the marks allotted to these candidates to Dr. Kavita Sachdeva, ma'am.
Okay, thank you. Thank you, Dr. Kavita, for organizing this. Thank you so much.
Thank you, ma'am.
Thank you.
Okay, now we will be starting with the e-posters. And for this, I would like to welcome Dr. Sanjay R. Agrawal, sir, HOD, Khandwa Medical College, and Dr. Anirudh Shukla, sir, Associate Professor, NSCB Medical College, Jabalpur. Thank you so much, sir, for chairing this session. I welcome both of you. Now, I would like to request all the candidates to be ready to present their sessions. We will be displaying the posters one by one. The first candidate whose poster will be displayed is Dr. Deepak Mahawar. Sorry, Dr. Deepak Mahavar. Dr. Deepak, am I audible to you? Are you ready?
Yes, ma'am. Hello,
Okay.
I'm Dr. Deepak. I am ready.
Yes, okay. I'm sharing your presentation. Can all the candidates please note that you will be given 3 minutes for your presentation. After that, the slide will be closed on itself. Okay, Dr. Deepak, your slide has been displayed.
Cannot visualize.
Kindly present.
Ma'am, actually the font size is very low, so not visualize it.
Okay. Is it okay now?
Yes, ma'am. Is it, ma'am? It's okay, ma'am. It's okay now.
Yes. Kindly present and be quick.
Good evening, everyone. I am Dr. Deepak Mahavar from MGM Medical College, Indore. Today, I will be going to present my poster on the Goldenhar syndrome, a case report. Goldenhar syndrome is the auriculovertebral syndrome. It is a rare congenital condition arising from the defects in the first and second branchial arches. The incidence is 1:240,000 to 60,000 in male-female ratio 3:2. The etiology is not yet fully established. The abnormalities of the chromosome or the neural crest cells maternal factors during the pregnancy, the ingestion of the drugs such as cocaine, thalidomide, retinoic acid or alcohol during the pregnancy, which can affect the developmental of the disease. The clinical, the patient may present with a variety of the features ranging from the facial abnormalities, ear abnormalities, eye abnormalities, vertebral defects, and the congenital heart problems. A case reports a 10-day postnatal day newborn male was referred to our tertiary health care center with the complaints of regurgitation of the feet, the anomalies of the external ear, the right side facial weakness. It was a term normal vaginal delivered baby cried, which was immediately after the birth. The birth weight was 2.9 kg. On examination, the ear was found then on NOC on the right side, and the microcephaly with the underdeveloped and the superior part of the helix and antihelix on the left side. The left external ear canal was clear, and the tympanic membrane was intact. On facial nerve examination, there was an inability to close the right eye, fully deviated angle of the mouth on crying, and loss of the wrinkling of the forehead on the right side while crying. On ophthalmologic evaluation, the right-sided leg ophthalmos was exposure with exposure keratopathy was noted. No coloboma and a limbal dermoid was seen. On otological examination, the acoustic emissions, there was absence of the TOI and DPOI on the left ear indicates which was abnormal functioning in the outer inner hairs in the cochlea and indicates cochlear pathology. And there was an X-ray spine was exposed, which has the wedge-shaped vertebra noted in the right side of the spine at the 8th thoracic vertebrae level. There is a blurring. And the noted in the right side of the spine at the 8th thoracic vertebra level and of the spine to the ipsilateral side at that level. The intervertebral disc space was seen with the adjacent vertebra above and below, which is suggestive of hemivertebra, fully segmental type with a dextroscoliosis at the 8th vertebral level. One ultrasonography of the fontanelles was within normal limit, and the X-ray abdomen and the echocardiogram was within normal limits. There was no systemic involvement was found in the patient that was usually warrants a good prognosis. And the discussion for this patient was the golden heart syndrome.
Thank you, Dr. Deepak. Your time is up. Thank you for the presentation. Now, I would like to request Dr. Alafia to be ready. Dr. Alafia, are you ready? Can you hear me?
Yes, ma'am.
Okay. I'm displaying your presentation.
Good evening, respected chairpersons. I'm Dr.
Alafia, is your slide visible?
No, it's not visible. Kindly sign in.
Kindly start.
Yes, ma'am. Good evening, respected chairpersons. I'm Dr. Alethia presenting the poster on topic post-temporal bone fracture unilateral facial nerve paralysis, evaluation and surgical exploration under the guidance of Dr. Anil Kumar Jain, sir, Professor in Acute. The incidence of post-traumatic facial nerve injury is 7 to 10%, the commonest mode being road traffic accidents. Traumatic facial palsy may be immediate when the onset begins within hours post-injury or delayed due to secondary ischemia caused by edema in fallopian canal. Facial nerve injuries, if not treated promptly and effectively, can cause permanent disabling facial deformities, which can have devastating psychological impact on a person's life. A 48-year-old male was brought unconscious to the ER following motorbike accident 30 minutes ago with right side ear bleed, fractured clavicle, facial edema, and abrasions. Patient was received by critical care unit, primary support was provided, and patient was intubated and stabilized. There was no history of seizures, vomiting, hypertension, and nasal bleed. Detailed ENT examination was carried out, which revealed right-sided facial paralysis, house Brakeman grade 4 type, abrasions present to a forehead and right pinna. On otoscopic examination, fresh blood clots were present in right external auditory canal. Right TM could not be visualized. Left ear was normal. On investigations, audiometry was suggestive of bilateral mild conductive hearing loss. HRCT temporal bone revealed longitudinal fracture of mastoid and squamous part of right temporal bone with fluid collection in right EAC and mastoid ear cells. MRI temporal region revealed no facial nerve injury till the level of first gen. Facial nerve could not be traced beyond first gen to fluid collection and bleeding. After ruling other head injuries, surgical management was done. Facial nerve decompression via transmastoid approach under general anesthesia was planned. On elevation of musculoperiosteal flap, a fracture line was seen running longitudinally. Canal wall down mastoidectomy done. Facial canal was traced anteromedially to LSC at the level of second genital. Multiple bony fragments and sharp bony spicules impinging on the nerve sheath were dissected gently and removed. Thus, facial nerve paralysis is the most noticeable cranial neuropathy, having tremendous psychological, emotional, and social impact. Management of associated neurological emergency precedes management of facial nerve trauma. Indication and timing of the facial nerve decompression for facial paralysis and the anatomical extent of decompression has always been a subject of controversy. HRCT temporal bone was helpful to us in tracing site and extension of fracture and planning of management. Transmastoid approach was adopted for facial nerve decompression and complete eye closure was achieved post-operatively. Post-operative management included steroid therapy, facial exercises, and appropriate eye care. Hence, we conclude that approach to the management of intratemporal facial paralysis following trauma remains controversial. A criteria for surgical intervention was based on clinical staging of facial nerve injury and presence of fracture line in CT scan. With our experience in the patient and literature review, we conclude that early clinical and radiological assessment in post-traumatic facial nerve palsy and early and appropriate surgical intervention may achieve better results in greater majority of patients.
Dr. Alafia,
Here are my differences. Thank
your
you.
time is up. Thank you for the wonderful presentation.
Thank you.
I would like to request Dr. Sumit Nigle to kindly be ready. I will be projecting your presentation shortly. Also, there is a complaint that the font is so small. So since we don't have to run the presentation, it's just one slide, you can read it from your own PC. Okay, for the convenience, we will just display it.
Okay.
Dr. Sumit, kindly be ready. I am displaying your presentation.
Good evening, everyone.
Dr. Sumit, your slide has been displayed. Kindly present.
Good evening, everyone. Myself, Dr. Sumit Ningwale, second year PG student from MGM Medical College Indore. I'm going to present my e-poster on the topic ototoxicity in MDR-TB patient due to ATT. Multi-drug resistant tuberculosis is defined as a tuberculosis caused by Mycobacterium tuberculosis as in the in vitro effects of isoniazid and rifampicin with or without resistance to any other drugs. The injectable anti-TB drugs like aminoglycosides and polypeptides selectively destroy the basal hair cells of basilar membrane, which are required for high metal ions to produce reactive oxygen species, which in turn damage the cells through oxidative process. The aim of our study is to document the incidence and severity of the ototoxicity in MDR-TB patients receiving Category 4 treatment under the received National Tuberculosis Control Program. This study was carried on proven cases of MDR-TB patients attending the OPD of ENT from August 2022 to January 2022 were included. All the patients were subjected to detailed history-taking clinical examination. First 3 months of the study were pre-treatment basement audiogram were recorded by pure to audiometry and repeat audiogram was done after 6 months and 9 months. Total 25 patients were evaluated for the development of ototoxicity for a period of 6 months. Coming to the result, out of 25 patients, 8 patients developed ototoxicity with incidence of 35%. A threshold shift greater than 10 decibel in bound condition was considered as significant hearing loss. Categorization of hearing loss of total 8 patients according to the hearing disability. Out of 8 patients, hearing loss of 4 patients was within the normal limit. 2 were having mild hearing loss, 1 was having moderate hearing loss, and 1 was having severe hearing loss. Coming to the discussion, tuberculosis has been existed for millennium and remains as a major global health threat. Long-term treatment of MDR-TB often results in the development of the side effects that affect the patient health condition. The treatment of drug-resistant TB necessitates the use of second-line injectable anti-TB drugs which are associated with the hearing loss. The aminoglycoside group is a major drugs group which is used in the treatment of patients with MDR-TB and can lead to the irreversible hearing loss. The use of aminoglycoside is itself troublesome in MDR-TB. In our study, out of 25 patients, 8 patients developed ototoxicity with incidence of 35% at the end of the study. It has been noted that the loss of 4,000 hertz can affect the communication where there is a background noise, even though it is not a speech frequency. This shows that there is a high level of affectation of patient speech and communication with the second line of medication. Despite of this, kanamycin is still commonly used in the clinical settings like ours in developing clinic for MDR-TB, where the cost consideration are major factor in the patient compliance. Monitoring of the hearing loss after the baseline has been recommended 1 to 2 times per week for the patient receiving ototoxic antibiotics. Protection against the ototoxic may be achieved by reducing the availability of iron using chelators such as desferrozamine, dihydroxybenzoate. This may lead to dramatic reduction of aminoglycoside ototoxicity. Coming to the conclusion, in our study, we concluded that the effect of aminoglycoside on hearing in patients receiving second-line ATT is serious challenge as there is a high prevalence of MDR-TB in our environment. The high-frequency hearing loss was most common hearing impairment in MDR-TB patients, followed by hearing impairment across all frequencies. As hearing loss in this patient is permanent, careful audiological monitoring should be done regularly. Early identification of ototoxicity and institution of another regime may be done. Ototoxicity may be also reduced by use of autoproductive agents. Thank you.
Thank you so much. Thank you so much, Dr. Sumit. Now I would like to request Dr. Abhishek to kindly be ready. We will be sharing your PPT. And for your own convenience, kindly read it from your own laptop. We will just project the slide. Dr. Abhishek, your slide has been shared. Kindly present.
Okay. Thank you. Good evening, everyone. Myself, Dr. Abhishek. My topic for e-poster today would be adequoantral disease with microtia, a surgical challenge. For introduction, disorders of pinna and external auditory canal are common entity in clinical otology. Congenital cholesteatoma is a rare entity in routine clinical practice. Secondary otitis media makes it further difficult to diagnose it. CT scan in cases of congenital oral atresia also helps prognostically to predict the outcome of surgical correction. Now, a set of case series, a retrospective case series of 3 cases of squamosal chronic otitis media with unilateral congenital ear deformities who visited ENT OPD in our tertiary care center within the period of 11 months. All patients had atretic external auditory canals with hearing loss. Following routine investigations, Puritan audiometry, otoendoscopy, HRCT temporal bone was done, and mastoid exploration with canal reconstruction was planned under general anesthesia. Key findings were all 3 patients had hearing loss ranging from moderately severe to severe conductive hearing loss. Evidence of ear pain and low set ears were present in all 3 patients. In 2 patients, there was evidence of mastoid abscess with discharging sinus post-orally, and grade 3 facial nerve palsy was also present. The anatomy of middle ear structures was seen to be distorted with all cases showing absence of ear ossicles. Evidence of cholesteatoma was evident in all the patients. Now, the operative management, combinations of cortical mastoidectomy, modified radical mastoidectomy, tympanoplasty with cartilage ossiculoplasty, flap reconstruction and exteriorization of mastoid cavity was performed. To delineate the atretic EAC, anteriorly the temporomandibular joint was palpated. Posteriorly, the sinus and dural plates were identified following mastoid drilling to trace the EAC, as no cartilaginous landmarks are discernible. In the middle ear, facial nerve was seen to be dehiscent and exposed in 2 cases. Cholesteatoma was removed from mastoid cavity, and no ossicles or eustachian tube openings were seen. A new external auditory canal was made by flap reconstruction. The EAC and mastoid cavities were unified and saucerized. Post-operative results, after 2 months of surgery, healed external auditory canal was seen. Patients showed improvement in hearing loss with reduction in underlying symptoms. Now, the conclusion would be patients with congenital ear deformities prove to be challenging candidates for surgery as normal anatomy of the external and middle ear is distorted. Patients with microtia presenting with pain in ear could be harboring an underlying cholesteatoma or mastoid abscess. Hence, HRCT temporal bone is warranted in all the cases. The islands of underdeveloped cartilages need to be left until end and then excised. The bony landmarks need to be followed to trace the atretic external auditory canal. So posteriorly, the sinus and dural plates, and anteriorly, the temporomandibular joint needs to be identified correctly. Tympanoplasty with cartilage ossiculoplasty and flap reconstruction with the flaps sutured inward onto the newly reconstructed canal ensures graft stability, better conduction of the sound to inner ear, and a well-ventilated external auditory
Dr.
canal.
Abhishek,
Thank you.
Dr. Abhishek, your time is up. That was a beautiful poster presentation. Thank you.
Thank you, ma'am.
Now I would like to request Dr. Dipankar to kindly be ready. We will be sharing your presentation shortly. Dr. Dipankar, your presentation has been shared.
Uh, Good evening, everyone. My topic for today's poster presentation is foreign body in external auditory canal causing subperiosteal abscess. 11-year-old male child with intellectual disorder presented in a casualty with facial swelling on the right side, as well as the swelling is on the right post-auricular area since 4 days. At the day of presentation, whiteboard aspiration done, more than 80 ml of pus is drained, and pus is sent for culture and sensitivity. On examination, diffuse swelling in right post-auricular area about 15 centimeter into 10 centimeter, extending to the right half of the head, occiput and frontal areas, leading to the closure of the right eye. Tympanic membrane was not visualized bilaterally due to the pus present on the right side. A lighthouse sign was present and wax on the left side. For investigations and finding, apart from the routine investigations, automicroscopy done for this patient, multiple setting of automicroscopy was needed. Pus is suctioned out initially, then we find on the right side multiple organic and inorganic foreign bodies. These were removed in multiple settings. After the removal of foreign bodies, right tympanic membrane was found to be severely inflamed and congested. On the left side, foreign body which is embedded deep within the tympanic membrane is seen in the posterior superior region. Since the patient is a child, the pure tone audiometry is inconclusive and BERA could not be done in our college. HRCT temporal bone, tympanic membrane could not be assessed bilaterally. Bilateral chronic otomastoiditis is present with the right side greater than left side. Large fluid collection in subcutaneous and intramuscular plane of the right parieto-temporomastoid measuring 23 millimeter thickness, communicating with the lateral mastoid due to bony erosion. Pus culture was sent for pus culture done from the pus obtained from the subperiosteal region. The organism found was Staphylococcus, which is sensitive to clindamycin. CB net was negative. Whiteboard, apart from the whiteboard needle aspiration and automicroscopy, incision and drainage was done to remove the pus. Around 100 ml was pus was drained through the incision on the right parieto-temporo-occipitomastoid area. For the treatment of this patient, our right side modified radical mastoidectomy with type 3 tympanoplasty under general anesthesia is performed. The patient's general condition improved dramatically after operation with proper eye opening. Inferences neglected, unnoticed, long-standing foreign body in external auditory canal can be the cause of unsafe ear, especially in the small children, and may present with life-threatening complications, which on prompt and timely management will be life-saving. Thank you.
Thank you so much, Dr. Dipankar. It was a great presentation. With this, we have concluded the section of the poster presentation. I would like to thank Dr. Sanjay R. Agrawal, sir, and Dr. Anirudh Shukla, sir, for chairing this session. Thank you so much, sir.
Thank you very
Kindly
much, ma'am,
forward
for
the marks
inviting us.
allotted to the...
Ma'am, thank you so much for inviting us for this session. And all the participants have done fantastically in this session. I congratulate all the participants. Thank you, ma'am.
Thank you so much, sir. Thank you, sir. And I would request the chairpersons to kindly send the marks allotted to candidates to Dr. Kavita Sachdeva, ma'am. Now we'll be starting the next section of the e-poster, that is the head and neck section. From that, I would like to request the first candidate, Dr. Ankit Kumar Tiwari, to be ready. Dr. Ankit, are you ready?
Yes, ma'am.
Dr. Ankit? Okay.
Yes, yes, I'm ready.
We'll be projecting your slide. Kindly present it.
Okay.
Dr. Ankit, I'm doing it. Okay, Dr. Ankit, your slide has been shared. Kindly start the presentation.
Okay. Good evening to all. Today I'm going to present e-poster on the local skin flap in head and neck cancer, our experience. The introduction is the local skin flap can be used for reconstruction of intraoral, mucosal or facial skin defect caused by the tumor. Mucosal, skin and bone reconstruction can be done in head and neck and face region. The aim of the study is to evaluate the effectiveness of the local skin flap reconstruction in head and neck tumor in terms of the graft uptake, functional outcome, and cosmetic acceptance. Method and methodology: 12 patients with oral lesion like erythroplakic, leukoplakic, ulcerative proliferative lesion, verrucous lesion at the ella of the nose and nasal tip, gingivobuccal sulcus, parotid region came to our department. The lesion is confirmed by the biopsy, and primary excision was done and reconstruction done with the flap, and the patient sent for the radiotherapy and concurrent chemotherapy for the to reduce the recurrence of the disease. Out of 12, 5 have basal cell carcinoma, 3 has squamous cell carcinoma, 3 has verrucous carcinoma, 1 has low grade malignancy. These are the some photographs which are showing the pre-op picture and intra-op picture of the cases. Now come to the observation and result. In all the cases, good cosmetic and functional outcome were seen. Nasolabial flap was the most commonly used flap. Wound infection, dehiscence of the flap, flap necrosis, flap rejection, orocutaneous fistula, and disease recurrence and trismus did not occur in any case. Cosmetic and functional results were also good in all the patients. So the conclusion is that the local skin flap is good for flap for the reconstruction of a small orofacial lesion after excision of the primary tumor with good cosmetic and functional outcomes. The take-home message is whether big or small, facial defects should be reconstructed as it boosts the confidence of the patient and because of the क्योंकि चेहरा में इनका बना हुआ है. So much. And my references given below in the slide. Thank you.
Thank you so much, Dr. Ankit. Sorry, but it seems that our chairpersons are not with us at present. I would like to welcome Dr. I would like to welcome Dr. Aparajita Mundra ma'am and Dr. Ruchir Varshney sir. Dr. Aparajita Mundra ma'am is assistant professor at MGM Indore College, and Dr. Ruchir Varshney sir, assistant professor, Chirayu Medical College, Bhopal. Respected ma'am and sir, I welcome you for chairing this during the session of the head and neck. For chairing the head and neck section of the e-poster. I would like to request Dr. Farhan Alam Khan to be ready. Dr. Farhan. Respected chairpersons, may I please ask, have you assessed Dr. Ankit Kumar Tiwari, who has just presented the poster?
No, I was just asked right now.
Okay. Ji ma'am. Okay, okay. Ma'am, I'll ask him to kindly present it again.
Okay.
Ji ma'am. Dr. Ankit, sorry for the inconvenience, but can you please present your poster again?
Yes, ma'am. Yes, I can do. Now I will start.
Yes, yes. Ma'am and sir, can they start?
Yes, yes.
Yes.
Good evening to all of you. Today I'm going to present my e-poster. The topic is local skin flap in head and neck cancer, our experience. The introduction. The local skin flap can be used for reconstruction of the intraoral mucosal and facial skin defect, which is caused by the tumor. Mucosal, skin and bony reconstruction can be done in head and neck and face region. Aim of the study is to evaluate the effectiveness of the local skin flap reconstruction in head and neck tumor in terms of the graft uptake, functional outcome, and cosmetic acceptance. Methodology: 12 patients with oral lesion like retroplakic, leukoplakic, ulceroproliferative lesion, varicose lesion at the L of the nose and nasal tip, gingivobuccal sulcus, and parotid lesion came to our department, which is the lesion is confirmed by the biopsy, and the primary excision was done and reconstruction done with the flap, with the help of flap, and sent for the patient for the radiotherapy, concurrent radiotherapy and chemotherapy to prevent the recurrence. Out of 12, 5 has basal cell carcinoma, 3 has squamous cell carcinoma, 3 has varicose carcinoma, 1 has low-grade malignancy. These are the some photographs which are showing the pre-op picture and intra-op picture and post-op picture of the patient. Now coming to the observation and result. In all the cases, good cosmetic and functional outcome were seen. In all cases, nasolabial flap was the most commonly used flap. Wound infection, dehiscence of the flap, flap necrosis, flap rejection, orocutaneous fistula, and disease recurrence and trismus did not occur in any patient. Cosmetic and functional results were good in all the patients. So now conclusion, local skin flap is good flap for the reconstruction of a small orofacial defect after excision of the primary tumor and with good cosmetic and functional outcome. The take home message is whether big or small, facial defects should be reconstructed as it boosts the confidence of the patient and क्योंकि चेहरा मन का आईना होता है. Thank you so much, and the references are given below in the slide. Thank you so much.
Thank you so much, Dr. Ankit. Okay, now I would like to request Dr. Farhan to be ready. Dr. Farhan, are you ready? Dr. Farhan, are you ready? Okay, so you can present it later. Right now, I'm going to present the slide of Dr. Lakshmi. Dr. Lakshmi, are you ready?
Yes, ma'am. Ma'am, Dr. Farhan.
Sorry. Okay, Dr. Farhan, you are there.
Yes, ma'am.
I'm presenting your presentation now. Dr. Anjali, your slide has been shared. Kindly present the
Good evening to respected chairpersons. I am Dr. Farhan Khan presenting e-poster on paraganglioma of neck in middle-aged male, evaluation and management under the guidance of Dr. Anil Kumar Jain sir. Paragangliomas of the head and neck represent rare tumors of neural crest origin comprising of less than 0.5% of all head and neck tumors. Approximately 3% occur in the head and neck area. They are benign in majority of cases in the head and neck. They commonly arise from the carotid body, tympanojugular and vagal. In case, a 33-year-old male presented to the ENT OPD with the complaints of swelling on the right side of neck since 2 years, no history of dysphagia, dyspnea, fever, weight loss, ulcer in oral cavity, and change in voice. On examination, the patient had a swelling on right side of neck extending from angle of mandible up to supraclavicular region, 10 into 6 cm in size, ovoid in shape, non-tender, smooth surface, well-defined rounded margins, firm in consistency, non-fluctuant, non-transluminant, non-compressible, non-reducible, no lymphadenopathy present. On indirect laryngoscopy, bilateral vocal cord mobile, no definite evidence of any growth. On radiological evaluation, USG neck showing well-defined heterogeneously hypoechoic mass lesion on right side having minimal vascularity, On MRI neck study, a well-defined heterogeneous mass on the right side posterior to carotid vessels, which suggestive of neoplastic lesions, mostly neurogenic stroma. FNAC report suggestive of benign spindle cell lesion. All pre-op routine investigations are within normal limits. The management is surgical, curvilinear incision given on junction of upper 1/3 and lower 2/3 of neck swelling, grayish white colored capsule, encapsulated mass which is posteromedial to sternocleidomastoid muscle and posterolateral to carotid vessels. Capsule of mass is arising from nerve sheath. Mass approx 9 into 6 centimeter excised. Major neurovascular structure were preserved. The post-op period was uneventful. Post-op histopath report suggestive of highly vascular area with nuclear palisade and verrucous body in anatomy areas with suggestive of bigger schwannoma. In discussions, schwannomas of neck is a rare type of paraganglioma. Patients with cervical paragangliomas frequently present with a painless, slowly enlarging mass in radial side of neck. The involvement of the cranial nerves, especially to the vagus and hypoglossal, occur in 10% of the cases. These slow-growing tumors are mostly benign. However, malignant transformation may occur in up to 10% of cases. Evaluation by an imaging modality is necessary to establish the diagnosis. In conclusion part, the approach to management of cervical paraganglioma depend on the number of factors that include clinical observation and potential morbidity of surgery, which places cranial nerves at risk. From the literature review and our experience in patient, we conclude that in early stage cervical paraganglioma with low risk of surgical complications, primary resection for cure is recommended, which followed by the references part. Thank you.
Thank you so much, Dr. Farhan. Now I would like to request Dr. Anjali to please be ready. I'll be displaying your presentation shortly. Dr. Anjali, your poster has been shared. Kindly start presenting.
Good evening, everyone. My topic is spindle cell tumor of the parapharyngeal space. Introduction. Parapharyngeal space tumors account for 0.5% of all head and neck masses. Of this, 82% are benign and 18% are malignant. Case presentation. 60-year-old female presented with a swelling below left ear for the past 10 years. It was insidious in onset, slowly progressive. She had difficulty in swallowing and voice change since 1 month before presentation. Patient had no comorbidities. In the first picture, you can see the infraauricular swelling, and the second picture, you can see the palatal bulge. Examination, a swelling of size 5.5 into 6 centimeters square in the right infraauricular area, soft to firm consistency, non-tender, cystic, non-transilluminate with restricted mobility. Palatal bulge present on the right side, uvula pushed to the left. Investigations, UST guided FNAC of the right infraauricular swelling showed benign inflammatory cystic lesion. MRI neck with contrast, well-defined expansion lesion with fluid level seen arising from the right greater wing of sphenoid, protruding medially into oral cavity with displacement of tonsilla fossa. Posteriorly, it displaces carotid and jugular vessels, and laterally it extends into the parotid space. In the first picture, you can see the cystic lesion pushing the posterior pharyngeal wall, and in the second picture, you can see the dumbbell shape of the tumor pushing the tonsillar fossa medially. And in the third picture, you can see the extension of the tumor into the skull base. Surgical management. Cyst was excised using transparotid approach using a modified Blair's incision. Cyst was seen attached to the greater wing of right sphenoid. Intraoperatively, cyst ruptured and chocolate-colored fluid came out. Cavity was washed and drain was put in cavity. Post-op period was uneventful. In the first picture, you can see the modified Blair's incision, and second picture shows the post-op specimen, which is the ruptured cyst. Post-op HPR showed spindle cell tumor. Discussion. Parapharyngeal space is an area of complex anatomic relationships, and it is difficult to obtain surgical experience in this region. MRI and CT helps to localize to find the origin and extension of the tumor that helps in planning the surgical approach. Surgery can be performed by a transparotid approach with no need of major reconstructive procedures. Conclusion, parapharyngeal tumors, though rare, should be considered as a differential diagnosis in case of swelling in parotid area. Preoperative planning is essential in view of vital structures in relation to the mass. Thank you.
Thank you so much, Dr. Anjali. It was a beautiful presentation. I would like to request Dr. Krishna Valecha to be ready. Dr. Krishna, are you ready?
Yes, ma'am.
I would like to request all the students to please wait for the results, as the results will be shortly declared of every competitions held today. And also, I would like to request Dr. Krishna
Yes,
to
ma'am.
present your presentation. I am presenting your slides. Okay.
Yes, ma'am.
Dr. Krishna, your slide has been shared. Kindly start presenting.
Thank you, ma'am. Good evening, everyone. Myself, Dr. Krishna Valecha, second year postgraduate student at Department of ENT at MGM Medical College. I am going to present my e-poster on role of neck triangles in safe thyroid surgeries. Thyroid surgeries are commonly performed by head and neck surgeons. The first thyroid surgery was performed by Cocker in 1912. The most important thing about thyroid surgery is meticulous dissection needed to preserve the two nerves, that is the recurrent laryngeal nerve and external branch of superior laryngeal nerve. The most dreaded complication during thyroid surgery is the injury to recurrent laryngeal nerve. Actually, the course of recurrent laryngeal nerve and superior laryngeal nerve are highly variable. It is hence difficult to identify these structures during routine surgeries. Therefore, various triangles have been described with the hope that they will help the surgeons in identifying these nerves. Hereby, we are starting with the triangles. First is the Beer's triangle. This triangle is also known as Riddle's triangle. This was first described by O.H. Beers. The triangle is used to identify the recurrent laryngeal nerve close to the tracheoesophageal groove. Recurrent laryngeal nerve forms the one side of this triangle, while the other two sides are formed by the common carotid artery and the inferior thyroid artery. The recurrent laryngeal nerve forms the lower arm of this triangle. The most accurate and safe way of identification of this nerve is to seek it low down in the tracheoesophageal groove. Next is the Joll's triangle, which is also known as sternothyrolaryngeal triangle. This triangle is used to identify the external branch of superior laryngeal nerve. The nerve lies in the Joll's triangle. The upper pole of thyroid gland and the superior thyroid vessels forms the lateral border, while superiorly there is attachment of strap muscles. Floor of Joll's triangle is formed by the cricothyroid muscle. Next triangle to identify the recurrent laryngeal nerve is the Simon's triangle. The anterior border of this triangle is formed by the recurrent laryngeal nerve and posterior border is formed by the common carotid artery. Base of Simon's triangle is formed by the cricothyroid muscle. Next is the Lord's triangle. It is also used in the identification of recurrent laryngeal nerve. In this triangle, the medial border is formed by the trachea and esophagus. Lateral lies the common carotid artery. Superiorly lies the inferior pole of thyroid gland. Next is the triangle of concern. It warns the surgeon during thyroid surgery about the most vascular and dangerous areas of surgical procedure. It is the commonest site of bleeding in thyroidectomy. Next is the cricothyroid space of Reeves. It is a avascular space between the upper pole of thyroid and the cricothyroid muscle. Dissection confined to this area helps the surgeon in avoiding injury to the surrounding and important structures like the superior laryngeal nerve. Through this poster, my take-home message is that various triangles in the neck have been described to identify the vital structures during thyroid surgery.
Krishna, your time is up. Thank you so much for the wonderful presentation. Now, I would like to request Dr. Meenakshi Ambulkar to please be ready. Dr. Meenakshi, are you ready? Dr. Meenakshi?
Yes.
Okay, I am about to display your poster. Kindly be ready.
Okay. अंकित सर का बोलते ना उसको टीचर सर मेरा डाक ये है ना कौन सा बोल रहा है बोल क्या बोलना अपना नाम बोलना है
Okay, Dr. Meenakshi, your slide has been displayed. You can start presenting.
Okay. Good evening to all. Myself, Dr. Meenakshi Gupta from Gandhi Medical College, Bhopal. I am going to present a poster on an interesting case of knotted Ryer's tube. For introduction, Ryer's tube are widely used in medical practice. Complications associated with Ryer's tube are usually either during RT insertion or removal. Spontaneous true knot formation in the tube is rarely encountered, but if undiagnosed can cause serious complications. Although knotting of the Ryer's tube has been reported, but its incidence is very low. There was a 9-year-old female came to ENT OPD for follow-up and Ryer's tube removal post-esophagoscopic post-esophagoscopic battery removal. 2 to 3 attempts were made to pull the Ryer's tube, but it was failed to be removed. Chest X-ray was done showing a knot in the Ryer's tube in the stomach. Esophagoscopic guided Ryer's tube removal was planned. Several attempts were made to loosen the knot and Ryer's tube removal via rigid esophagoscope, but failed. After consulting with consultant general surgery, gastrotomy was planned. Midline vertical incision given over anterior abdominal wall and stomach, visualized, and rectangular flap elevated near greater curvature. Ryer's tube was taken out and not visualized. The knot was then released and Ryer's tube was taken out. Patient was then observed for 10 days post-operatively and was discharged after suture removal. For discussion, awareness of possible complications related to Ryer's tube will help improve patients' outcomes. Ryer's tube knotting is a rare complication with the potential to cause significant trauma on tube removal if unrecognized. Risk factors include the length of the tube, smaller diameter tubes, insertion deep into the stomach. This case report serves as a reminder to clinicians of a rare but possible complication which could be avoided. Large Ryer's tube caliber as well as approximate RT length based on external measurement from the ear lobule to tip of nose and up to Zifi sternum can decrease the chances of Ryer's tube knotting. Thank you so much.
Thank you so much, Dr. Meenakshi. Okay, thank you so much, Dr. Meenakshi, for the wonderful presentation. With this, we have concluded the head and neck section of the poster presentation. I would like to thank Dr. Aparajita Mundra ma'am and Dr. Ruchir Varshney sir to chair this session. Ma'am and sir, kindly send the marks you have allotted to these candidates to Dr. Kavita Sachdeva ma'am. Now, I would like to announce the starting of the next section of the e-poster, that is the nose and the laryngology section. I would like to welcome Dr. Pawan Kumar Sharma, sir, HOD, HOD of Ratlam Medical College. We welcome you, sir, for chairing this session. And I would like to welcome Dr. Aditya Gargava, sir, who is Associate Professor, Atal Bihari Vajpayee Medical College, Vidisha. Heartiest welcome, sir, and I thank you both for chairing this session. Now, I would like to request and I would like to welcome Dr. Izhar, sir, also for chairing this session, who is from Medical College, Shahdol. Thank you, all the chairpersons and all the candidates. Please be ready. The first candidate in this section is Dr. Ritu Rani Vinodia. Dr. Ritu, are you ready?
Yes, ma'am. Yes, ma'am.
Okay, I'm displaying your presentation shortly.
Yes, ma'am.
Okay, Dr. Ritu, your slide has been displayed. Kindly start presenting.
Sure, ma'am. Good evening, everyone. I'm presenting an uncommon case of ossifying fibroma of maxilla. Introduction: ossifying fibroma is classified as a rare benign fibro-osseous lesion occurring most commonly in tooth-bearing areas, with prevalence in the lower jaw up to 90% and male to female ratio of 1:5. Mandible is more commonly affected than maxilla. Ossifying fibroma arising from the anterior part of the maxilla is rare, only 7%, usually smaller than 1.5 centimeter in diameter. Here reporting an uncommon case of huge ossifying fibroma.
A 17-year-old female came to ENT OPD with a complaint of 18-month history of a progressive non-painless swelling in left cheek. There was no history of trauma and fever. Swelling was firm, fixed, non-tender, approximately 6 into 4 into 4 centimeter in size. And on examining intraorally, firm swelling was present with normal overlying mucosa with broadening of alveolar ridge. A thorough ENT examination was done and the patient was admitted. After all the routine investigation and radiological investigation, excision under GA had been planned. On imaging, CT phase was suggestive of expansile hypodense solid cystic lesion, approximately 6.5 into 3.6 into 4.5 centimeter, showing peripheral calcific foci extending into left maxillary sinus, causing extensive cortical thickening of its anterior wall, anteriorly obliterating left nasolabial and nasomaxillary folds and bulging the overlying skin, medially extending into left maxillary antrum, laterally reaching up to zygomatic process of maxilla, superiorly reaching up to floor of the left orbit, inferiorly reaching below the level of the angle of the mandible. It was managed surgically under general anesthesia. Total resection was performed intraorally via Caldwell-Luck approach. Tumor was found to be attached to periosteum of the maxilla. Anterior wall of the maxilla was eroded. Tumor excised in toto as the margins were well defined, and it was sent for HP. Maxillary enterostomy done endoscopically. As there was no major aesthetic and functional losses, reconstructive surgery was not required in the area of residual bone defect. HP was suggestive of ossifying fibroma. Patient is currently with 3 months of uneventful post-operative follow-up without recurrence. My conclusion is ossifying fibroma of such a large size as presented in our case is rarely encountered, and surgical management of ossifying fibroma was possible by intraoral approach, even taking into account the limitation of the axis and complexity of the anatomy of facial bones involved. Ossifying fibroma, although a rare tumor, but occurs, so one should keep them in mind as a differential diagnosis while evaluating a maxillary swelling. Thank you.
Thank you so much. Thank you so much, Dr. Ritu. Now I would like to request Dr. Soumya to kindly be ready with her presentation. Dr. Soumya, your presentation has been displayed. Kindly start presenting.
Good evening,
क्या है
all.
जब तुम किसी घर में जाओगे ना स्टेथो है ना टॉर्च क्या देख के करेंगे हम टाइम पास दवाई हो तुम कोई भी मेडिकल वाले से देगा ले लो दर्द की दवाई
Mute yourself.
फिर सदभाव
Candidates,
कहाँ
all
सतनाम में
candidates, kindly mute yourself.
1 से 4 दोपहर में 1 से 4 ठीक है ले आना वहीं हाँ हेलो हाँ प्लीज कंटिन्यू द सेशन
Dr. Soumya, kindly continue with your presentation.
Good evening. I'm presenting my e-poster odontogenic keratocyst. Introduction. Odontogenic keratocysts are benign intraosseous lesions of odontogenic origin that account for about 10% of jaw cysts. They are characterized by an aggressive behavior with a relatively high recurrence rate. Case presentation. A 54-year-old male presented with left cheek swelling since 2.5 years and left upper toothache since 7 months. Patient has the comorbidities of hypertension and diabetes. On examination, patient had the swelling on the cheek, which was hard, tender, non-mobile, non-fluctuant, with the smooth boundaries of size 5 to 4 centimeters square. The gum swelling was firm to hard from the left upper jaw canine till the last molar. Investigations which were done were orthopentamogram. There is an expansile unilocular lucent lesion in the left maxillary region with the well-corticated margin. Cytopathology. The smears are paucicellular. Smear shows group of cells having hyperchromatic nuclei and abundant vacuolated cytoplasm. Cone beam computed tomography. The buccal cortical plate and palatal cortical thinning, extension till the left maxillary sinus, destruction of the left nasal lateral wall, paraapical pathology. Surgical interventions, debulking by the Denkel's approach through sublabial incision, anterior wall of maxilla is removed, partially destructed embedded third molar was removed. Post-op HPR report is suggestive of odontogenic tumor. Differential diagnosis can be ameloblastoma, simple bone cyst, dentigerous cyst, radicular cyst. Conclusions, Odontogenic keratosis should be taken for intervention at earliest as it is a locally aggressive benign disease and can involve orbital region superiorly, compromising the vision. The cosmetic issue may arise as a delayed operation may require facial incisions. Thank you. References are here.
Thank you so much, Dr. Soumya. It was a wonderful performance. Now, I would like to request Dr. Ankita Singh to kindly be ready. Dr. Ankita, are you ready? Dr. Ankita?
Yes, I'm ready.
Okay, I am about to
I'm
display
ready.
your. Okay. I'm about to display your presentation. Dr. Ankita, your presentation has been displayed. Kindly start presenting.
Good afternoon, everyone. Today I'll be presenting my e-poster over the topic Transnasal Endoscopic Cooperator-Assisted Excision of Juvenile Nasopharyngeal Angiofibroma, a case series. The juvenile nasopharyngeal angiofibroma, it's a rare, benign, and highly vascular and locally aggressive tumor, generally seen in pre-pubertal and mainly targeted to male adolescents. The objective of the study was to see the role and outcome of cooperator-assisted excision of JNA. In our observation, a retrospective study of 4 cases of probable JNA who visited in our OPD in tertiary care center within the period of 7 months, June to December 2021. These patients were young males with complaints of frank epistaxis. All patients were thoroughly examined, radiological investigations were done, and these patients underwent endoscopic transnasal cooperator-assisted surgery belonging to 1A to 2C staging of Radowski. In our observation, the cooperator assisted excision offered following advantages. It allowed controlled debulking of tumor with improved and magnified view, and there was minimal blood loss and lesser number of instruments were required. There was minimal damage to adjacent tissues, and there was lesser hospital stay and morbidity and minimal scarring to the patients. In my conclusion of the study is that transnasal cooperator-assisted excision proved to be the better method for tumor excision and control of bleeding with better visualization, lesser post-operative morbidity and recurrence compared to traditionally done transpalatal and lateral anatomy approaches. These are the following references. In the picture, we can see first the CT finding of the patient, where we can see the mass occupying the right nasal cavity and the pterygopalatine fossa. The second picture, we can see the use of the cooperator, and this is the post-op picture and the final specimen removed. Thank you so much.
Thank you so much, Dr. Ankita. Now, I would like to request Dr. Rajendra Bharti to be ready. Are you ready? Dr. Rajendra?
Yes, ma'am.
Okay, I am displaying your presentation. Okay, your presentation has been shared. Kindly start.
Good evening, everyone. I am presenting a case of frontal lymphoidal mucophyseal with unilateral proptosis. Mucophyseal are slowly expanding cystic lesion with respiratory epithelium containing mucus, most commonly affecting the frontal sinus and ethmoidal sinuses. They are caused by obstruction of sinus ostium. The occlusion of the ostium may be secondary to congenital anomalies, allergy, infection, and trauma intervention. Intervention in the nose and neoplasm of metastatic tumor. Even benign, they have tendency to expand, and they can they displace the destroyed structure by pressure and bone resorption. Swellings in 6 months. On examination, found diplopia, restricted eye movement, proptosis. Investigation we have done a CT scan PNS with orbit was suggestive of huge cystic swelling seen in the left frontal sinus with erosion of superior wall of the orbit as well as lamina preparation leading to compression of left eyeball, superior oblique and rectus muscles. Treatment endoscopic draft type 2A surgery was done. Endoscopic drainage of frontal sinus was done. Intraoperatively, there was breach of lamina papyraceae and floor of frontal sinus, frontal ostium widened up to lamina papyraceae. Approximately 30 to 40 ml purulent material drained. Frontal sinus mucopyrosil lining marsupialized. Post-operatively, vision improved, eye movement became normal. The term mucopyrosil was introduced by Rowlett in 1996, and the first histopathological description was made on ONOD in 1901. The exact mechanism underlying the development of a mucocele of the paranasal sinus is unknown. Most of the authors believe this cystic dilatation of the sinus to be secondary to obstruction of the nasal ostium as a result of recurrent bouts of inflammations, trauma, and or repeated surgery in and around the nasal cavity adjacent sinuses. It is very important to suspect post-traumatic obliteration of ostium, which eventually may lead to mucopyrosil formation as it happened in our case. Sites of occurrence of mucoceles are the frontal sinus, anterior ethmoidal sinus, maxillary sinus, and rarely the posterior ethmoidal sinuses. They may occur at any age, but most of them seen between the 4th and the 7th decades. Now, the conclusion: frontoethmoid mucoceles are benign and with good outcome if treated timely. Early recognition and management of paramount importance because they can cause local, orbital, and intracranial complications. The objective of the therapy is to remove the cyst completely and restore the drainage from the occluded sinus into the nostrils, irrespective of the approach either endoscopic or external or combined. Thank you so much.
Thank you so much. With this, the nose section. Now I would like to request Dr. Dr. Rakhi, are you ready?
Dr. Rakhi, are you ready?
Dr. Rakhi? Dr. Rakhi, are you ready?
Yes, ma'am.
Okay, your presentation has been displayed. Kindly start reading.
Yes, ma'am. Good evening, everyone. Myself, Dr. Rakhi Kaushik, PG second year student, Department of ENT, MGMMC, Indore. I'm presenting my e-poster on an interesting case of foreign body in bronchus, a case report. A foreign body is an endogenous or exogenous substance incongruous with the anatomy of the site where it is found. The goal of this poster is to present a case with different sites of foreign body lodgement as well as the challenges presented to the ENT surgeons by a variety of possible foreign bodies. A 3-year male came to MY hospital casualty with the complaint of fever and cough since 2 months. On examination, labored breathing and subcostal retractions were present. Patient vitals were stable. Diagnosis on chest, X-ray and abdomen, we found a metallic foreign body in the trachea and extending till left bronchus. On CT virtual bronchoscopy, we confirmed the site of foreign body and with the collapse consolidation of the entire left lung. Well-defined lobulated heterogeneously enhancing mass involving right, middle, and lower lobes. Management, video-assisted rigid bronchoscopy was performed under GA and foreign body iron nail was removed using optical forceps. This is the pre-op X-ray of the patient showing the nail in the trachea and left main bronchus. And this is the intra-op picture of the patient, which is showing the nail in the trachea. And this is the picture after removal of the iron nail. And this is the post-op picture of the patient after 2 days, which shows the improved air entry to the left lung. Discussion, the diagnosis of a solid foreign body can be difficult as the physical examination is generally not rewarding for patients with foreign body. The main diagnostic technique is the use of radiographs to localize the foreign body, and radiographic examination should be considered and offered in every patient, even asymptomatics. In literature, the right bronchus is the most affected. This is explained by the increased verticality of the right main bronchus, its largest diameter and greater airflow therethrough, and the location of the carina to the left of the tracheal midline, among others. I'm concluding my e-poster as this is an everyday situation that clearly reminds us the importance of a multidisciplinary approach to avoid delay in acknowledging the situation and providing treatment for a condition that may prove to be fatal. Optical forceps assisted rigid bronchoscopy is reliable in removing foreign bodies in the bronchus. Here are my references. Thank you.
Thank you so much, Dr. Rakhi. It was a great presentation. Dr. Aditya Goyal, are you ready? The next candidate is Dr. Aditya Goyal.
Ready.
Okay, I'm about to display your presentation. larynx है ना? तीन ही entry था ना? अच्छा. Okay, your presentation has been shared. Kindly start presenting.
Thank you. Good afternoon. Myself, Dr. Aditya. I'm presenting an e-poster on presentation and outcome of laryngotracheal trauma in our setup. So introduction: in any injury which is causing breach in the laryngeal framework and also involving the trachea, for which airways to be managed, is considered as a laryngotracheal trauma. It can be self-inflicted. It can be self-inflicted, assault, animal bite, road traffic accident, or due to any fall. It is a very rare cause of trauma, less than 1% of all the cases, and it is more prevalent in young males, mostly of the 24 to 36 years of age. My aim is to see the effect of prompt first-line management in salvaging the patient and to see the outcome of laryngeal repair along with tracheostomy in terms of voice gain. The clinical picture: in total, 15 patients were admitted in the ENT head and neck surgery department from January 2021 to June 2021 were considered. A first-line management like shock management, hypovolemic shock, oxygen saturation, followed by laryngeal repair and tracheostomy was done, and patients were followed up for a period of 6 months. Fiber optic laryngoscopy was performed in follow-up patient to see the vocal folds condition in laryngeal framework and voice. Management: examining the vitals and as airways was assessed, patients was vigorously managed, and prompt first line management and tracheostomy was done, followed by explorative layer by layer laryngeal repair. Keeping the laryngeal anatomy in mind, these are the photos showing the laryngeal repair. Step by step, first we'll intubate the patient, then we do the tracheostomy, then layer by layer followed by the laryngeal repair, we close the wound. Result and follow-up: 9 patients regained voice and 3 patients underwent subglottic stenosis or poor voice gain post decannulation of the tracheostomy tube, mainly patients with the thyroid cartilage injury or the glottic injury. 3 patients certified post-operatively due to the other complications like shock, poor lung compliance, and the respiratory distress. So my take-home message is quick and vigilant response in these cases is an important in salvaging the patient. Securing the airway and a good pulmonary reserve and prompt laryngeal repair serves as a very good prognostic factor. And in these cases, main thing is to look for the infections as it is to be avoided, keeping the compromised state of the patient in mind. Thank you so much. These are my references.
Thank you so much. Thank you so much, Dr. Aditya. Now, I would like to request Dr. Sanju to kindly be ready. Dr. Sanju, are you ready?
Yes, ma'am.
Okay, I'm displaying your presentation.
Okay, ma'am. Good evening, everyone. I, Dr. Sanju Surage, second year RSO of ENT Department of MGM and MIH Hospital, Indore. I am going to present my e-poster on a neglected, unusual foreign body in airway. Foreign body aspiration in children is common and usually present with the initial episodes of respiratory symptoms like cough, wheeze, and stridor with a decreased or abnormal breath sounds on examination. However, it can mimic other illness and causes difficulty in prognosis. Radiological investigations may help to confirm aspiration. Here we present a case of unusual neglected foreign body for days and discuss the appropriate management for foreign body aspiration. A 9-month-old male child presented to the pediatric department with a history of cough, which was sudden in onset since 4 days. He also had a history of fever since 4 days. The patient visited a nearby health center for these complaints, where he was given routine OPD treatment for cough, but the patient was not really following, which they reported to our tertiary health center, where X-ray, chest, AP and lateral was done as a routine investigation. A sharp radio-opaque shadow was visualized at the level of T5 to T7. The patient was immediately referred to the Department of ENT, where the history of foreign body ingestion was investigated, which was negative. Patient had an intercostal and subcostal retraction and maintaining SpO2 93% on a room air, with the air entry reduced on the left side on auscultation. A CT virtual bronchoscopy was done, in which a hypertense foreign body measuring approx 18 mm in length was visualized at the level of carina extending into the left main bronchus, with near collapse of left lower lobe. Patchy areas of air trapping was noted on the left lung, and patient was planned for the video assisted rigid bronchoscopy. LED bulb was visualized with a 0-degree pediatric telescope in the left main bronchus during the video assisted rigid bronchoscopy and was removed. After the procedure, the patient saturation improved and equal air entry on the both the sides, and intercostal and subcostal retraction was resolved, and cough was improved at the time of discharge. In the discussion part, foreign body aspiration by children, especially those below the age of 2 years, is common. Aspiration of foreign body is concern when a positive history of aspiration is obtained. Generally, with a negative history of patient was treated before the referral with antibiotics and bronchodilators. Factor which may delay the diagnosis include first parental negligence and misdiagnosis, lack of symptom, particularly after the acute initial phase of dyspnea, diverse clinical features due to aspiration of foreign body. The triad of wheezing and paroxysmal cough and decreased air entry is considered highly suggestive of foreign body aspiration. And finally, the conclusion: it is recommended that patients satisfying the following criteria should be subjected to diagnostic bronchoscopy. First, the history of definite or suspected foreign body aspiration. Second, features of foreign body aspiration is, for example, choking, wheezing, stridor, and paroxysmal cough. Third is recurrent chest infection with
Dr.
no.
Dr. Sanju, your time is up. Thank you so much. With this, we have concluded the e-poster session. I would like to thank all the chairpersons of this session. I would like to thank Dr. Pawan Kumar Sharma sir and Dr. Aditya Gargava sir and Dr. Izhar sir for chairing this session. Respected chairpersons, kindly forward the marks you have allotted to these candidates to Dr. Kavita Seva ma'am.
Thank you for having us here, and I would like to congratulate all the participants and the organizer for having such a great academic feast. Thank you.
So, students, we are coming to the end of this e-conference for which we were waiting for past 2 to 3 months. And I will really like to congratulate each and every participant as a chairperson, as a paper presenter, case series for putting his heart into this presentation. And it is very difficult to judge or give marks on a scientific paper. And you all know that basically it is a training part of a postgraduate course that a student observes, learns the methodology of research and writes papers. And this is all learning. And you are passing through this learning curve. So you all are winners in this conference. Judgment is only done for encouragement so that you improve more next time. Basically, we would, as a chairperson, we would have suggested you all that what improvement you can do, but constraint of time also prevents us from discussing all this. That was one of the reasons why questions were limited, or we were not permitting the questions because of time constraint. But I know you all are working under good great teachers who are guiding you. I am seeing that all the HODs are guiding the PGs. So I really basically would like to congratulate all HODs for producing such a good product with such a good, highly high quality of scientific research which I've seen today. Even the posters were good, case series were wonderful, and PG, the papers were good. And consultant paper, Dr. J.K. Sharma was हम लोग सबके teacher है, so he had better words. But for my students, all of you are our students, and I really would like to congratulate. But just to fulfill this part, that yes, what are the results? Because many of you would carry these certificates for you lifelong. So I am now announcing the results of Mahadevaya otological session, and in that we have first position Dr. Ankit Kumar Tiwari, GMC Bhopal. A lot of congratulations, Ankit. The second prize goes to...
Thank you so much, ma'am.
Yes, congratulations, Bache. Congratulations to you.
Thank you, ma'am.
The second prize goes to Manasa Krishna, Again, GMC. Congratulations. Yes, paper. So next time participate more with more heart. And the third prize goes to Dr. Samiksha Mishra, RD Gadi Medical College, Ujjain. Congratulations, Samakshi. Now there is one more third prize because there was a tie between two. So we are awarding it to second also. That is Anmol Patil from LN Medical College, Bhopal. Congratulations to you.
Thank
So
you,
now
ma'am.
in otologicals, well, it's so nice to see you all, bacho. Now the consolation prize we are giving to Riya Jain, that is from RD Gardi Medical College, Ujjain, which in spite of that inspection participated. And the second consolation prize again to Ujjain, that is Dhaval Bhojani. So otological section, I think we have awarded everyone because you all have worked hard. Now we are coming to Renuka Bradu rhinological session. So we have participants. The first, the winner of this session is Dr. Lakshmi Viraj. She is from Medical College, Jabalpur. Second is Dr. Steffi from NSCB Medical, Jabalpur. And third is Dipankar Chandra Kapurkar from NSCB Medical College, Jabalpur. There is a one consolation prize to Dr. Anjali for the rhinological session. Now we are coming to the head neck session. So in head neck session, we have first position is being bagged by Shobhit Yadav, Aurobindo Medical College. Congratulations, Shobhit. I think he is not there. The second prize is going to Dr. Krishna Valecha, MGMC Indore. And the third prize is going to Aditya Goyal, GMC Bhopal. So congratulations, Adit. And consolation prize is going to Surya Kant Sharma, RD Gadi Medical College. So this is what was paper presentation. We tried to recognize your work, boys and girls, and I am thankful that you participated. Now we are coming to the winner of case series. And the case series, there is tie. So first is Dr. Shireen Ansari from SAMES Indore. Congratulations. The second prize, first prize is again shared between Dr. Krishna, MGM Indore. This is
Thank
for
you, ma'am.
cases. Welcome. I thought Indore people have left. Congratulations, bacho. The second prize is again shared between two. That is Dr. Samiksha from RD Gadi Medical College, Ujjain, and Dr. Soumya Saini, NSCB Medical College, Jabalpur. And the third prize is going to Dr. Dhaval, RD Gadi Medical College, Ujjain. Now, quiz winners, you know who is the quiz winner. But just to repeat, the quiz winning team is GMC Bhopal with participants Dr. Mansa Krishna and Dr. Ankit Kumar Tiwari. The
Thank you so much,
second
ma'am.
prize.
Thank you so much.
Wow, that is great. Congratulations to your HOD. And the second is NSCB
Thank you.
Medical College, Dr. Steffi and Dr. Lakshmi. And the third prize of quiz has gone to SAMES Indore, Dr. Rishi Kumkar and Dr. Manan Jhawar. So congratulations. Now I would like to declare the results of e-poster. So I really appreciate students participating in e-poster because you have to participate, present a big data in a very concise form. So it is a very art to make a poster and to present a poster. So you all have passed through that stage, and I really would like to congratulate each and every presenter of poster. So in otology session, we have Dr. Deepak Mahavar from MGMC Indore as first, Dr. Abhishek GMC Bhopal is second, and there is tie between two, Dr. Aditya from Chirayu Medical College and Dr. Dipankar from NSCB Medical College. Now we are coming to the head neck session, and in head neck session, the topper is Dr. Farhan Alam, that is from Chirayu Medical College, Bhopal.
Thank you so much, ma'am.
Welcome, bachcho. The second is Dr. Anjali Krishnan, NSCB Medical Jabalpur. And third is Dr. Ankit Tiwari, GMC Bhopal.
Thank you
We
so much,
have
ma'am.
given. Bolo. What happened? You want to repeat? Ankit.
Thank you, ma'am. Thank you so much,
right.
ma'am. Thank you, ma'am.
Okay, nice to share this. Thanks. Now the consolation is going to Dr. Minakshi Ambulkar, as she was the only one of our series. It was a different case. So we have given a consolation to her. Now we have the last category left. That is rhinology and laryngology session. So students, to do a e-conference and to do a physical conference, you might be wondering why I went for a e-conference. So I would like to tell you one thing. जब फिजिकल कॉन्फ्रेंस होती है तो मैं अपने डिपार्टमेंट से 2 या 3 बच्चों को भेजूंगी, तो पूरी की पूरी टीम 12 लोग पार्टिसिपेट नहीं कर सकते हैं. So that was one of the thought which was behind it, that when you do a e-conference, we give opportunity equally to all students to participate. And this is, as I told you, a necessary part of our training, that every student should know how to make a poster, how to write a case series, how to present a paper. So this is a part of training, and equally everyone should get the responsibility. So that was our motto behind holding this e-conference, since now we have so much facility. And I got support from all the HODs, and they encourage their PGs to participate. So that is the spirit which we all HODs are sharing. And I really appreciate that this teaching motto should keep on rising, and we should be at par with any world universities. So keep on putting your heart and brain to your field and start excelling as high as you can. I am congratulating each and every one of you. We are waiting for rhinology result. They are just adding. और अपने मन में कुछ नहीं रखना, क्योंकि आज हम विनर और रनर अप की बात करते हैं. कल हम सब लोग बस इवेंट को याद रखेंगे कि यार ये क्विज कितना अच्छा था, उसका पेपर कितना अच्छा था, और ये आपकी एक बहुत अच्छी मेमोरी बन जाएगी. तो स्टूडेंट्स, कीप ऑल द पॉजिटिव थिंग्स विथ यू एंड टेक देम एज अ पॉजिटिव सोर्स फॉर ग्रोथ. So I am coming with the rhinological decision.
Just
so
like to say to
Madam.
Yes, Smita is there. Congratulations, madam.
I just want to congratulate you for this having this wonderful conference here. We all enjoyed a lot. You have given us such a beautiful platform for all the PGs to present themselves. I am very happy that my students, all of them, can present. In spite of doing all their duties, clinical duties, they can present all their whatever the presentation was there, and I am very happy.
Thank you, Smita. This is your support which I am getting. बहुत अच्छा लगता है, क्योंकि अपन सबका मोटो एक ही है कि हमारे पीजीज आगे बढ़े और सबको इक्वल अपॉर्चुनिटी मिले. बहुत अच्छा लग रहा है. थैंक यू फॉर काइंड वर्ड्स, स्मिता.
Ma'am, I would just like to add 2 lines if you allow.
Yes, बोलो. समीक्षा.
From on behalf of all of us PGs from RD Gardi.
आप थोड़ा सा लाउड बोलोगे बेटा.
Thank all of you a lot, and a very big thanks to our HOD for encouraging and guiding us all through.
HOD का नाम भी बोलो बेटा. HOD का नाम भी बोलो.
Dr. Sudhakar Vaidya sir, the backbone of our ENT family here in RD.
आप लोगों को थोड़ा सा एडजस्ट भी सुबह कराना पड़ा, बिकॉज सर वांटेड कि आप लोग अच्छे से प्रेजेंट करें, एंड आई विल रियली लाइक टू अप्रिशिएट दैट सर ने इन स्पाइट ऑफ ऑल ऑड आप लोग को प्रेजेंट करवाया. थैंक यू समीक्षा. क्या है बता कॉलेज के नाम. So students, I am having a tie again in rhinology, I am declaring the result of rhinology. So topper are first position. There are two. Ankita is from GMC Bhopal and Sanju from Indore. MGMC Indore.
Thank you so much, ma'am.
Congratulations, bachcho. The second prize goes to Dr. Rajendra from Sagar and Dr. Aditya Goyal from GMC Bhopal. And the third prize goes to Dr. Rakhi. She and Dr. Rakhi is from Indore and Dr. Soumya from Jabalpur. बाकी जिनको कोई प्राइज नहीं मिली है, प्लीज personally message me. I will really like to give a consolation prize for participation. And congratulations. Enjoy your Saturday evening and have a wonderful year ahead. Best wishes to exam going batches. We will keep on meeting annually. Thank you.
All the best to all the students.
Thank you, ma'am.
Thank you so much, ma'am.
Thank you, ma'am.
Thank you all.
कि जब हमने लास्ट टाइम ई कॉन्फ्रेंस की थी तो हमने लोकल ऑडियो वीडियो वाले को हायर किया था और उसके बाद हमने साल भर में डॉक्टर श्रीहर्षा को देखा एंड ही केम आउट ऑफ हिज ओन. हमने एक छोटी सी इवेंट की थी, उसमें डॉक्टर श्रीहर्षा ने हमें हेल्प की. Then I approached him and he provided me all the support for launching it on a YouTube and free conference, this our media Cisco WebEx. So my heartful thanks to Dr. Sriharsha, and I will really like him to unmute and interact with PGs for 5 minutes. Dr. Sriharsha, please, I know you are very shy, but I want you to give some message to PGs. You are there or not? और मयूर कॉल करिए. अभी इस बीच कोई कुछ बोलना चाहता है तो बोल सकता है. बोले सर प्लीज लॉग इन हो बच्चों के लिए. सो स्टूडेंट्स बकअप, एंजॉय, खेलो कूदो, मस्ती करो और अपने प्रोफेशन को एंजॉय करो.
मेरा मैडम बस यही बोलना, कोई भी कॉलेज का कोई भी स्टूडेंट हो, मैं बस यही बोलना चाहूंगी, दिस इज जैसे आपने बोला कि सेम थिंग इज दैट दिस इज अ पार्ट ऑफ अ लर्निंग प्रोसेस. अभी ये तो स्टार्टिंग है, पोस्टर से प्रेजेंट करके आपको कहाँ कहाँ नेशनल इंटरनेशनल प्रेजेंट करना है, तो पार्टिसिपेशन इज वेरी इंपॉर्टेंट. प्राइज मिलना नहीं मिलना डिफरेंट चीज है. और अभी तो खैर ये किया है, अब दे हैव टू स्टार्ट स्टडिंग फॉर देयर एग्जाम्स. इतना अच्छा यहाँ किया है, आई होप कि ये सारे के सारे जितने स्टूडेंट्स हैं हमारे, जितने भी मेडिकल कॉलेजेस के हैं, वो सारे के सारे एग्जाम में भी उतना ही अच्छा करें. और बिग थैंक यू मैम, बिकॉज ऑफ यू थोड़ा सा कानों में इनके स्टिमुलस आता है, बड़ा एक्साइटमेंट आता है, कुछ चेंज लगता है लाइफ में स्टूडेंट कुछ करने के लिए, तो उन्होंने किया एंड ऑल द स्टूडेंट्स हैव पार्टिसिपेटेड वेरी नाइसली.
Thank you, Dr. Smita. Dr. Sriharsha is at least they catch up with you, they follow you, they run behind you, and they will reach somewhere.
Thank you, ma'am. Even though I was with my clinic, I was following all the presentations briefly, and most of the students have really done well. Only thing is we actually have done previously other conferences also. So most of the students usually they just read the presentations. So I hope next time when you prepare your presentations, don't just read the presentations. Whenever you are presenting a topic, the judge should feel that you have thoroughly prepared and you came well prepared. It's not just you just read the presentation. So this will actually fetch you good marks in the upcoming conferences. That's all. Of course, we are all not perfect. We are all learning. So all the best for all the postgraduates.
Thank you for kind words. Means homework should be done and rehearsal should be done.
Yes.
Mock drill should be done. Huh? And I would personally like to thank you for supporting this event, which went all well and smooth with your guidance. Thank you, and I hope you will keep on.
Ma'am, I would like to say some words.
Right, Dr. Sanjay Agrawal, बताइए.
E-poster, definitely all presentations were excellent, but definitely I would like to say some corrections for the new PGs, that it should never be a theoretical presentation like it's not a novel. Always have a pointing presentation that yes, there is otorrhea. Don't write there was an otorrhea like this. Number one, limited presentation. That's very important for you in a learning phase. Second thing, I would like to say that this is definitely a conference where you have a stage presentation. You develop a stage daring. This is one thing you learn. It's not winning or losing what you told, but also, as my experience tells me, that they should learn. They are ENT surgeons now. They should learn and develop this surgical skill labs, ma'am, which I am very much interested, and I would like to emphasize myself as a proud PG when I was, that I was the first PG to do temporal bone dissection in GMC Nagpur with the first lab I established as a PG. And I think I was the last, unfortunately. And that is a bad sign of it, what I want to say. So all PGs needs to be enthusiastic in surgical skill labs, which we teachers need to encourage them to develop, ma'am. And I wish all the students all the best and all the hearty congratulations to your team, ma'am. Thank you, ma'am, for allowing me.
Sir, what you told, we can next time, whenever these PGs are passing through the poster and all, we all can jointly guide them because they are unguided, they are learning on their own, and we finally don't have time even to see their presentation end time when they are done. So we can always improve them, and every day is a new start. So we hope that we'll do this. Thank you all for a hectic day. Bye. We close the ceremony. Thank you all. Thank you.
Thank you.
इसको डाल लिखो लिखो पेपर लिख दिया ये भी लिखो पेपर्स ये सब चेयरपर्सन बनाने काम आएंगे चलो थैंक यू टीम आज जाकर सुनना नहीं सोचना कि क्या क्या इम्प्रूवमेंट कर सकते हैं इसे क्या बोलते हैं